Doctor, I think it's here. It's live YouTube already.
Okay, good. I will share with you the link now so you can share it with everyone, okay?
Okay, doctor.
Just 1 second.
Doctor,
Yes.
I think it's here. It's live YouTube already.
Yes. Okay, good. I will share with you the link now so you can share it with everyone. Do you see my screen now, Danny?
Yes, doctor. Clear from here, doctor.
Okay. Now, Lani, I think you received my email.
Right. I have already, doctor.
Yes, please. So now can you send it as invitation to all registered people? As you can add the YouTube link to the registration. So you can say this is alternative if you cannot access the webinar. You can use the YouTube.
Okay. Hold on.
Thank you. السلام عليكم، حياك الله دكتور بدر ودكتور أحمد، حياكم الله جميعا.
حياك الله يا دكتور خالد.
لين كيف حالك دكتور أحمد؟
الحمد لله تمام تمام، الحمد لله يا دكتور.
السلام عليكم، صباح الخير يا شباب، الله يعطيكم العافية.
سلام ورحمة الله.
بالخير يا
صباح
دكتور.
النور. حياك الله. كيف أموركم دكتور بدر؟
حياك الله أبو وليد، كيف حالك؟ كيف صحتك؟
الحمد لله بخير الله يبقيك. معليش مصحينك في الويكند بدري.
لا أبد، الله يعطيك العافية، مناوب أصلا.
يعانك الله عجل.
الله يعطيكم
يعانك
العافية،
الله.
جزاكم الله خير.
الله يبقيك. في دكتور بدر بس يعني في نهاية السيشن يعني في معنا اللي هو after 55 minutes بيكون في 5 minutes for question. ممكن حتشوفها في الكيو ان اي section. إذا
تمام
ما كان في we will move to the next one إن شاء
تمام
الله.
تمام، ممتاز، بحول الله وقوته.
إن شاء الله الله يعطيك العافية. بس 3 دقائق ونبدأ بإذن الله.
بإذن واحد أحد، بإذن الله. واضحة الصورة دكتور خالد؟
واضحة. الله يعطيك العافية. دكتور بدر بس إذا تسمح لي ممكن نعمل
تسلم.
الشير بعد ما نسوي introduction
طيب طيب،
ولا
أبشر.
it is clear. الله يعافيك.
أوكي.
السلام عليكم وصباح الخير جميعا حياكم الله. I would like to welcome you all to our dialysis course, which is the Ministry of Health dialysis course for the second year. It's our pleasure to have you here today with us. We have a group of eminent speakers who are going to cover different topics of dialysis and giving us the update in each topic. At the beginning, I would like to thank the Saudi Society of Internal Medicine for their organization. Also, I would like to thank Fresenius company for their sponsorship and Spimaco الدوائية. Also, this course is CME accredited, and anyone who attended today, inshallah, will receive the CME since we have your information. Each session will have 55 minutes of presentation and then 5 minutes at the end for questions. You can leave them at the Q&A part, inshallah. At 12, we will have a break for 30 minutes, then we will have to resume because we have limited time, and inshallah we will finish within the scheduled time. And we will be happy to receive any comment from you through the chat, please. It's my pleasure to introduce our first speaker, Dr. Badr Al-Hamid. Dr. Badr, he's a consultant nephrologist and transplant nephrologist at King Fahd Hospital, Medina Munawwara. Also, he is the head of nephrology department at King Fahd Hospital, Al-Medina, and the director of King Abdulaziz Dialysis Center at King Fahd Hospital. Dr. Badr will talk about introduction to dialysis. Dr. Badr, the mic is yours.
Thank you very much, Dr. Khalid. Thank you for asking me to participate in this important meeting. And thank you for this introduction. طيب. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد عليه أفضل الصلاة وأتم التسليم. Inshallah, within the next 55 minutes, we are going to go over certain things, certain topics in the field of dialysis, and we are going to cover certain areas looking at the epidemiology of end-stage kidney disease in the kingdom. What are the consequences of developing end-stage kidney disease? And then we're gonna touch base on the treatment options for end-stage kidney disease and the importance of preparing our patient for dialysis. And then touch base on timing to initiate dialysis and having some idea also about what are the goal-directed dialysis cares. Yes,
can you make it full screen, Allah Yafik?
Okay. Is it clear now, Dr. Khalid?
ايه واضح، بس اذا ممكن نخلي السلايد فول سكرين. هي واضحة
الآن هي فول سكرين معايا أنا.
اوكي طب it is fine, we can proceed then.
Actually, as you know, end-stage kidney disease does cause significant morbidity and mortality. And as you know, that the cost of renal replacement therapy are very high and represent a great social burden. And the reason behind that is probably related to the evolving healthcare environment. We do have an ongoing and growing elderly populations, and the new technologies used in dialysis, in addition to the increment in the population worldwide. And as you can notice, also the economic constraints which is happening globally. As you can see in this paragraph, that the current number of end-stage kidney disease in the kingdom.
باش دكتور بدر نعتذر منك، يبدو في مشكلة في السلايد. It's not moving.
I'm trying to stop share again. ما أعرف إذا وضحت الآن دكتور خالد.
واضحة نعم السلايد الآن. So can you move it?
Moving?
لا، ما أنا بالنسبة لي ما تتحرك السلايد. ما أدري باقي الزملاء هل تتحرك عندكم السلايد؟ واضحة؟ إيه الآن تتحرك. نعم
الآن واضحة؟
إيه الآن واضحة تمام.
Okay. طيب. So as you can see in this paragraph, the current number of dialysis patients or end-stage kidney disease by 2020, they were touching around 30,000 patients, and the expectation that we are going to touch around 44,000 if there is no effort done to decrease the number of these patients. And we hope that this number will get less to around 38,000 if some strategic plans are done to decrease this number. Currently, there are more than 275 dialysis centers in the kingdom, as you can see in this slide. And the number of the dialysis patients is actually growing gradually or incrementing throughout the years. And if you look at the last 5 years, we are recording more than 4,000 incident dialysis patients throughout the kingdom. Actually, 56% of our dialysis or hemodialysis patients are male, and around 44% are female. And out of the total number of hemodialysis patients, we do have more than 83% of our patients are Saudis. This slide will show you the different providers who are delivering hemodialysis in the kingdom. And as you can see that around 75% of the providers are MOH, whether they are MOH completely or it is the outsourced program, and that represent around 75% of those who are delivering the service. Again, looking at the number of dialysis patients in MOH and non-MOH sectors, that's again around 65% of the patients are delivered through the MOH, and around 35% are delivered through non-MOH patients, non-MOH sectors. And in these slides, you can see the dialysis centers which are distributed in the whole kingdom in the different regions with variable number and variable distributions. What about PD? The PD is also growing up, and by the end of 2022, of 2021, we are having almost around 1,900 patients who are doing peritoneal dialysis. And the PD centers, as you can see, also are distributed throughout the kingdom with variable number, variable percentage to the total patients. What you can see in this global map, that the incidence of end-stage kidney disease in different countries and different regions. And if you look carefully here in Saudis, they are around 100 to 200 incident dialysis patient per million. And you can see these are the different recording throughout the globe and with variable number per million populations. Again, as you can see, in Saudi Arabia, we are around in the top 20 countries who are reporting incident in the stage renal disease, and we are reporting around, as we said, 100 to 200 new patient or incident patient per million population. The prevalence of end-stage kidney disease in the kingdom is around 800 per million population, according to the USRDS annual report. So what you are seeing right now is just like the tip of the iceberg. And we know how much people are on dialysis, but the problem that we don't know how many people or how much people are having the chronic kidney disease. And this is not recorded, unfortunately, and nobody knows how much of them they are running in the society. What's the problem of this? This chronic kidney disease are representing a huge burden to the healthcare system. I will show you, this is our data in King Abdulaziz centers. We were just recording how much chronic kidney disease patients get hospitalized because of their chronic kidney disease problem or the associated problem with their chronic kidney disease. That was recorded between January to December 2022. And what we have noticed that around 31% of our chronic kidney disease, they get admitted because of cardiac disorders, and around 20% of them, they get admitted because of volume overload issues, and around 16% of them, they get admitted because of infectious complication, including pneumonia, urinary tract infection, and diabetic foot, and these things. And around 6% they get because of GI problems, 4% because of their hematological presentation, and so on. So this is considered as a huge burden on any healthcare system. So what are the reasons for the increasing number of end-stage kidney disease? We believe that the reason for increasing this, as you know, is to increase the awareness of the disease. There is a huge improvement or marked improvement in the healthcare system. As you know, the population is increasing. We do have a huge prevalence of diabetes in the kingdom, and we believe that there are cases or good number of cases who are having missed or neglected glomerular disease. According to Scott data, these are the most common reason for end-stage kidney disease in the kingdom, and diabetes is representing around 42% of the causes, 34% is related to hypertension, and then you will have the unknown cause, which represent around 7%, and the remaining causes including glomerulonephritis, hereditary disorder, obstructive uropathy, congenital malformation, vasculitis, pregnancy related with a variable percentage. So we can do some improvement in the modifiable risk factor for end-stage kidney disease, which is diabetes, hypertension, use of non-steroidal anti-inflammatory drugs or the obstructive causes, and the obesity. These are the modifiable risk factors which need to tackle. There are other non-modifiable risk factors for the progression of end-stage kidney disease, which is including family history, older age, hereditary disorders, and so on. See, these are the non-modifiable, and we need really to focus mainly on the modifiable risk factors so we can prevent the progression of this disease or the reporting of this disease. So what's next? There are consequences of developing end-stage kidney disease, as you can see in this slides, and these consequences constitute a mortality, increasing mortality, cardiac problem, economical stretch, the effect of frequent hospitalization and rehospitalization, infection, fracture, the burden on the caregiver who are taking care of the dialysis patients. What about mortality in end-stage renal disease? According to the IHME, which is the Institute for Health Metrics and Evaluations, here in the Kingdom, with the CDC reporting, chronic kidney disease represents one of the top 10 causes of death, and it's coming in number 4 as the main cause of death for the Saudi population, and it's coming after ischemic heart disease, after road injuries, and after stroke. Chronic kidney disease come as a number 4 cause for death in the Saudi populations. And as you see in the end-stage renal, as you see in this slide, that most common cause mortality in the hemodialysis patients is really related to the cardiovascular complication, and that represent around 50% of patients. They do die because of a cardiac, because of cardiac problems, whether it is arrhythmia, ischemic heart disease, acute coronary syndrome, or congestive heart failure. And actually, most of the deaths of end-stage renal disease who are in hemodialysis does happen on Mondays or Tuesday after a prolonged weekend. For those patients who are on conventional hemodialysis, and I'm sure if you look at your dialysis centers, you will find that most of the problem for the dialysis populations come on because we are dialyzing our patient on Saturday, Monday, or Wednesday, or Sunday, Tuesday. So you'll find most of the problem happen on Saturday and Sunday. And I hope that you will look keep an eye on that, because most of the problem will happen within these 2 days after prolonged weekends. And the causes of death also for the peritoneal dialysis is mainly related to cardiac consequences or the cardiac problems, and looking mainly at acute coronary syndrome, congestive heart failure, arrhythmia, and so on. What about hospitalization? Again, we looked in our centers about what are the main causes of hospitalization in our dialysis population, and we found that 46% of our admission is access related. What I mean by access related, thrombosed fistula, line sepsis, non-functioning permacath, creation of an access, and that represent around 46% of our patients, they get admitted because of access problem, and around 30% they get admitted because of cardiac problems, and the remaining are with a very variable reason, including pulmonary, surgical, fractures. So around, if you look carefully, that we have a huge number of patients, they get hospitalized because of the dialysis itself or because of the complication of dialysis. And this is again applied for the peritoneal dialysis. Again, we have around 35% of our dialysis patient or peritoneal dialysis, they get admitted for access issue, creation, repositioning, and so on, non-functioning, and around 30% of them, they get admitted because of cardiac complication related to end-stage renal disease. What about the cardiac risk? What about the cardiac risk? I have shown you in the previous slides that cardiac risk or cardiac complications are the main cause of deaths in dialysis population. And as you can see in this slide, there is a strong association between the cardiovascular diseases and chronic kidney disease, and each one of them predisposed to the other. So if the patient does have a cardiac problem, that will predispose him for developing renal problem or vascular problem, and vice versa. If the patient does have a chronic kidney disease, he's high risk for developing cardiovascular complications. And we believe that is related to the inflammatory process which is happening in the dialysis population because of the calcification, because of the uremic toxins, and because of the calcification, because of the dyslipidemia, which is our predisposing factor for developing cardiac complication. Around 20%, as I showed you earlier, of mortality of end-stage kidney disease patient is attributed to coronary artery disease. And many dialysis patients have more than one traditional risk factor, which is resulting in even higher risk of adverse outcome. And patients who have both diabetes and hypertension does have a 5 to 6-fold increase in the risk of developing heart disease compared to those without history of either condition. Indeed, as you can see in this slide, the cardiac mortality in the general population and in patients compared to those who are end-stage renal disease, and even younger population in the age of 25 to 34 year old, they have 500 to 1,000 fold increased risk of developing cardiac complications or cardiac problems compared to even those who are older than them. So even if you have dialysis problems or end-stage renal disease at younger age, you will have high risk of developing cardiac complications compared to the general population, and that high risk increase up to 500 to 1,000 fold increment. And this huge number and this huge increase actually in the mortality when you compare it to the different stages of chronic kidney disease, those patients who are end-stage renal disease on hemodialysis, they have around 50% risk of having sudden cardiac death compared to those who are not yet on dialysis with variable degree of GFR. What about infection? Infection which is happening in the dialysis unit, and that's probably maybe related to the process of hemodialysis with the catheter-related bacteremia, infective endocarditis, metastatic septic emboli, AV fistula or AV graft infection, dialysate water-related infection, or the infectious problem happening between the patients like hepatitis B, hepatitis C, MRSA, or the respiratory infection like COVID, tuberculosis, influenza, and pneumococcal. What about the risk of fracture? We know that the fracture risk increase in our dialysis population, and bone fractures are important outcome in adults with chronic kidney disease. They can result in a huge morbidity and mortality and economic cost. The bone changes which occur in the chronic kidney disease patient increase their fracture risk, and many individuals with chronic kidney disease are frail to bone, and they are subjected for falling, which predispose them to suffer from fracture. Different fractures does happen to the CKD and end-stage renal disease patients, and forearm fracture represent the most common fracture for chronic kidney disease stage 2. Then you will have the hip fracture, which is the most common fracture from stage 3 to stage 5. What about the economical impact of end-stage kidney disease on the community? As you know, the healthcare cost for one person needing dialysis that constitute around $150 thousand to 200,000 real, and the annual global dialysis costs exceed million and trillion over the years. And that, even when you look at that carefully, that does not even take into account the healthcare costs for people who still have some kidney function but require treatment for heart disease and other health problems, which are getting worse by the kidney problems. So developing a dialysis is a huge burden on any healthcare system. What about the effect of dialysis on the caregivers? And this is usually one of the aspects which we usually forget to look at that carefully, because even before end-stage disease is reached and the renal function deteriorate, patients more frequently need additional support, and it is often family members are the one who are providing this. And the studies have shown that good family support is associated with successful adaptation to dialysis and compliance with dietary restriction. And one of the main factors associated with patient discontinuing dialysis is patient perception that they have become a burden to the family. And actually, both hemodialysis and peritoneal dialysis may have a disruptive influence on the family member social life, and the structure of the week may be geared toward dialysis session. And some of the patients, they become frail and they become very dependent on the family member. And actually, you will be surprised that even this family member have some health and social needs, and that need to be addressed. And most of the time, we don't look at that carefully. So what are the, again, just go back to find out what are the treatment options for end-stage kidney disease. As you know, that once the patient develops end-stage kidney disease or he reached chronic kidney disease stage 4, stage 5, discussion with him about the prognosis and the prolonged outcome, certain discussion should be focused on the treatment options, which is including hemodialysis, peritoneal dialysis, or kidney transplantation. And actually, this can happen vice versa, that any who start hemodialysis can go to peritoneal dialysis, or peritoneal dialysis, he can be shifted to hemodialysis, or even those who receive kidney transplantation, if their kidney doesn't work, he can go back to either one of them if needed. So the dialysis options, as I said, it's either hemodialysis or peritoneal dialysis. And when we talk about hemodialysis, we are talking about the conventional in-center hemodialysis or the home hemodialysis with the short daily or nocturnal. And when you talk about peritoneal dialysis, we talk about the manual, which is the the manual CAPD, or the cycler, which is the CCPD or in IPD, and we will describe that in the next few slides. So what about hemodialysis? As you know, hemodialysis, it's the process of cleaning the blood, where the blood enter through the system to the through the dialyzer, where the blood will move from the toxins will move from the area of high concentration to the low concentration to get cleaned and returned back to the blood. And that is usually happen through an AV fistula or through a catheter, which is inserted to the patients. So what are the process? The process of dialysis will be how there are certain principles for dialysis, and there are certain principles related for solute removal or water removal. And the process include the principle for solute removal include diffusion, convection, and for the water removal, the main principles are considered as ultrafiltration or osmosis. The process of diffusion, which is the movement of solute through a semi-permeable membrane from one side to the other based on the concentration gradient. And this process will be affected by the molecular weight of the solute, the size and the distribution of the pore, the temperature on both sides from the dialysate and from the blood, the membrane thickness, the resistance, and the membrane surface area and the concentration gradient. These are the main thing which does affect the diffusion process. What about the convection, which is the bulk flow of solute across a semi-impermeable membrane together with a solvent? This is a process, we call it solvent drag, in a manner that is dependent on the transmembrane pressure and membrane characteristic. What is ultrafiltration? It is the process of fluid removal using the dialysis membrane. The pressure on the dialysate usually is lower than that on the blood side, which does have the higher pressure. So the process of movement of the fluid using the dialysis membrane, it is called ultrafiltration, and that is the it goes from the higher area to the lower area. And this process of ultrafiltration is affected by the transmembrane pressure and the ultrafiltration pressure. Osmosis, which is one of the steps or one of the basic principles for removing fluid. And it is the process where excess fluid moves passively from the blood to the dialysate through a semi-permeable membrane. So what are the difference between different dialysis options or hemodialysis options? In-center hemodialysis does have some advantage or disadvantage. The advantage is that the trained staff perform all the aspects of the treatment. Since there are other people are dialyzing at the same times, there will be a chance for more friendship and having a new friendship in the unit. The disadvantage that the treatment day and times are scheduled by the centers. You must travel to the center at least 3 times weekly. Other people are doing dialysis at the same time, so you might have less privacy. And in-center hemodialysis does cause exhausting the blood vessel, and usually there is faster loss of residual urine output, risk of infection in in-center hemodialysis, whether this is an access or airborne or blood. And sometimes there will be some of the center, they apply a certain rule against eating and drinking while on dialysis. What about home hemodialysis? Again, there are also advantages and disadvantages. Advantages include that studies have shown that having dialysis at least 5 to 7 times a week have dramatically better outcome in every way, including longer life and better survival. You and your dialysis partner learn to do the treatment without the in-center staff. Dialysis is done in the comfort of your own home. There is no need to travel to the dialysis center. There will be more flexibility to choose convenient time to do the dialysis, and a greater sense of control from being independent and doing treatment yourself. What about the disadvantage? That you and your dialysis partner must take time off from work on regular routine to attend the training. Space in the home need to be adjusted to have a place for the machine, water system, and if needed, or and supplies. Special electricity and plumbing may be needed, and there are no medical professionals at home to monitor the treatment or to answer immediate question, although you can call the centers at any time and go to the center periodically to be checked. What about peritoneal dialysis? Peritoneal dialysis, it's the process of where we use the peritoneal cavity, and we're using the peritoneal membrane to work as a membrane for the dialysis itself. The fluids will go in the tummy through a catheter, which is inserted in the peritoneal cavity. It leave it for some time, which is, we call it a dwell. Then we start to drain it after that, and to be drained in the draining bag. So the abdominal cavity is lined by a vascular peritoneal membrane, which acts as a semi-permeable membrane. Diffusion of solutes, urea or creatinine, and so on, will go from the blood into the dialysate contained in the abdominal cavity. a removal of excess water, which is the ultrafiltration due to osmotic gradient generated by the glucose, which is used as a dialysate solutions. What are the type of peritoneal dialysis? We have the continuous peritoneal dialysis, and we do have the intermittent peritoneal dialysis. The continuous PD regime, which is a multiple sequential exchange, are performed during the day and night. So the dialysis occur 24 hours a day, 7 days a week. This is the CAPD, we call it continuous ambulatory peritoneal dialysis, or the continuous cyclic peritoneal dialysis. The intermittent PD regime is performed every day, but during certain hours. We have the daytime ambulatory peritoneal dialysis, which is having multiple manual exchange during the working hours. Or they have the nocturnal peritoneal dialysis, where the patient perform his dialysis while asleep using an automated cycler machine. Sometimes 1 or 2 times manual exchanges are added to enhance the solute clearance. What are the advantage and disadvantage of peritoneal dialysis? The advantage that studies have shown that PD patients, we believe some of PD patients, they do live longer, more mobile, it's more mobile and more flexible. Peritoneal dialysis preserve residual urine output. It's more friendly with the patient. He can travel, he can take his machine with him, he can take his solution with him, and he doesn't need or she doesn't need to find a place to get dialysis. If she get traveled, may have a fewer fluid and diet restriction. Peritoneal dialysis patient have this advantage. It does preserve the vessels for the future hemodialysis if needed, and we believe that peritoneal dialysis have a good bridge for kidney transplantation. The disadvantage of peritoneal dialysis is the catheter may affect the body image. It's also a potential for weight gain because of the glucose, which is used as a dialysate solutions, and it is done every day. Risk of catheter-related infection, and the storage space which is required at home for fluids and supply. So which is better, BD or hemodialysis? And this is a long debate actually, but we believe that in the first 5 years, well, usually peritoneal dialysis, they do better compared to the hemodialysis patients. And after 5 years, usually the hemodialysis patient, they do better. And we believe that multiple factors lead to this. And we believe the main issue is the preservation of the residual renal function. So after all what I have shown you and we have discussed, we need really to prepare our patient for dialysis. And according to the KDIGO guidelines or KDIGO guidelines, we need to refer the patient early to the nephrologist, especially when their GFR is less than 30 ml per minute. And the education about the type of renal replacement therapy, whether hemodialysis or peritoneal dialysis or kidney transplantation, should be done earlier, and we don't wait for the last minute. And the discussion for the kidney transplantation will need to be done when the GFR is less than 20 ml per minute, and that you need to discuss with the patient whether they have a living kidney transplant, and you need to build the time to put the patient on the list. And that will give you a time even to transplant patient before they start dialysis, what we call it preemptive kidney transplantation. It's important, one of the most important issues that you need also to inform your patient that no PICC lines, especially when you are for your patients, especially when their GFR go below 45 or 40 ml per minute, and they should not use their hand for PICC line insertion unless that's medically indicated. Otherwise, no blood sampling, no PICC line. You should stop doing that for patient to prepare them for dialysis or hemodialysis in the future if they decide about that. What is the advantage of timely referral of the patient? That will help in improving patient preparedness for renal replacement therapy. You will have a chance greater use for permanent vascular access instead of creating a temporary catheter or a permacath. You will have a time to insert an AV fistula or AV graft or creating a PD catheter. and then you will avoid an emergent hemodialysis initiation, and the patient will have a greater utilization of transplantation and self-care dialysis, and you will be having time for management of his medication or her medication, and that will help in delaying the need for renal replacement therapy, giving the nephrologist adequate time to counsel a patient through its challenging transition in their lives. What are also the advantages of timely referral? You will have protocol for laboratory and clinic visits, which with attention on chronic kidney disease and cardiovascular associated morbidities and comorbidities, and you will be able to control these associations, and you will be able to prevent the consequences. You will have time for ethical, psychological, and social care. You will be having time for dietary counseling and education on the lifestyle modifications, and you can start your vaccination program for the dialysis patients. So speaking about patient right to choose and have time to decide what modality to start with, this study, which was done in USA and Canada, when they looked about, they tried to see how much patients are interested in doing home dialysis or peritoneal dialysis, or who is making these decisions. And when they were asked, they found that around 45% of patients, they will be they will like more doing a home type of treatment, whether a home hemodialysis or PD. And when they look at that in Canada, they found around 47% of the participants will like to do more of a home type of treatment. And when nephrologists were asked what type of dialysis they will choose, most of the nephrologists, they will choose, and actually there's another study, they try to find out what the nephrologist will like if their kidney failed and they still have times to go for kidney transplantation. What they found that most of the nephrologists, they will be more with a home type of treatment or home type of dialysis, whether this is a nocturnal hemodialysis or nocturnal in-center dialysis or the peritoneal dialysis. So they will choose more of a home type of treatment. On the other way around, and according to this survey, which happened in between 2004 and 2018, most of the nephrologists, they admit that the predominant therapy used in their centers actually were in-center hemodialysis or peritoneal dialysis, and less use of home type of treatment or the home hemodialysis. And the utilization of dialysis therapy other than standard hemodialysis is usually dependent on the training and the experience. So this tells you that we are affecting and we are influencing the decision of our patients. And what I can tell you, look at this again, this another studies which looked at if the effect of education of the patients in making decision for what type of treatment they will like. And this is when they enrolled around 70 patients were randomized to receive either standard care alone or standard care with educational intervention. And when they give the educational intervention, which is more education about the different type of treatment, different type of therapy, home type of treatment, 64% of those who get participated, they were more interested on home type of treatment, whether this is a home hemodialysis or peritoneal dialysis. And what is found also that there will be, in another way, studies that patients receiving peritoneal dialysis were 1.5 times more likely to rate that their care is excellent than those using the in-center hemodialysis, and patient and caregiver perceive that home hemodialysis offer them the opportunity to thrive, improve freedom, flexibility, and well-being, and they're strengthening their relationship. And again, looking at our influence on making the decision, this is the study where they looked at who make the decision for the type of treatment the patient is receiving, and most of the centers they found that physicians, especially for the hemodialysis, you will find that the physicians are the one who are making the decisions compared to the peritoneal dialysis, which most of the time the patient does do that. But for the hemodialysis, you will find that the physician is the one who is making that decisions. And when the nurses who are taking care of the dialysis patients were asked who are making that decision for the patient for the type of treatment in a survey, around 47% of the nurses, they said that physicians are the one who are making the decisions for the type of treatment. So that's all of this tells you that really patient should be involved more in making decisions, and the physician should not be the one who is making these decisions, because that will affect the patient life, will affect their caregiver. So we need to spend time with the patient to decide what type of treatment, and at the same time we need to have an early referral for the nephrologist to have a good enough time to discuss all the options of treatments so they can make these decisions. What are the consequences of late referral to the nephrologist? Again, you will have more problem with the anemia, more problem with control of hypertension, more problem with dialysis access, delayed referral for the transplantation, higher hospitalization rate, increasing the 1-year mortality, and decrease the patient right to choose what type of treatment suit them. So when to initiate dialysis? Actually, the timing for initiate dialysis is an important factor, but there are certain and absolute indication for the renal replacement therapy, and this include hyperkalemia, which is resistant to treatment, metabolic acidosis, which is resistant to treatment, fluid overload and recurrent congestive heart failure admission, uremic pericarditis. Sometimes you need to start the patient, and that's also absolute indication when they start to have persistent anorexia, nausea, impaired nutritional status, sleep disturbance, decreased energy level, or a change in their cognitive function. So these are absolute indications for renal replacement therapy. But when to initiate dialysis, and this is the famous study, which is called the IDEAL study. And actually, this is a study which changed a lot of practice in globally. And this was done between 2000 and 2008, where they looked at whether there is a difference in the outcome or time of death between early start, which is when the GFR of the patient is 10 to 14 ml per minute, or late start with which is 5 to 7 ml per minute. And the mean age for those who contributed in this study was around 60 years, and 2/3 of the patients were male and 1/3 were female, and around 350 of patients were diabetic, and they followed up these patients for around 4 years, 5 years, and what they found, there are no difference in the in the outcome or mortality between early start or late start for dialysis. And what they found that around total of 75% of patients in the late start group, they started the dialysis when GFR was around 7 ml, owing to the development of the symptom. This is what they claim. And in this study, early initiation of dialysis patient with stage 5 CKD was not associated with improvement in the survival or clinical outcome. So the conclusion was, it's okay to delay the initiation of dialysis until the GFR is less than 7 to 10 ml per minute. And the dialysis initiation should be based upon clinical factors, symptoms, rather than GFR alone. And if you look at the different guidelines, different recommendations, if you look at the National Kidney Foundation, the Canadian Society of Nephrology, the European Best Practice, and the KDOQI guidelines, most of these recommendations now talk about initiating dialysis if the GFR is less than 7 ml per minute, or if the patient is really having symptomatic reason for initiating dialysis, and there is no need to an early start, because that will not affect the prognosis in general, and that will not have any consequences on survival. So I will conclude with a potential target for goal-directed care for the goal-directed dialysis care. And what I want to say that there are targets which is directly related to the dialysis treatment and dialysis unit care, and there are targets which is not directly related to the dialysis treatment or dialysis unit care, and that actually these two targets, or these targets, are coming in between these two things. So you need really, when you are dealing with a dialysis patient, to focus on their symptoms: fatigue, nausea, cramps, pains. These are one of the targets which you need to focus in and try to find solutions for that. Control their fluid intake. Make sure that you remove the solute, toxins. Make sure that you have a good control in their electrolyte. Make sure that you focus on their associated comorbidities. Make sure that you focus on their phosphate levels, protein intake, blood pressure management, anemia, their sodium intake. They make sure that you control their medications and make sure that they are adherent to the medication. Evaluate their cognitive function. Discuss with them their depression, their anxiety. Found out what is their treatment burden and volume status, assess their volume status, and more of these talks will, my colleagues, they will talk to you about all of these things in the next few presentation, inshallah. So in conclusion, end-stage kidney disease continue to be one of the major health problems that need a lot of attention. There is enough evidence that the prevalence and the incidence of end-stage kidney disease in Saudi Arabia is increasing and showed rapid rise over the last 3 decades. Change in our lifestyle, high population growth, fast increase in life expectancy have contributed to the changes in the chronic kidney disease pattern. Diabetes and hypertension are the 2 main causes of end-stage kidney disease in Saudi Arabia. Complications and comorbidities associated with chronic kidney disease, end-stage kidney disease patients are more common and more severe. Most of our patients, they do die because of cardiovascular related complications. Our CKD, end-stage kidney disease patients, are at higher risk of hospitalization for different reasons as compared to their age-matched population. The cost of renal replacement therapy are increasing, which mandate an aggressive and long-term strategic plan to control all the risk factors predisposing to end-stage kidney disease. Understanding the patient's social background, family relationship are very critical in providing better care for avoiding complications. More effective prevention, intervention, and early detection program for CKD is needed. Early referral to the nephrologist will help early intervention. Make sure that this is patient try to understand and to decide what modality suit them and fit them, and it don't make decision for the patient, let them decide by themselves. It's important for the healthcare provider and financial planner to understand the magnitude of such a problem in order to have a clear strategic plan to deal with this devastating disease. And thank you very much for your attention. And the floor is open for questions.
Thank you so much, Dr. Badr, for your nice lecture about the introduction to dialysis. I think we have few questions. If we can take them quickly, it's about, is there any CKD screening program in Saudi Arabia?
CKD screening program in Saudi Arabia, I'm not aware that there is such a term called CKD screening program. There is efforts now for early detections and in different regions in the kingdom, but I'm not aware that there is really a chronic CKD program run by the MOH until now. I think it's all what we have is different efforts by different health sectors in the kingdom trying to find out what's going on about this chronic kidney disease. There are in some hospitals, they do what they call the pre-dialysis program, or which is stage patient who reach stage 4, stage 5. They start to follow them in a specialized dialysis clinic, so a specialized chronic kidney disease clinic. But I'm not aware really about a chronic kidney disease program in the kingdom.
Also, there's a question about the home hemodialysis. It's available in Saudi Arabia.
Yeah, it's available, and in variable degree. It's available in Riyadh, in Jeddah, in Dammam. Different company are doing that, and it's one of the goal and strategic plan in the kingdom to go more for a home hemodialysis or home dialysis type of treatment. Peritoneal dialysis is available, as I showed you, and the home hemodialysis is available. It's still low number, it's still low percentage, but it is evolving.
Okay. There's a question about the incidence of what's the incidence of cardiovascular complication in hemodialysis patient?
As I said in my presentation, around 20 to 25% of our patients are up to 30% of our patients on dialysis are cardiac patients, and that's the incidence of their coronary artery, whether they have coronary artery disease, arrhythmia, or congestive heart failure, and that represents around 30% of our dialysis population.
Thank you, Dr. Badr. Also, we have two more questions. Why there is incidence of hypocalcemia or why it is more in peritoneal dialysis patient, the hypocalcemia?
I'm not aware that really PD carry increased risk in hypocalcemia. I'm not aware about that. I think if you have more hypocalcemia, probably you need to focus more on patient management in terms of medications, in terms of compliance with the medication, and prescribing the appropriate treatment for the calcium and compliance with the treatment. One of the major reasons for the calcium problems in dialysis population in general is the size and the magnitude of the pills which the patient does receive. But to be honest with you, I'm not really aware that hypocalcemia is more common in peritoneal dialysis population. I did not come any studies which say such a comment.
I agree with you, Dr. Badr. I'm not aware. Maybe it's just the management overall.
Yeah.
It's not specific to the dialysis. Last question, Dr. Badr, is about what is your advice to a patient who has a chronic kidney disease, chronic diseases like DM and hypertension, to prevent from to progress in this stage?
It's a continuous process. It's a continuous work. The general guidelines talk about having a hemoglobin A1C less than 7. You have to have really a good control for their blood pressure, keeping their systolic blood pressure less than 130, controlling their LDL cholesterol, controlling their volume status, avoiding non-steroidal anti-inflammatory drugs. Well control of diabetes is the key factors, and that will really help regressing the progression of the problem, and that will delay the progression to end-stage renal disease.
Okay, so I think we have no further question. Thank you, Dr. Badr, for your kind participation and your great lecture. And if you allow me, we would like now
Thank
to
you very
move.
much.
Thank you, Allah.
Thank you very
Now,
much.
شكرا لك. الله يحفظك دكتور بدر. Now we will move to our next lecture and speaker. It's my pleasure to introduce Dr. Sumaya Skandarani. Dr. Sumaya, she is a transplant nephrologist at King Fahd Specialist Hospital in Dammam, and also she is the head of nephrology section and hemodialysis unit at the hospital. She's going to talk about the water treatment. Welcome, Dr. Sumaya. The mic is yours.
Okay, thank you, Dr. Khalid. Before I start, I would like to thank the organizing committee to give me this chance to talk about dialysis water treatment. I have no conflict of interest. And the objective of my presentation is to talk about general principle of hemodialysis purification system, clinical feature of exposure to contaminants, element of water treatment system, purified water versus ultra pure water, quality and monitoring sampling method of the dialysis water. So if we talk about general principle of the purification system, and we make a simple comparison between the healthy individual. As you know, the healthy individual drink about 40 liters per week. And when we are, it's equal to 2 liters per day. And this is with the presence of the selective gut barrier and also the excretory capacity of the urinary system. This water, it will not come in contact with the blood. It has two systems to filter and to control. What about dialysis patient? Dialysis patient, in the other hand, they do expose to about 120 to 190 liter per session, which is equal to 600 liter per of water. And this water, it's separated from their blood only by semi-permeable membrane. Any little contaminant in this water, it will associated with major consequences. So we are talking about the exposure and we are talking about high quantity. That's why the dialysis water is completely different than drinking water. If you go to the scheme of the dialysis water, from the start till the end user. It's a start from municipal water or governmental water. Then it will go to the dialysis water treatment, the process. Then we have the distribution system, the system that transfer the water from the water, the RO system till the patient. So it's a 4 process. Each process, it has its own regulation and policy and regulation. When it's come to the water, in general, water has either particle or solute. Particles, it's either minerals or colloid. Minerals, it's usually sand, iron, or clay. Colloid, it's the silica. And when we're talking about the solute, we have in the water inorganic ions like sodium, calcium, magnesium, zinc, and cation and anion. We have organic like chemical pollutants. We have microorganism and we have chemical. And when we are talking about source of the water, there are only 3 sources of the water. Groundwater, المياه الجوفية, surface water, السطحية, or rainwater. And these water, each one, it has its own characteristic. The groundwater, like well spring, usually it has high inorganic and metals, while it's the organic, it's less. The surface water, usually it has less inorganic but higher organic. The rainwater, it's usually it's a variable between the inorganic and organic. Regardless of the source of the water, the process in the government or municipal water, it has the same process, which is sedimentation, pelliculation, softener, oxidization and disinfect, and carbon filter. That's why it's like in one study, they study it was done in Australia, in 27 households that they are using the rainwater, they found 70% of them, they have E. coli and enterococcal. So for the previous reason, the quality of the dialysis water is different than drinking water. We said about the quantity and also the system we are using to filter this water. So if you see just a simple comparison, like the aluminum and chloramine, you see it's like we are talking about more, the ratio, it's like more than 100 more in the drinking water. And this is important to know and important to have a clue, because as I said, any high contaminant, it's associated with the major consequences. And if we are talking about the consequences, aluminium, it's usually associated with dialysis encephalopathy, bone disease, microcytic anemia, calcium and magnesium. It's associated with hard water, which cause nausea, vomiting, muscle pain, headache, hypertension. Chlorine and chloramine, which is usually added by the government to the water as disinfectant substance, is usually associated with hemolysis and other features like in chlorine, hyperkalemia, shortness of breath, hypoxia, and cardiac arrest. And in chloramine, it's beside the hemolysis, we have anemia and methemoglobinemia. Copper also associated with hemolysis and hepatitis. Fluoride also, it's considered as one of substances added by the government to decrease the infection or to purify the governmental water. It's associated with bone disease and cardiac arrest if there is exposure to high concentration of the fluoride. Lead, it's associated with peripheral neuropathy. Nitrate, methemoglobinemia. Sodium, as you know, it will cause hypertension, pulmonary edema, headache, tachycardia, seizure, and may cause coma. Sulfate, also associated with metabolic acidosis, nausea, and vomiting. Zinc, anemia, microbial and biogen. As you know, it's associated with sepsis. So now we will talk about the general principle, how it's look like the dialysis water. Started by the tap water, then we have the pre-treatment. The pre-treatment usually is to protect the RO. Then after the RO, we have also some other processes called secondary treatment, is to just to be the final tuning of this water. This is the general, I think most of the dialysis water treatment system look like this. The water will come from the governmental water. Then we have valve, temperature regulator, and we have the bulb. Then we have different process to, then after the RO, we have the tank that it will store the water till we be used by the patients. This is other like the same scheme. It's like we have here the valve, then we have the temperature regulator, the pump, and then multimedia filter, water softener for calcium and magnesium. Then we have the carbon filter for chlorine and chloramine, then the RO, then the storage. The function of each part of this it's like of this of the part of this of the dialysis water system. If we talk about the backflow preventer, because once you start the process, you cannot have this water mixed with the governmental water. So you have a valve that prevent the dialysis water to get mixed to governmental water. Then we have the temperature blending valve. Usually it will keep the water system around the dialysis water temperature around 25. That's why in the summer we are using the chiller, because if the temperature of the dialysis water is high, the RO will not function. Then we have the booster pump that keeps the pressure of the water. After that, we have the multimedia. Usually it will remove the large particle. If you remember, it's in my previous slides, I said the water has particle and solutes. Then this multimedia, it's called stone and different part of different layer that it will remove the particles. And usually the multimedia, it will be changed every 2 to 4 weeks. After we are removing the large particles, now we have to concentrate on the solutes. So we have to make the water less hard. And this is by presence of the carbon filter. Carbon filter, it's about sodium resin. The sodium, it's look like this. Then the water, it will come to this sodium resin. Calcium and magnesium will attach to this resin. So basically the sodium, it will stay in the water, while the calcium and magnesium, it will attach to the resin. Then we have the brine tank, which will remove this resin with the calcium and magnesium. Usually it is the half-life of the carbon filter 3 to 5 years, depend on the manufacturer recommendation. Then we have the chlorine. The chlorine we are using, you have to keep in your mind, RO will not remove the chlorine. It's only removed by the carbon filter. And the carbon filter, we have 2 tanks. Usually the first one is called the worker, the second one is called the polisher. And the removal of the chlorine, it depends on the time of the exposure and the number of the pores. It's like how it's removed, it's got attached to the carbon filter. Then after the pre-treatment, now we have to go to the main bulk of the dialysis water system, the RO. The RO, it's usually, it's overcome natural osmosis by forcing fed water under pressure through semi-permeable membrane. It's look like this, huge layer of the semi-permeable membrane, and there is a pressure. The water will come through this layer and it will remove plenty of contaminant, ion and organic. Of course, there are different types of the RO system, but I'm talking about the commonest process of the cleansing the water. After the RO, and of course, there is a half-life for the RO, usually it's 10 years. It depends on the manufacturer recommendation. And also if you don't have very protective system, the pre-treatment, you may damage your RO faster if you don't have the good pre-treatment quality. Then after that, we have the what's called deionizer. Whatever it's left after the RO, we have to remove it. The deionizer, it will remove the anion and the cation. It will not remove non-ionic contaminant, bacterial or endotoxin. It's contain cationic resin, contains sulfuric radical and exchange hydrogen that remove sodium, calcium, and aluminum. And also it's anionic resin that containing ammonium radical with exchange of the hydroxyl ion, chloride, phosphorus, and fluoride. Consequently, bacterial and endotoxin preventative filter are installed after the deionizer to prevent contamination of the distribution. It's look like this. It has a resin that removes the anion and cation. And then after that, we have the bacterial filter that it will remove the bacteria and the biofilms. Also, you have something called the ultraviolet system. Ultraviolet system, it's keep the temperature or the energy high to remove the whatever it's left from the bacteria. So it will kill the bacteria, but you will be left by some endotoxin. After we finish from the pre-treatment, the RO, the post-treatment, which is the deionizer, and also the bacterial filter and ultraviolet filter, now we come to the distribution system. Distribution system, it has 2 types, direct feed and indirect feed. Direct feed is usually, if it's the water treatment room, it's at the same level of the dialysis unit. And if your dialysis unit, it's small, then you don't need a storage tank. So you will cleanse the water, or you will filter the tapping water, drinking water, and this water, it will go to the patient in the dialysis machine without any storage or any complicated distribution system. But in case of you have like different floor, or you have a big unit, then you need a tank. This tank, it will go to the dialysis unit. So direct fit is directly deliver the product water from the RO unit to the loop of distribution. Indirect, it's involve storage tank that accumulate the product water and deliver to the distribution loop. Unused portion are recirculated back to storage tank. And even this, the distribution system, it has to be continuous loop and no dead end, because if you have like dead end or multiple branch, this is area where the biofilm or bacteria can grow. So this is like a scheme for the direct fit. We have the municipal water, we have the backflow preventer, temperature, booster, the pre-treatment with different filter. We have the RO, then we have the deionizer, then we have the post-endotoxin retentive filter and ultraviolet filter. Immediately it will go to the dialysis machine. You don't have tank, you don't have to retain any whatever unlift water. What about if you have the dialysis water in different floor, or you have big unit, then you will need storage tank. And after the storage tank, you will have the heater, and also you have pump, and then we have endotoxin, other endotoxin. Usually there is one here and one here, and then it will go to the dialysis machine. Whatever it's unused water, it will go to the tank, but some unit it will go in here, pre-RO, depend on the, it's like, you know, the manufacturer or the how it's made, the unit. So basically, but you have to be sure this unused water, it will go again through the post-endotoxin retentive filter. This is other, it's like you will find there is a different way of this, the retaining water. Some of them, they will go just before the RO, then it will go to the whole process. Other, it will go to the storage, but you will have this, the retentive filter. You will have one filter here and one filter here. Other, they will have filter here, vent filter, and will have filter here. So basically, it's the most important thing, we will keep highly purified water, regardless of the how it's you design your dialysis water room. Then what is the quality? Which quality you have to maintain? Now we discussed about the quality of it's like, you know, the solute and the particles. What about the microbial? Based on the AMI, the new standard in 2014, you have to keep the bacterial count less than 100. And the action, if you just around 50, then you have to take action. You don't wait. You take action till the bacteria it's around 100. Action need to be taken when the bacterial count it's around 50. What about endotoxin? It's the cut limit. It's 0.25, but the action it's when it's around 0.125. This is we are talking about the pure. What about the ultra pure, which is used in hemodiafiltration? Ultra pure has bacterial count less than 0.1 colony and endotoxin less than 0.03. And in the contrast, we said about the pure water, it has to be less than the bacterial count less than 100 and the endotoxin less than 0.25. Because hemodifiltration, there is some exposure to the blood, while pure will not expose. What is endotoxin? Endotoxin, usually the gram-negative bacteria has very stable cell membrane. And when you kill the bacteria by whatever chemical or heat, the wall, it will stay in the water. And if you have high quantity of endotoxin, it may cause inflammatory reaction to dialysis patient. What about which quality of you have to maintain in your dialysis water? You have, of course, you cannot keep the dialysis water, it's open to everyone. You have to have some regulation in opening and closing, access to the room housing, the water treatment system, and you have to have appropriate labeling. You have to have procedure for operation and maintenance of all components of the water, for the valve, the chiller, for the multimedia filter, for the carbon filter, for the RO. You have to have some operation and maintenance. And you have also to know how and from where you collect the water for sampling, and which action need to do based on the result. And also, in case if you are dealing with the third party, Fresenius, B. Brown, Baxter, so you have to distribute the responsibility, and you have to have meeting for and operation and audit. There is a guideline for the dialysis water by MOH. It's a nice one. Also, there is a SIBAHI chapter for dialysis water, and also there is the CDC and there is AMI. If you go to read all of them, you will find a lot of similarity about policy, about the manufacturer recommendation, about hardness and chlorine, microbial monitoring. I'm not going to go over in detail in this because I think most of the nephrologists are aware about it, that you have to have like this, but I'm going to go in general about what is the weekly, what is the daily checkup, what is the weekly, what is the monthly, what is the annual. So in general, you have to look for the chlorine, the turbidity, and also you have to look the bacterial, and you have to look for the hard metals. And in regarding the disinfect, if you go to the RO, you have to look to the, if there is no membrane heat, then you have to look to the manufacturer recommendation. Usually you will use the acid, and based on the unit specific, you're gonna to disinfect your RO. If you have the new RO, which is there is a membrane heat, I think most of the unit they have membrane heat, then you will do it weekly. Okay. If you have portable RO and there is no membrane heat, then you will do it. You will use acetic as manufacturer recommendation. There is membrane heat, like most of the unit. Then you will use the heat to disinfect your RO system daily. In regarding the distribution system, if you have the heat, then you will do it daily or weekly. If you have, because you know chemical, if you use it frequently, it will damage your systems. You're gonna use it quarterly. This is regarding the daily monitor. So the biomeds or the engineer, whoever like taking care in your unit, he will go daily to look to the following things. Will the conductivity and the temperature in the pre and post RO. Look to the pressure. If you go to the RO, you will find like, you know, 4 screen. It will tell you about the conductivity and the temperature, the pressure, and then they will check the chlorine through the dipstick. and the pump pressure. Then they will look to the hardness post softener. It will tell how much. Unfortunately, here in Eastern province, we have the hardness of the water. It's little bit high, and this will participate on the RO system. Then you will get this. This is from our unit. This is like, you know, a weekly check for the chlorine, pH, and the turbidity. And then we have the monthly for the bacterial endotoxin. Unless if you suspect something, then you will do it more frequently. And this is about the metal trace element. You have to do it annually. Unless there is something going on, then you will do it more frequently. From where you get the sample? Sampling point, you have to know from where you collect the water. Post carbon for the chlorine, post RO for pure. For ultra pure, you put it in dialysate port. And sampling for chemical contaminant and microbial contaminant. So basically, if you suspect, there are also it's like, you know, way from where you get based on the what you are looking for. It's like the chlorine or magnesium, or based on the suspect. For the microbial, also the membrane filter, spread plate assay, and bore plate technique. And you have to look for the culture. You don't put it in any culture. It has to be low nutrient, because it's the bacteria in the dialysis water. Usually it's slow growing. So you have to keep it in between the temperature 17 to 23, and you wait up to 168 hours. And this is also about the frequency, but again, you have to do it based on your manufacturer recommendation. And action should be taken if the bacterial more than 50, if we are talking about the pure water, endotoxin more than 0.125. Chemical, if it's based on the more than the maximum recommendation. And this is example, or this is the scheme. I like it. If it's the endotoxin for pure water less than 0.125, bacterial, it's around 50, less than 50, then you continue your dialysis. If the post-RO water sample endotoxin, it's between 50 to 100, between 0.125 to 0.2, then you continue dialysis, but you will ask the biomeds to do disinfect for the RO and the circuit. Then you repeat the sample. If the sample, again, it's between the, it's like this borderline, then you may consider other way of disinfect. If you are using the heat, then you will use the chemical. If you use the chemical, you may combine. Sometimes you increase the concentration of the chemical based on the result. But if the endotoxin more than 0.25 and the bacterial is more than 100, then in this condition, you will stop the dialysis. You will do thorough disinfect and cleaning the RO, then you resume it once the test is within acceptable range. This is other example. It happened usually if there is any crisis in the municipal water, they will inform you. It happened in West Virginia. There was a chemical spill in the river. Then they call the dialysis. You have to have some plan B, like you refer your patient to other unit, or you change the source of your water. Again, there was like Lake Era bloom, and there was bacterial contamination. The most important thing is to keep contamination, is to follow, from where you got your water, and you keep tiptoe. And this is the most important thing. And the summary of this presentation: dialysis water is different than drinking water. and this is because the dialysis patient, they do expose to about 600 liters of the dialysis water. They don't have any protective system to protect them and to filter this. Actually, the blood, it's only separated from the dialysis water by semi-permeable membrane. You have to know where is the origin of the tap water. And you have to know, because the component of different part, the surface water or the groundwater or the rainwater, is different from one side to other side. The element of the water treatment system, we have the pre-treatment, which is very important figure that protect your RO, secondary treatment, and the distribution system. Maybe you have perfect pre-treatment, perfect RO, but you don't have good bacterial filter in the secondary treatment, or maybe you have a lot of loop branches in distribution that cause your system, the whole system, to shut down. Then you have to know the difference of the pure and ultra pure to design which quality, because if you wanted to put all your patient in hemodiafiltration or in hemodialysis, you have also to know the different type. Also regarding the monitoring, it's not enough that you have a good pre-treatment, RO, and post-treatment or secondary and distribution without good monitoring. Monitoring is important, and also you have to know which action need to be taken in case of emergency. And thank you.
Thank you, Dr. Sumaya, for your nice talk and overview about the water treatment. I think we have some questions. Okay, so I'm not sure it's related about the I don't see a question related to the talk directly. Actually, there's just about maybe the previous talk, and we can answer them another session. We can just give a few minutes if you have any question about this topic to the audience.
Maybe I was so clear or I was not clear.
That was so clear. Allah يعطيك العافية. It was really clear to everyone. So I think the point that is, as you mentioned, that we have the guideline which is going with the international. So just following them and have regular checkup is important. Okay. Well, I think now, since we don't have questions, I would like to thank you, Dr. Sumaya, for your nice talk and your participation today with us. And now we can move to the next presentation. Thank you, Dr. Sumaya. Thanks. Now, it's my pleasure to introduce our next speaker, Dr. Ali Hakami. Dr. Ali is a nephrology consultant at King Fahd Central Hospital in Jizan and the Chief Medical Department at King Fahd Central Hospital in Jizan. Dr. Ali, he's going to talk about the hemodialysis prescription. Dr. Ali. كنا دكتور علي حضرتك ميوت.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. الصوت بعيد شوي. دكتور علي احنا ما نسمعك، الصوت مو واضح.
طيب يبقى الآن كيف يا دكتور خالد؟
ستيل يعني شوي الصوت ضعيف.
أنا حطيت أكسس. من وين طيب لو نغير الصوت؟
ممكن بس لو يمكن المايك بعيد عنك شوي، أو لو بس ممكن ترفع الصوت شوي أعلى.
دقيقة بالله خلينا نشوف. الآن طيب كيف دكتور خالد؟
بتر.
أنا ما عندي بعد نتكلم أنا داير الجو دائما عشان كذا مستغرب. طيب الآن كيف؟
لا يزال شوية في ضعيف، معلش.
طيب ممكن أعمل له تيست في كاميرا عندي هنا. ما عندي.
ممكن ممكن دكتور علي تعمل شير سكرين من هنا، ومثلا
أيوة.
وتدخل من الجوال.
طيب أعمل شير سكرين.
في تحت في أسفل الشاشة في شير سكرين.
فيها شيء. نعم شير سكرين. طيب خلينا نسوي طيب الآن كيف؟
الآن واضح البرزنتيشن. هل ممكن نسوي فول سكرين؟
واضح الآن الصوت يعني؟
الصوت أفضل الآن. أيوه.
أيوة. طيب الآن كويس يا دكتور خالد، نبدأ؟
إيه ممكن نبدأ. أيوه.
لا إذا كان باقي في لخبطة في الصوت أنا ممكن أغير عادي، بس ما أدري من هنا. فأنا غيرت.
لا الآن أفضل. لا الآن أفضل.
الآن أفضل ها؟
نعم.
طيب معناته نبدأ إن شاء الله إذا كان يسر. خلاص أبدأ يا دكتور خالد؟
إيه تفضل.
طيب. Good morning everybody. Thank you too much Dr. Khalid and your colleague for inviting us to participate in this course. And already my colleague Dr. Usmay and Dr. Badr talk about important lectures, and now I'll continue other which is called hemodialysis prescriptions. And we'll take not, I hope it will not be more than 40 minutes like that one, so we can keep time for question. Hemodialysis prescription, I think one of the most cornerstone when you just manage your patient, dialysis patient, make sure that he's getting enough dialysis and at the same time he's getting the correct prescriptions. So this is our actually aim when you're just seeing our patient daily in dialysis, that is he getting enough dialysis or not? And this is actually the aim for just sharing with you this lecture today. And I will just give you a scenario, which I'm sure commonly you see it in our units, whatever central or peripheral units, that we have, for example, 25-year-old male is in the stage of disease and hemodialysis, getting only twice per week dialysis. And we are seeing many patients even getting once, sometimes 3 times, sometimes 2 times, through a fistula since the last 5 years. He has uncontrolled hypertension, his weight 70 kilo, intradialytic weight gain approximately 4 kilo. His cardiac function has deteriorated from 60% ejection fraction in 2016 to 25% in 2021. His hemoglobin 10, calcium okay, phosphorus high. His parathyroid hormone is increasing over time, reaching 900 plus. His sodium is okay, potassium is still at 6. Since last few weeks, he's getting more breathless at night during exertion, and also getting cramps and back pain. His hemodialysis prescription was or is polysulfone dialyzer 1.2 millimeter meter surface and ultrafiltration approximately 8 ml per hour per millimeter mercury. He's getting twice per week, 3.5 hours, and every session only sometimes 3 hours. Blood flow 250 ml per minute, dialysate flow 500 ml per minute, ultrafiltration 1.25 liter per hours, and dialysate sodium 140, potassium 2, calcium 1.25. So this is the dialysis prescription for our patient And I'm sure all of us have seen this in units, especially in peripheral units, sometimes even in the central units, that they have only 2 hours or 3 hours blood flow on 250, sometimes 300 ultrafiltration per hours. So dialyzer, as you know, that our patient, especially Minister of Health, unfortunately, sometimes it is small dialyzer, sometimes big dialyzer, sometimes low flux, sometimes high flux. So all this one actually playing a major factor in delivering adequate dialysis for our patient. And we'll try to discuss this case scenario. And after that, we go how going to just help this patient to get adequate dialysis. From the clinical scenario, looking at that, he's more heart failures, and he's become more sick for the last weeks, and we need to modify his prescription. Otherwise, he will continue to deteriorate. So, where is the problem in this patient? Nephrologist has not taken care for the patient. Patient has not taken care for itself. Hemodialysis prescription was not revisited, and or both 1 and 3, or both, or all the 3, 1 and 2 and 3. I think from this one you can just see that especially 1 and 3 was not touched. Most likely the reason for this patient to getting more sick and deteriorate. So always the question when you see your patient, as I mentioned before, does the patient get enough dialysis or not? And the outline of my lecture will be method for measurement of dialysis dose, and this is very important actually. So we just know about the patient getting enough dialysis or not. The second important thing will be the component of the hemodialysis prescription. I will concentrate it more on type of dialyzers and blood flow in relation to the clearance and dialysis flow, frequency of dialysis, and the ultrafiltration goal. You know that is long story to cover anticoagulation and provide like sodium, potassium during dialysis. But actually, I'll just go to cover this items. So when you see your patient in dialysis, and you know this patient getting the dialysis, good dialysis adequacy or not, actually you have many factors controlling our patient in dialysis. Not simply blood pressure is good or not, control or not is very important for us. Anemia management, good nutritional, electrolyte, and fluid management, recurrent edema, for example, by multiple ultrafiltration, bone marrow disease, you know that hyperphosphatemia, hypercalcemia, hypocalcemia, and hyperpara. So plus the adequate solute removal, which is the adequacy of dialysis, what we are just trying to measure. So our patient have multiple factors, and if we need to control or just improve dialysis adequacy for any patient, we need to control major, this is all the major factors, and including our delivering dose of dialysis, which is the adequacy of dialysis, or dialysis dose, which I will talk about here today. So there is two central issues in the management of patient undergoing maintenance hemodialysis. Initially, we need to do the amount of dialysis that should be prescribed. Any patient come to you, for example, new to dialysis units, you need to know this patient needs big dialyzer, small dialyzer, heparin, how many hours, how many ultrafiltration. So this is dialysis prescription. And second important thing, we need to just see the amount of dialysis that actually delivered to the individual. So meaning that I need to measure this one later, just make sure this patient gets usually this is the dialysis prescription correctly or not. And this is the two important actually cornerstone for managing of adequacy of dialysis prescription in our chronic end stage or end stage need. Measurement of dialysis dose, they have multiple actually, as you know. The most easy one now is urea reduction ratio. Simply just measure the urea pre and post, divided urea pre post over the pre, multiply by 100. If more than 60 to 65%, this is considered actually good dialysis. But actually, this is one, it's simple to calculate, but the effective bacterial filtration not included. And usually I'm measuring only, it is less accurate since it's assumed that the urea volume distribution remain constant during dialysis, and this is not correct actually. As you know, the urea will go down with dialysis, and this one, the accuracy for it is very low. But it's easy to be done. It's a very simple procedure. You can do it very easy. The second one is the KT over P. And the KT over P, we have actually multiple types. The one called the single ball KT over P, and this is the most widely used now in our dialysis unit to see if there is really adequate dialysis or not. And actually, the minimum dialysis delivered according to the last legal guidelines 1.22, and the target is 1.4. And this is actually the most widely used. There is a limitation for it, we'll see it later. And this is the reason. The second one called the equilibrated or double ball KT over P. Double ball KT over P is around 1.2, the targets. It is more accurate than the other one. But as you know, it is not easy to be done, or this is called equilibrated. And you know, when you're starting patient on dialysis, the urea will go down because the urea will be intravascular and extravascular. And when you are take the urea sample at the end of dialysis, immediately we're just measuring the one intravascular which was affected by dialysis. However, the one extravascular, it will go to the intravascular, and the serum will be start rising gradually. And with this issue will take approximately half hour after you finishing the dialysis. And this is actually give you the true urea post dialysis. And this is the one called double ball, or the equilibration of the KT over P, which is usually 1.2. But as you know, our dialysis patient, after I finish 4 hours or 3.5 hours, he will just jump to go home, and he will not stay for another half hour to take this urea sampling. So it's not easy actually to be done, especially in our dialysis unit, busy units, a lot of patients waiting with this bed or this chair. So since we'll finish the patient's dialysis, we'll just go home and take another patient. Even the nurse will be busy. So this is actually, but actually this will be more accurate if just compare it to the single ball KT over P. There is something called the standard KT over P, and actually is a very, I'm sure in the future will be this the most important one, and this is will be replacing all the equation. Because standard KT over P, sometimes you know that we're dialyzing patient 4 times or 5 times per week. We're dialyzing, for example, or 2 times per week. Sometimes the patient have good urine output. Sometimes the patient, you will see the effect of ultrafiltration on the clearance. So this one just to give you the standard KT over P over more than 2 in the week, by the week. And actually, it's a little bit complicated to calculate it, but actually it is available on the websites. And as you mentioned, the single ball KT over, just take it for the patient getting dialysis 3 times per week. So this is the most important equation that we calculate the adequacy of dialysis. The urea reduction is easy to be done, and actually, but you know that's not accurate like the other one. The single ball KT over is the one most commonly we are using in our dialysis units. And the other one, the equilibrated, already mentioned, that's fine. The standard KT over for a patient getting, as mentioned, 4 times, 5 times, or 2 times. The patient has good urine output, so it's better to use standard KT over. Actually, you know, that's simply to go to the website or just clinical calculators and just put your for example, urea and the other pre and post, and calculating the adequacy. For example, our patient that this is the equation that commonly used now. This is casing a single ball KT over P by Jardis, and they just taking the pre-dialysis urea, post-dialysis urea, duration of dialysis, volume of ultrafiltration in liters, for example, 2 or 3 kg, post-dialysis weight, and KT over P. It will give you the calculate for you the KT over P and the urea reduction rate. So simply when you just putting our patient in this calculations or just KT over P calculators, we put the urea and pre and post duration of dialysis. When the patient, we assume that the patient getting 4 hours, and we just volume of ultrafiltration, and you can see that the KT over P only 0.79, and the urea reduction ratio is 45. So we just make sure that we give the patient 4 hours, not only 3 hours, 3.5 hours. In spite of that, came very low his KT over P. That indicated this patient is not getting enough dialysis. So now I'm going to improve his dialysis adequacy and delivering good dialysis. As you mentioned, KT over P is the preferred method measuring the dialysis dose. The available is in the website. And this is K, meaning the dialyzer clearance of the urea, which is depending on the blood flow and dialyzer size. And T for the duration of dialysis, minutes. P for the volume of distribution of urea in the body, which is approximately equal to the total body waters. So this is the most important thing we are just manipulating in prescribing our dialysis. And you can see the clearance of dialyzer, depending on the two important issues. Dialyzer size, bigger dialysis will be more clearance, and higher blood flow will be more clearance. So this is actually the most important. Plus duration of dialysis, approximately all of that. Now they're using 4-hour dialysis for their patient. All of distribution, of course, will not be changed. This is the weight of the patient. There is a limitation of KT over P. Actually, first of all, this is KT over P. You know that more than 20 years and now in the clinical practice, and actually this is developed in the era when dialysis used small bore cellulose dialyzer. Nowadays we're using the synthetic membranes, and the other thing and nowadays we're using large bore high flex dialyzer. So this will be actually we need to modify our new calculation, because nowadays they change the dialyzer, the size of dialyzer, everything changed. And this one based on the kinetic pattern of one single solute, which is urea. And the evidence of toxicity of urea is very limited. And as you know, our patient always asking about urea and creatinine, which is actually not toxic. And the European people published now more than 146 uremic toxins. It's more serious than the urea. So unfortunately, you are just depending on the urea measurement and calculator, which actually it is not toxic material. Measuring urea clearance in single session. Simply, we can just change the time of dialysis. Simply, we can change the blood flow for the patient, and this will just give you good dialysis prescription or just a good KT over P result. Error in timing of both dialysis blood urea, as already mentioned now, because the urea calibration it will take approximately 30 minutes, and sometimes maybe it will be late, maybe it will be early to take the urea sampling. So this is another issue we'll face in our dialysis unit. And the overestimate dialysis among small size and malnourished is important. And this is the people that need really good dialysis. And the other thing, it will not, the KT over mentioned before, it does not take the account contribution of residual renal function to the clearance of uremic toxin. Actually, when it was published, was not putting the urea renal residual renal function. We know that's a very important contribution to the uremic toxins, especially from our PD, peritoneal dialysis literature and cases. KT over P cannot be used to compare treatment among patients when dialysis frequency deliver more than 3 times per week. And this is the one we need, for example, to use the standard KT over P. So all this limitation of our KT over P we're using nowadays And this is the point. I'm just trying to most likely future will be change this KTO/P and to be the more applicable, most likely to the standard KTO/P, which is the weekly, the one per week, not only the one per session. Actually, the question always, if just as you mentioned, KTO/P 1.2. Some people they need to make it 1.7 like peritoneal dialysis patient. Is this affect survival or not? And this is hemo study was published a long time in New England Journal of Medicine, and just simply comparing single bore KTO/P versus high dose single bore 1.65, and also the compared low and high flux dialysis in more than 1,800 patients undergoing 3 times per week. The survival curve for high and standard dialysis, meaning that this is the high dose, the red lines, the 1.65, the high dose, and this is the standard dose 1.2. You can see this the study running for around approximately 5 years, and there was no difference in the patient survival. So if you try to push the KTO/P to 1.7, 1.2, it will not make a lot of change in the patient survival. So this is another point. Second point from this also study, but it's actually long time, 2002, I think, in New England Journal of Medicine, that there is no difference between low flux and high flux. But later, actually, multiple trials came and found that the high flux dialyzers is good, especially in special situations. We'll just go through. So the conclusion from hemo trials was the dialysis prescription of KTO/P value less than 1.2 may carry high risk, high mortality, and morbidity. Increasing the dose of dialysis of KTO/P more than 1.2 does not carry any significant benefits. So, and they recommended that single KTO/P 1.2 to up to 1.4. So this is actually some people are always asking, shall we push more the KTO/P than? Yes, you can push and put a lot of dialyzer, for example, a lot of blood flow. But this actually will not change actually from this study, but this is actually 2002, approximately 21 years ago. This is the standard weekly KTO/P. I know this is a very bad calculation, but this is now available in the websites. And you can see that including the residual renal function, including the ultrafiltration. Ultrafiltration is a very important factor for clearance of the toxin also. And treatment duration, and also the number of treatment per weeks, and the volume of distribution, and also including the equilibrated KTO/P. So all this one, it's available in the website. All this one, you can put it in the information, just fill in the gaps, and you'll find the results, for example, 2 or less or whatever. But it's very important now, including the ultrafiltration as contributing to the clearance, including the residual renal function, and including the number of dialysis per week. And this is what I mentioned before, that most likely it will be replaced the KTO/P in the future. So last guidelines, as you know, KDUKI guidelines, we recommended the target single ball KTO/P 1.4, minimal 1.2, and the preferred to be 1.4. And in the other important for hemodialysis schedule other than 3 times the target KTO/P, the standard target KTO/P 2.3 per weeks with minimal delivered dose 2.1 using the method of calculation that already we mentioned before. So I think we finished the first important point, that how going to just measure the adequacy of our just dialysis dose, and we'll go to the next. So our goal for a successful hemodialysis prescription, we need to remove the solutes, either small or large, fluid removal, quality of life. So the component of the hemodialysis prescriptions. actually is very important when you now writing the prescription for the patient, what type dialyzers, how many hours dialysis per week, and duration of dialysis, the blood flow, the dialysis flow, duration, and the ultrafiltration, dialysis composition, sodium, potassium, calcium, anticoagulation. Actually, because of time and issue, I didn't included these two items. I don't know that Dr. Ismail will finish early, otherwise I can put it. So we'll see now the effect of the dialysis in our patient or the adequacy of dialysis and how it's important for our patient. The ideal dialyzer should have high clearance of the small and medium molecules weight volumetric and negligible loss of vital solute. As we know, we have small molecules, large molecules like medium molecules like microglobulinemia. This is the one contribution to joint pain, neuropathy, and operative complications. So, and the other, plus the other we'll see it later. So the ideal dialyzers, they need to have good clearance for the small like urea, creatine, plus the middle molecules like as mentioned, beta-2 microglobulin. So the dialyzer, we have important point for dialyzer, or the important actually the solute clearance, how it will remove the water clearance, especially how to contribute the ultrafiltration for the patient and the biocompatibility. I will not touch biocompatibility a lot because, as you know, most now all the dialyzer coming to us, it is biocompatible, mainly the synthetic membrane. It's not the cellulose, semicellulose membrane. So now all the worldwide dialyzer coming compatible. So this is actually important point for dialyzers to know the type, to know when you're selecting for your case what the type of dialysis. The surface area is very important. But usually what's available for us adults from 0.8 to 2.5. And usually this is depending on the size of your patient. For example, our patient in this scenario is around 70 kilo. So I will try to use, I cannot use 0.8 at the same time, I cannot use 2.5 for a patient more than 100 kilo. So usually like, for example, like this patient, you can use like 1.6, 1.8 surface area of dialysis. It's very important, especially for the supervisor of the hemodialysis unit when just unit, that makes sure they have the correct dialyzer size, not just putting, for example, 70 kilo patient on small dialyzers. Unfortunately, will not do anything. So we usually correlate the size of the dialyzer for the size of the patient. It's a very important point. And we're seeing frequently our dialysis unit that putting small dialyzer for a bit. And this is just, and if in the physician must writing that the dialysis prescription, write it very clearly that I need to 1.8, I need to 1.7, 1.5, 1.4 for our patients. It's a very important surface area of the membrane or dialysis. There is something, this is the KOA, this is the mass, this is the mass transfer, whatever, forget about this, but this is it will be found it written in the dialyzers, and this is meaning that the solute clearance, and this is the one dealing with the removal of the toxin, especially urea, what you're measuring here. And this is the maximum clearance for any dialyzer in ml per minute. And depending on that, we're defining our dialyzer to 3 types. If it's less than 500, it's called low efficiency dialyzer. If it's from 500 to 800, it's called high moderate efficiency dialyzer. If it's more than 800, it's called high efficiency dialyzer. This is the solute removal, and this is usually written in the dialyzers that. By the way, all the dialyzer now delivered to Ministry of Health centers, it is high efficiency dialyzers. So if in more than 800 ml per minute, sometimes 1,200. So this point is important. I didn't think will play a lot of major role in our prescription, but this is a surface area important. The another thing to the water clearance, or this is called ultrafiltration coefficient, which is meaning that of the volume of the plasma water filter in ml per hour for each transmembrane pressures. And this is actually very important. We just try to dialysis prescription. Sometimes we need to use low flux, sometimes we need to high flux dialysis. By the way, all dialysis units nowadays are using high flux. This is the new patient. Otherwise, use high flux. And we try to just twist all the fluxes to be high flux, not low flux dialysis. And this is actually could be also 3 categories. Either low, if the less than 8 ml per minute per hour is called low flux dialyzer. And if it's from 8 to 20, it is intermediate. If it's more 20 ml per hour, is called high flux dialyzer. So this is actually slides are very important when selecting the prescription for the patient, because this will give you initially the size of the membrane that I need to use for the dialyzers, and depending on the size of your patient. And the other important thing, please try to select the high flux unless the patient newly diagnosed and very high urea creatinine, that we need to avoid disequilibrium syndromes. And as I mentioned, nowadays all the dialyzers in our Ministry of Health high efficiency dialyzer. So unless we don't know, but to notice that all of our dialyzers high efficiency dialyzer. So this is a very important actually when selecting the dialysis prescription, especially concentrating about the dialysis. There is another actually character of the dialyzer, that something called low permeability, something called high permeability. And this is mainly related to high permeability, usually high flux dialyzers, and more than 20 ml per minute. This is the one we are concentrating about regarding the middle molecule, which is the beta-2 microglobulins. So also you can find it in your when you just reading the numbers in your dialysis. So the solute clearance will be determined by many factors, as already mentioned. This is dialysis-related factor, and already discussed in detail the surface area, the membrane types, and diffuse permeability. And the other important thing, dialysis-related factors, which depends on the blood flow, dialysate flow, and dialysis times. It's very important. And the other important thing is something called patient-related factors. Vascular access for the patient has permecat or fistula, good fistula or not. The percent of circulation, recirculation is not more than 10%, and the weight of the patient. So this is factors are very important to play a very important role in the clearance of the uremic toxins. As you mentioned, dialysis-related factors, dialyzer-related factor, and dialysis-related factor, and the patient-related factor. All this one will keep it in our mind. We're just writing dialysis prescription. This one already I discussed with dialyzer. We'll go to the other one. As you mentioned many times, that we have the small molecules. These are kilodaltons, approximately less than 460. This is called small toxin, or just small size toxin like urea, creatinine. And this one can be simply removed by the low flux, high flux dialyzer. And this is very important. The beta-2 microglobulins, for example, and the myoglobulins, they need, especially beta-2, they need, this is the one related to amyloidosis and joint pain and other issue. This is the one we need actually to use high flux dialysis. So the low flux will be here, but unfortunately for beta-2 and the other no. There is something called large molecules like interleukin-6, inflammation like blue light chain, multiple myeloma, hepcidin, and the other like acute phase reacting. This is actually the need to be used large dialyzer. And this, for example, nowadays in the market, we have Terranova dialyzers available now. And this is we can use. The other one, the albumin, actually, this is the essential albumin protein, which we try to avoid to use it, because as the dialyzer becomes larger in clearance or just bigger in the clearance, we'll go to this direction. What we have in our marketing approximately up to here. But sometimes we have, for example, Terranova dialysis. So this is the very important solute size and what are the dialyzers we're using there. The solute clearance, as you mentioned again, that low molecular weight, for example, urea, this is easily can remove by diffusion. As we know that there is two important removal of the toxin regarding the clearance, that either by diffusion from high concentrated to low concentration, and usually like low molecular weights like urea and creatine easily can remove by diffusion. High molecular weights like beta-2 and others like leucine and free light chain. This is the need of something like convection. And convection we are doing through the hemodiafiltration. I think hemodiafiltration is not widely available in our Ministry of Health. Simply, I think Dr. Sumaya, she was pointing to this very nicely, that we need to have ultra pure water, 0.0125, which actually nowadays all the Ministry of Health actually guidelines concentrating mainly about the endotoxin with 0.25, less than 0.25. So we're not concentrating a lot about the ultra pure water. You cannot use, because we're using large amount of fluid for the convection of the hemodiafiltration, which approximately is but actually we can remove the high molecular weight by high flux dialyzer. So we can use high efficiency high flux dialyzer instead of the convection to remove the high molecular weights, just middle molecular weights. This is actually the very important slide I like it really, because this is correlate the dialysate blood flow and blood flow for the patient in the dialysis. And this is actually the dialysate flow is fixed, actually 500 ml per minute. And this is the clearance. And as you know, as the blood flow will go up, there will be increased clearance. But very important, you can show up to 200. And this is actually the 5 dialyzer. Are you dealing with high efficiency dialyzer or low efficiency dialyzers? And you can see that up to 200, the blood flow is still there is no contribution or whatever the type of dialyzer. So sometimes you're putting your patient in 200 ml per minute flow, and you're using high flux dialyzer. This is wasting of money for them. To get benefit from the dialyzer clearance, we need to go above 200. You can see easily that now the lines start separating. For example, this is the low efficiency dialyzer. This is approximately the efficiency around 600, and this is the high efficiency dialyzer. So to get more clearance, we need to get blood flow more than 200 to see the effect of the dialysis. So whatever dialyzer you're using, low flux, high flux, it will not do anything for the clearance, unfortunately. So when you're just using blood flow 200, above 200, it's recommended to 350 at least, to 400. You can see easily that now the lines started separated by the type of dialyzers. It's a very important clearance increase with increase of dialyzer efficiency. Increase in clearance is most prominent and with adequate blood flow, as mentioned. And the blood flow less than 200, the clearance is low, whatever the dialyzer we're using. If you start blood flow more than 200, now it starts separating, now it starts seeing the effect of dialyzers. Most benefit of high efficiency dialyzer is with adequate blood flow. It's recommended that to keep at least 350 up to 400 to really get benefit, excellent benefit from the type of dialyzer and have excellent clearance actually. It's a very important actually slide. And this is actually just, I mentioned before that I have Terranova now dialyzer available, I think in Mr. Phil. And this can be used to use it for the, for example, patient rhabdomyolysis, blue light change, multiple myeloma, acute blue light change. So we can use the high cut of dialyzers. It's a very, this is one called, I think, expanded hemodialysis. Actually, the water clearance, I just want to just just to mention that there is desired weight loss will depend on the ultrafiltration coefficients of dialyzers, which actually already mentioned this low or high flux dialyzer, dialysis time, and the transmembrane pressure. This is the most important factor contributing to the water clean. Simply, these two figures that to show you that this is the low flux dialyzer, small bores, and this is the high flux dialyzer. You know that high flux can be small size or large size, and again the low flux can be small or can be large. When large size, for example, size 2 and low flux dialyzer, this is called high efficiency membrane. So there is any difference. Now we'll go back to the any difference by high flux and low flux membrane, the outcome. There is 3 large randomized trials, HEMO and EMBO and EMBOS, HEMOS USA, MBOS Europe, and AGE failed to show any benefit of high flux membrane. One secondary outcome analysis in HEMO trials and meta-analysis Cochrane trial showed reduction in cardiovascular mortality with high versus low. However, there is a very clear that reduced cardiovascular disease for a selected patient, low serum albumin, and high dialysis duration more than 3.7 years, and diabetic patients. So this is showing no harm actually. So actually, if you just see that most of our patients already either diabetic or below albumin, or they have dialysis for more than 3.5 years. So actually, so this is a point that, and often from Cochrane trials that showing that reduced cardiovascular. And this is actually behind the recommendation now to use high flux dialyzers as the main dialyzer in the old days. All of our patients diabetic, hypertensive, and low albumin and long-standing dialysis. So hemodiafiltration, I will not just touch it up, approximately like the CRRT machine, but using large amount of fluid. And as you mentioned, you don't need to use ultra-pure waters. It's very good actually for the clearance of the middle molecules like beta-2. And this is actually the study was published in JSON that you can see it. Clearly, this is the people and the hemodiafiltration. And that you can see very clearly that the beta-2 will drop significantly versus the one getting low flux dialysis. And as you mentioned, this one is important for carpal tunnel syndrome, arthropathy, amyloidosis. It's very important actually, complication coming from beta-2. So we need actually to clear this one. And actually, but you know that high flux dialyzer membrane can remove the beta-2 microbes. This is the hemodiafiltration. And this is actually from mortality risk is reduced in a patient receiving hemodialysis. This is from European and DOPS tables. And actually, that showing that high efficiency yes, can reduce the mortality. Yes, the evidence is not very strong, but actually it's not easy to be to apply this hemodiafiltration for in our dialysis unit at level of our motor treatment and to take consume large amount of waters. So the other important thing, I hope the timing is not going fast. The other important thing, the blood flow and the contribution in our clearance, and already mentioned very clearly now. It's a very important blood flow. Is a very important determinant for the KTO for fee. I already mentioned that the blood flow dialysis depends on the size and the other important thing in the blood flow. And we can see it here that already our slide already mentioned before. As the blood flow go up, the clearance of the dialyzer will go up, especially after 200. And it's recommended that we keep our blood flow more than 350 ml per minute in all patients. And the blood flow 400 to 450 if good access, but the possibility of resuscitation will be high. Blood flow, unless the patient, for example, has cardiac problem or ejection fraction, it's difficult to push high blood flow, and patient has newly fistula, or patient has initiation of dialysis and they just started on dialysis. Of course, you cannot use it. Use only 150, 200 for any new patient. Patient cardiac problem, hypotension, new fistula, and the first dialysis, you will always try to use low blood. So please recommended that use as maximum as the venous pressure and arterial pressure can tolerate. Use the high blood flow. Go up to 350, 400. This is the one give you very excellent clearance that I mentioned in these figures. This is actually to have good clearance. Again, a good blood flow, we need to have good needles. As you know, most of our patients now, they prefer to use small needles, 17. If you use 17, you cannot use blood flow more than 300 because it's a very small needle, will not tolerate high blood flow. If you use 16, it can go up to 300, 350 blood flow. If you use 15 needles, it's a big one, and 14 can go up to 350 to 400. So you cannot use 16 or 17 and try to use more than 350 blood flow. It cannot go up because the venous pressure, the arterial pressure will be fair. So simply that, please try to use big cannula or big needles when you cannulated your patient so we can use higher blood flow. We know that our patient always it's not easy to actually to agree for big needles. A little bit the size bit. At the same time, if you just use this one, for example, our permacath, we have more than approximately 40% of dialysis patients through permacath. Permacath, I don't think we can exceed more than 300 unless, especially with this new permacath we have nowadays administered. So we need to have our patient in fistula and good blood flow to have actually good clearance. This is a very important point. Dialysis flow contribution to anything for the clearance or not. This is actually always important cutting point, especially for the physician writing dialysis flow. And actually, you can see from this slide that this is actually the dialyzers clearance, and this is actually the dialysate flow. Dialysate the flow we are using here 500 ml per minute, and actually this is the blood flow, and this is the dialysate flow. Dialysate flow here we are using 500, and you can see that the blood flow start blood flow 300, 350. If you're using dialysate flow 500 or 800 or 1000, it will not do anything for the clearance. I think it's clear. What are using in our center now? Up to 300 to 350 the blood flow. If you're using this one and measure the dialysate flow and also dialysate flow 500 or 800, 1000, there is no difference in the clearance. There is no difference in the clearance. So meaning that one, we're wasting of our money to use dialysate flow 800 or 1000 and will not add anything for the clearance. So dialysate is very expensive, and the blood dialysate flow, as mentioned, more than 500 is adequate to achieve a target urea clearance. It's a very important point that don't use 800 or 1000 dialysate flow, because if we just only you will use you consume your dialysate solution, but will not add anything for the clearance of the patient. Frequency of dialysis, I hope will not be only 10 minutes to finish. Frequency of hemodialysis. Actually, it's common that our patient asking us, you need to, can I go to only 2 or 3 or 4 dialysis? You know that the recommended 3 dialysis per week. For some patient, new patient, passing good amount of creatinine is not very high, you can use it. However, if you just see the literature that guideline recommended that patient with little or no residual kidney function less than 2, and it will go up to 3, undergoing 3 times a weekly dialysis and minimum 3 hours. But as you mentioned many times, that now we're dialyzing our patient 4 hours. Later, several observation studies of patients with adequate clearance have reported lower mortality rate in patients who had dialysis session more than 4 hours or more. So there is a lot of literature nowadays pointing that we need to dialyze our patient at least 3 times per week and every session 4 hours. So this is very important now, and a lot of literature supporting 4 hours. Some people that use 3.5 hours, depend on the size of the patient, the membrane when using dialyzers, and the K2 offer. This is another actually important point. This is, shall we dialyze the patient 3 times, or for example 6 times or 5 times? This is actually FHN trials, this frequent hemodialysis network trials, was published for approximately 12 years. And this is actually that dialyzing the patient, for example, 3 times versus 5 times, and time spending in dialysis will be, of course, longer in the patient getting 3 or 5 times in dialysis. Any difference in the outcome in dialysis? It's not easy to do it actually. Our patients hardly getting 3 times per week per dialysis. But some centers, especially during the research issue, they will actually dialyze the patient 5 to 6 times, and to see if there is any versus 3 times. Of course, there is improvement in left ventricle size, anything going to this direction in the favor of frequent dialysis. Left ventricle mass from cardiomyopathy improved, physical health composite improved, better in a patient getting frequent dialysis, and again, pre-dialysis systolic blood pressures is actually better. Pre-dialysis phosphorus, so it's actually is a good for cleaning the phosphate, for controlling blood pressure, for the physical activity, physical health, and for the hypertrophy. So actually, yes, 5, I think logically 5 times per week is better than 3 times or 6 times per week, better than actually 3 times per week. Actually, that cannot be done in our centers. They're very busy, crowded units, and a lot of patients. And sometimes we didn't have any space. Long-term effect, this is actually after 5 years. And you can see that this is the same, but after 5 years. And that this is the conventional dialysis versus frequent dialysis. And this is the survival probability. And approximately at 3 and 6 years, frequent hemodialysis reduced mortality 16 versus 28%. I think it's yes, it will be more clearance, more decreased mortality. I'm sure. Yes, the evidence is not very strong, but it's not easy to be done. It's not easy to be applicable in the every units. The frequency, everything without actually penalties. So the increased frequency of dialysis, improve blood pressure control, already mentioned, less phosphorus binder, improve co-primary outcome, including heart failure mortality. However, there is actually disadvantage, increased access complications. You're just calculating the fistula daily. I'm sure that over time with the pure fistula will be damaged. High ultrafiltration rate, higher ultrafiltration rates, and this is actually, we'll see the effect of doing ultrafiltration higher than the recommended. Higher medical care cost is very important. Higher medical care, because it's actually very costly for nurses, for supply, physician, for the units. It's not easy at all to be done. Yes, it's good, a lot of advantage, but I think it's not easy to be done. Last point I will comment about it, ultrafiltration goals. And this is actually, we'll go to our patient. He is specifically kilo, and his came with 4 kg weight gain. So shall I remove this 4 kg in, for example, 3.5 hours as his dialysis prescription, or shall I modify my dialysis prescription? Because I think if you remove 4 kilo in a 3.5 hours, not good at all. At the same time, some people, they mentioned they will do ultrafiltration with 1 hours in 2.5 hour dialysis. 2.5 hour dialysis will not be sufficient for him. So what we'll do now, the fluid removal rate should ideally be less than 10 ml per kg per hour. His weight is approximately 70. So 10 by it will be 700. If you give him 4 hours, 700, 7 multiplied by 4 will be around 22.8 liters. So what I can use ideally in this patient, if you just pull up this guideline, I would just remove approximately 2.8 liter per cup. So this one will not be sufficient because he will end it by more than 1.2 liters still in his body fluid. So there is a simple equation that dialysis hours, mainly volume overload. For example, this patient came with 4 liters. So 4,000 ml divided by 10 multiplied by pre-dialysis weight. So 10 multiplied by pre-dialysis weight, 74 kilo. This patient, I need to put him in the machine for approximately 5.5 hours to remove this 4 kg in 4 hours. So this is the way I'm going to. Sometimes your patient came with volume overload. We need to remove it. It's difficult to just run the machine within 3 to 5 hours, 4 hours to remove, for example, large amount. Actually, there is a lot nowadays. There is actually studies ongoing regarding the effect of rapid ultrafiltration in the mortality. And actually, this is was published in 2017 that there was incremental and almost linear association between the ultrafiltration rate and mortality, irrespective of gender. So if you exceed more than 10, which is now. So this is actually the absolute association between ultrafiltration rate and death. If the ultrafiltration less than 10, you can see the green color, and this is a good, and there is no risk for cardiovascular or cause mortality. If you just go to ultrafiltration more than 10 ml per hours, this is actually, it will go to, now you can see the lines start separated, and now we can see that there is a higher risk for cardiovascular mortality. So it's not line separated, sorry, the line will start going up, and this is, you can see the high cardiovascular mortality and all cause morbidity will be increased. So it's very important always to just make sure that we not remove excessive fluid and every dialysis, every visit of your patient to the dialysis units. So try always to calculate, really I need to remove this 4 kg or just about increase the time for the patient so I can able to remove this fluid. So let us go back to our patient. And nowadays, as I mentioned already, we calculate his KT over PKM to be very low. What we'll do now for the patient? So causes of inadequate dialysis, and already after this lecture, that fistula integrity is very important. Access is the most important factor actually playing a role because depends on that the blood flow. So patient has vermicath, the blood flow will not be more than 300, but for the dialyzer use it. Other important thing, good fistula will give you good dialysis for your patient. Short, actually, this is the cause of inadequate. Short dialysis time, like our patient 3 hours to 3.5 hours. So we need to give them 4 hours at least. Have good dialysis. The other thing, the contribution to access recirculation, as already mentioned, not more than 10%. So all this one leads to low. When you see low KT over P, maybe fistula is not working well, maybe the patient not getting enough time in dialysis, maybe there's access to recirculation. Inadequate needle placement and size, already mentioned, sometimes using 17 and try to push blood through high blood cannot be at all. And sometimes using small flux or low flux dialyzer for a patient actually is a large person. And the method of obtaining blood urea. So when you see a patient has inadequate dialysis, try to go and revise. This is a fistula, duration of dialysis, access recirculation, the needle size, the type of dialyzers, and the method of taking the blood sample for urea. And this is a very important actually to correct it. Otherwise, the patient will continue, unfortunately, having poor dialysis adequate. So in summary, sorry, take long times. In summary, KTOFRP is the most commonly method used to assess adequate hemodialysis, worldwide well known, but it's unfortunately is not really the ideal one that if you especially for a patient passing good amount of urine, patient has ultrafiltration high, especially in volume overload. So this is a point that most likely the standard KTOFRP will be the future for the calculating the adequacy. The solid clearance depends on the multiple factors already mentioned clearly that dialyzers are very important to use high flux, high efficiency dialyzers. It's a very important point, meaning the good size and will be high flux dialyzer. And actually dialysis factors mentioned that we need at least 4 times patient factors contributing also to especially the fistula and others. And the high flux dialyzer are better in a patient with low albumin, high vintage or just high duration dialysis for diabetic patients. Blood flow is the most important factor for clearance and KTOFRP. Ultrafiltration coefficient, ultrafiltration more than 10 ml per kg per hour is higher mortality. Thank you so much. Dr. Khalid,
Thank you so much, Dr. Ali, for this nice review about the dialysis prescription. And I think we have limited time, but just a question for what's the best modality for renal replacement therapy in diabetic patient?
Diabetic patient. Actually, maybe this is the slide you can see it there. The last one is that it is recommended to use high flux dialyzers. And the size, of course, will depend on the size of your patient. For example, my patient 70 kilo or 80 kilo, I will use dialyzer like 1.6 to 1.8. For example, the patient is obese, more than 100, I will use big dialyzer, 2 or 2.4, 2.5. So, and the other important thing, I will just make sure he has good fistula and has good blood flow as maximum more than 350 and using also good size of needles like 15 or 14. So then this is applicable for any patient to have have good dialysis.
يعطيك العافية دكتور. طيب في سؤال هنا about الهايبرفوسفاتيميا. What is the best extended session, the extended session or daily short session?
Yes, actually from the trials published already now that more frequent dialysis, whatever the trial already mentioned here or other trials, that more frequent dialysis, more actually clearance of the phosphates. It's very important. And especially the frequent dialysis are very good actually to remove our phosphate. But you know that is not easy actually to be done. The frequent dialysis you need to have enough number of nurses. You need to have good units that good number of chairs. It's not easy actually but actually just see that increased frequency of dialysis, less phosphorus binder because the phosphate will actually mentioned already here that the phosphate will be removal of the phosphate better than with frequent dialysis rather. Even left ventricular mass, left ventricular hypertrophy, pre-dialysis urea, blood pressure, all this one actually with frequent dialysis. Sometimes our patient will put in 4 hours. You know that it's not easy to put 5 hours, 5 times. Some patients are using 4 times in our dialysis. Especially patient has very high phosphate, blood pressure, and his weight gain is high. So you can go up to 4 times per week. Yes, possible. But it's not easy to make it 5 times per week. But frequent dialysis will known to improve a lot of factors.
Thank you, Dr. Ali. Just a quick comment about, do you check the urea immediately after the dialysis session or there's a specific time?
Actually, As mentioned initially in the first slide, it's very important just to mention this point. Dialysis, I'll go to, this one. The single ball keto overview, which the one used widely in all parliaments. You know that Sabahi people understand. Now they ask about keto overview are doing or not. They are pointing for this one, single ball keto overview, because simply take it at the end of dialysis. Immediately we just that's protocol. Stop the machine, take the sample, and after that the blood and stop dialysis. So immediately at the end of dialysis, and this is the one we're using for the single ball keto, and the figure you can see it here, 1.2 up to 1.4. If you just take it more accurately, we need to take the equilibrated one or the double ball keto overview. This is the same names. Simply, the urea is intravascular, extravascular. When you are doing dialysis, the urea intravascular will be removed and the urea will go down. And when you take the sample immediately after the end of dialysis, you'll find the figure a little bit up to 1.2 to 1.4, and it's called single ball keto. But if you wait for the 30 minutes at the end of the dialysis, when there is equilibration of the urea from extravascular to intravascular, will take approximately 30 minutes. Now we'll take the urea's measurement, the most accurate one. But actually, you know, that is not easy to be done. And when you finish dialysis, the patient he will go immediately at home. He will not stay for you half hour to take a blood sample. He's already stay for 4 hours in dialysis, so he will not stay for another half hour. And this is the point that we're using now. Only immediately at the end of dialysis, load up the machine, take the sample, and terminate the dialysis. This is the one called single ball keto, and this is the one we are measured in every dialysis unit. Double ball, it will take time to be measured, and we'll need to keep patient after finishing dialysis 3 hours to take blood samples. 30 minutes to take blood samples. It's not easy at all to be done. I hope it's clear, Dr. Khan.
Yeah, it's clear, I think. Thank you so much, Dr. Ali, for your presentation and answering the questions. And because we have limited time, we have to move to next lecture. Because we received
30 minutes.
Okay.
The time written 1 hour, I think, in this.
No, because now we have to move these lectures faster now.
No. This is the reason to prepare the lecture to approximately less than 45 minutes. This is the point. Otherwise, you can modify your lecture according to the times. That's my point.
Allah يعطيك العافية.
الله يجزيك خير إن شاء الله.
You are on time. الله يعطيك العافية. شكرا لك.
شكرا.
Okay. Just because we are receiving same question repeated.
Yeah.
كيف تقدر عليه تفضل؟
أقفل يعني؟
Yes, you can.
أنا بالنسبة لي خلاص تقريبا no more question. Huh?
No more question, yes.
Because you can give time for our colleague.
شكرا لك.
شكرا جزيلا.
شكرا لك. الله يحفظك دكتور علي. I think we received multiple questions about the CME. Please, if you registered with your name and you attended the Zoom with your name, you will receive the CME. And to receive the CME, you have to be one of the target audience. So please check the poster to see if you are the target audience, then you will receive it by default, inshallah. Now we will move to the next lecture. It's my pleasure to introduce Dr. Yassin Al-Hamad. He's a consultant nephrologist and interventional nephrologist in King Saud Medical City in Riyadh, and the medical director of Al-Iman General Hospital and First Riyadh Health Cluster. Also, Dr. Yassin is the nephrology lead at MOH. And Dr. Yassin, he will talk about acute kidney injury and continuous renal replacement therapy. The mic is yours, Dr. Yassin.
Assalamu alaikum wa sabbahakum Allah bil khair. Thank you very much, Dr. Khalid. It's my pleasure to be here with you. Inshallah, I will not take a long time. I'll try to finish quickly so we can go to the next lecture, inshallah. I will, inshallah, talk about the acute kidney injury, as you mentioned, with CRRT. The outline of the lecture will talk briefly about the acute kidney injury definition stages, indications of RRT, and the modalities that we use in terms of types of modalities and doses, recommended doses or the optimal doses, timing at which we start the CRRT, and I'll spend more time talking about the studies done in that area, the timing on which we prefer to start RRT. To start with, the definition of acute kidney injury, there we have many criteria and bodies to define it, but the most recent and important is the KDIGO definition of AKI. So AKI is defined as an increase in serum creatinine by 26 micromole per liter within 48 hours, or increase in serum creatinine 1.5 times from the baseline, which is known or presumed. And to be honest, it's difficult to, most of the time, it's difficult to know the baseline for patient crash landing in ER or in ICU. The urine, the other criterion is the urine volume decrease less than 0.5 ml per kg per hour for 6 hours. This defines an acute kidney injury. Of course, there is different staging schemes for acute kidney injury, but we'll use in these slides, we'll use the KDIGO. It's divided into 3 stages based on serum creatinine criteria and urine output criteria. The stage 1 is increase in serum creatinine more than 26 micromole per liter within 48 hours, or 1.5 to 2 folds from baseline. The urine output criteria, decrease of urine output less than 0.5 ml per kg per hour for 6 hours. In stage 2, serum creatinine increase 2 to 3 folds from baseline and drop in urine output 0.5 ml per kg per hour for 12 hours. The stage 3 is increased by 3 folds, or increase serum creatinine to more than 350, or initiation of renal replacement therapy regardless of stage. And urine output in stage 3 decreased to less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. So what are the indications to start renal replacement therapy? We all, I assume that our audience mostly working in nephrology and in dialysis units, so we all know the classic indications of starting renal replacement therapy, which are fluid overload, severe hyperkalemia resistant to medical management, overt manifestations of uremia like uremic pericarditis, uremic encephalopathy, or unexplained decline in mental status in ICU, in a setting of AKI for sure, and severe metabolic acidosis with pH less than 7.1 despite medical management. The treatment modalities, we have different modalities, and we use them depending on the availability of each modality and the experience of the staff with each modality and the clinical situation. Hemofiltration, CVVHF, hemodialysis, hemodiafiltration, where we combine the diffusive and convective properties of dialysis, or prolonged intermittent renal replacement therapy, where we utilize intermittent dialysis for 6 to 18 hours intermittently. Now, which is better? Which is superior? Intermittent hemodialysis or CRRT? When we talk about CRRT, of course, we include all these modalities: hemofiltration, hemodialysis, hemodiafiltration, which are types of CRRT. But what should we use, hemodialysis or CRRT? Few studies were done, and this is one study done or published in 2001 that is a randomized trial of continuous versus intermittent dialysis for acute renal failure done in US. It included 166 patients with acute kidney injury, randomized to either an intermittent hemodialysis group or CRRT group. The CRRT group, upon randomization, had a higher Apache score, which is score done in ICU to classify patients with higher or more sick patients. And liver failure was higher in that group. However, after adjustment of these, it was a randomization issue. After adjustment for these characteristics, the two groups were compared, and there was no increased risk of death or mortality in CRRT group with adjusted odds ratio of death of 1.58 with confidence interval 0.7 to 3.3, which is not significant. Another study published in 2006 comparing both CRRT and intermittent hemodialysis, HemodiAF. It's a French study, a prospective multi-center, included 360 patients with AKI and multi-organ dysfunction. They were randomized either to receive intermittent hemodialysis or CVV-HDF. The primary endpoint was survival at 60 days. And as you can see, there is no difference. Survival in both groups was around 32, 33. So another study examining trying to answer the same question, convent study. It is a single center study, enrolled 252 patients, randomly assigned to CVVH at a prescribed dose of 35 ml per kg per hour, or a daily intermittent hemodialysis. And it showed no difference in hospital mortality or mortality at 30 days, no difference in recovery of kidney function. The survival 14 days after discontinuation of RRT was 39% in intermittent hemodialysis group and 43%, which was not statistically significant. So to summarize or to answer this question, which modality should we use, intermittent or CRRT? We say that we don't have data to support superiority of any modality, and the decision is based on availability of the specific modality in question and the local experience, and most importantly, the clinical status of the patient. Of course, more sick patients whom we anticipate episodes of hypotension or sometimes most of our ICU units, we don't have the water system connected there. So most of them, we will utilize the CRRT. So it goes again to the availability and the clinical status of the patient and the discretion of the nephrologist or ICU physician decision. It's important to mention, I didn't want to forget to mention that, so I put a slide that peritoneal dialysis is still an option for AKI, for treatment of AKI. And we can consider peritoneal dialysis in this situation as acute PD where we have lack of access to extracorporeal modality or high risk of bleeding with anticoagulation, difficult hemodialysis access. Mainly we see these patients who were on dialysis before, or multiple access failure for any reason, like previous central lines, for chemotherapy, for whatever. Patients with heart failure, refractory to medical management, and patients with liver cirrhosis. Of course, in ICU setting, we don't prefer to start PD for patients, surgical patients where they have a recent abdominal surgery in the last 30 days, or where there is an active abdominal, intra-abdominal pathology or infection. In cases of sepsis as well, we don't prefer to start PD because it will be a source of infection. Now we come to dialysis dose. What is the best or the optimal dialysis dose that we can prescribe? One of the most important studies is the ATN study, Veteran Affairs National Institute of Health Acute Renal Failure Trial Network. They were able to recruit 1,124 patients, and they were comparing intensive regimen versus less intensive regimen. The intensive, they used, in the intensive arm, they used either SLID or intermittent hemodialysis 6 times per week with a target KT/V of 1.2 to 1.4 with a median of 1.3 per treatment, or CRRT dose of 35 ml per kg per hour. The decision whether to go for intermittent or SLID against CRRT was the patient's condition. If hemodynamically stable, they will go for intermittent hemodialysis. If unstable, they will go for CRRT or SLID. Back to the groups, the other group is less intensive. They go for SLID or intermittent hemodialysis 3 times per week only, compared to 6 in the more intensive. And the dialysis dose of CRRT is 20 ml per kg per hour in the less intensive. We noticed that the KT/V is the same target for both groups because it's per treatment or per session. The primary endpoint was death from any cause by day 60. And the result was there is no difference in mortality associated with more intensive dosing strategy. Of course, the higher dosing strategy or more dose carries a more cost. As we all know, the cost comes from fluid and from the filters, of course, the manpower, etc. Dialysis dose and intermittent hemodialysis, they recommended by KDIGO guidelines is to deliver a total weekly dose of 3.9. This comes from the study that we just mentioned, where they took the median. If you look here in the less intensive group, because there was no difference, and they took the median KT/V per treatment multiplied by 3, it gives us 3.9 per week for the patients undergoing intermittent therapy. When it comes to the CRRT dose, randomized evaluation of normal versus augmented level of replacement therapy, renal study, they recruited 1,500 patients who were randomly assigned to CVV-HDF at an effluent flow of or a dialysis dose of either 25 or 40 ml per kg per hour, with primary endpoint mortality at 90 days. The result, as you can see, mortality was the same in both groups, 44% with odd ratio of 1 and confidence interval of 0.31 to 1.23, which is not significant. So a meta-analysis of RCTs in intensive approach was associated with delayed recovery of kidney function, higher rate of electrolyte disturbance, especially hypophosphatemia, associated with higher dialysis dose and prolonged mechanical ventilator support. Now we come to the more important question of the timing of initiation of RRT, which was debatable for a long time between nephrologists and ICU physicians. ICU physicians used to think that, which is logical. They think that starting early will help control the toxins and electrolytes, clear them from the bloodstream, allow the other organs to function properly, like allow good contractility of the heart, less pulmonary edema, less or one fewer reason to have decreased level of consciousness. This might allow earlier extubation and discharge from ICU, and might carry a positive mortality benefit. The other viewpoint was that there might not be a real difference between starting early or late, and if we wait, some or a number of patients might recover kidney function, and they might do it without the need for going for a renal replacement therapy. This will save in terms of financial cost, plus avoid possible or potential complications that might come with starting renal replacement therapy. So in general, the factors that we consider before RRT initiation is the severity of AKI with the trajectory of urea and creatinine, the amount of urine output, and whether it's coming up or going down or stable, electrolyte derangement, acid base, and complications of uremia. Also, we think about the potential risks, as we just mentioned, the risk of line insertion, the mechanical risk, which might happen. I think Dr. Fadel will talk about it later today, or the infections that are related to presence of foreign bodies in the bloodstream. Hypotension during RRT, and clearance of nutrients and drugs, which needs modification of drugs or might need extra doses for those patients. So in 2012, what did KDIGO guidelines recommend in that regard? They recommended that initiation of renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist. It's more or less the same things that we talked about earlier. They also recommended to consider the broader clinical context, the presence of conditions that be modified with RRT, trend to laboratory values, rather than a single BUN creatinine threshold, which are the things that we mentioned about the trajectory of BUN and creatinine, rather than having a single reading. So what is the theory behind early initiation? I will not repeat it. The theory is simply that early initiation might have better overall clinical outcome in terms of survival and other measures. The theoretical drawback, as we mentioned, the infections, mechanical complications of catheter, risk of hypotension, etc. There was a study in 2011, a meta-analysis actually, that analyzed several studies examining whether we should start early or late, and the result of that meta-analysis came in favor of starting early, with odds ratio of 28-day mortality 0.45. That means decreasing mortality with significant confidence interval. So in 2011, we thought that we can, or it might be beneficial to start earlier. But we have several studies that came out later of prospective controlled trials. We'll start them by one based on the date of release. The first one is Akiki trial, which is a very famous trial. The principal hypothesis of that study was that delaying renal replacement initiation reduces absolute 60-day mortality. They recruited 620 patients. Patients were admitted to ICU with AKI compatible with ATN, on mechanical ventilation or vasopressor, at least one of the following, and they mentioned the criteria of KDIGO stage 3 AKI. So, patients admitted in ICU with AKI on ventilator or vasopressor with KDIGO stage 3 AKI. They were randomized to either early start renal replacement therapy or delayed renal replacement therapy. The early start group, they initiated dialysis less than 6 hours after criteria were met, while the delayed group, they initiated if one of the following criteria occurred: either oliguria or anuria for more than 72 hours, blood urea nitrogen of 112. Of course, this is important because we are going to see it in the second version of Akiki 2 at the end of the slide. In this study, they determined the blood urea nitrogen of 112 milligram per deciliter, serum potassium of 6, serum potassium concentration of 5.5 with medical treatment, pH 7.1 and less, and acute pulmonary edema. Those were criteria for the delayed group. The results, the early strategy group, 98% of those patients assigned to this group received renal replacement therapy at a median of 2 hours post-randomization. The delayed strategy, only 51 commenced RRT with a median time of 57 hours post-randomization. So we can see clearly that the delayed group and early group had no difference. The delayed renal replacement therapy did not result in improved 60-day survival. No difference in dialysis dependence at 60 days. However, there was catheter-related infection and hypophosphatemia higher in the early intervention group. Another study was done in Germany, ELAINE trial, early versus late initiation of RRT in critically ill patients. The principal hypothesis was that early RRT reduces 90-day all-cause mortality. They recruited 250 patients with inclusion criteria KDIGO stage 2, plasma NGAL more than 150 nanogram per ml, and one of the following: severe sepsis, vasopressor, or refractory fluid overload. The early group started RRT within 8 hours of stage 2 AKI. The delayed group started within 12 hours of stage 3 AKI or absolute indication. The early group, they all patients started RRT with a median time 6 hours post or from the time of eligibility, and the delayed group, only 92% of those patients started RRT at a median time of 25 hours from time of eligibility. We noticed that the high number of or the higher percentage compared to the previous study, and the shorter median time to start in the delayed group. So the result of this study is that among critically ill patients with AKI, early initiation compared to delayed initiation reduced mortality. So it came positive in favor of early initiation of renal replacement therapy. The third study that we will show is the ideal ICU study. It's again a French study. The hypothesis was that early RRT reduces 90-day all-cause mortality. They planned initially to enroll more than 800 patients. However, the trial was stopped early for futility, and they were able to enroll only 488 patients who underwent the randomization. The two groups were early initiation versus delayed. Early, they started within 12 hours of meeting AKI criteria. The delayed started 48 to 60 hours following enrollment or emergency indication. Early strategy group. In the early strategy group, 97% of patients started on RRT at a median 8 hours post-randomization. And the delayed strategy, 62% of those patients started at a median of 52 hours post-randomization. So the result, again, there was no significant difference in mortality. As you can see, the p-value is, there's a small difference, but it's not significant. The p-value is 0.5. So there is, it came negative. There is no difference between early or late in terms of mortality. But so now, would you start renal replacement therapy with the information that we have early or late, or are we going to use only the stage of AKI as an indicator whether we should start or not? So let's go to the most recent two trials, the START AKI trial. It was a multinational randomized open label controlled trial that was done in 15 countries and included 168 centers. Their selection criteria, they included all adult patients 18 years or older who were admitted to ICU with kidney dysfunction, serum creatinine level 100 for women and 130 micromole per liter in men. Severe acute kidney injury that was categorized as stage 2 or 3 by KDIGO classification. Just to remind ourselves of the KDIGO classification, the stage 2 to 2.9 times the baseline, or urine output less than 0.5 ml per kg per hour for 12 hours. Stage 3, 3 times the baseline, or more than 4 milligram per deciliter, or initiation of RRT for the urine output less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. The exclusion criteria, they excluded all emergency indications for dialysis, previous renal replacement therapy, advanced chronic kidney disease, uncommon causes of acute kidney injury, and one important point is that they allowed clinician or physicians were asked to affirm clinical equipoise by noting absence of any circumstances that would mandate either immediate initiation or delayed or deferral of initiation. That means that there was significant role of clinical judgment whether to initiate earlier or delay it. So patients were randomly assigned in a 1-to-1 ratio. Discontinuation of renal replacement therapy occurred only if recovery of kidney function was there, or withdrawal of life-sustaining support, or death. The two groups were either accelerated RRT within 12 hours once the criteria are met, or the delayed RRT only started the delayed group when certain criteria like pH less than 7.2, serum bicarb less than 12, evidence of severe respiratory failure, clinical perception of volume overload, or persistent acute kidney injury for more than 72 hours. The recruitment time was between 2015 and 2019, recruited total of 319 patients, 1,512 patients in the accelerated group. Among those patients, RRT was started in 96% of those patients at a median time of 6 hours after criteria are met. Standard strategy, they included 1,500 patients with 61% initiated RRT at a median time of 31 hours when criteria are met. The outcomes, the primary outcome was death from any cause at 90 days after randomization, and there were many secondary outcomes. One of the most important is death in ICU at 28 days or during hospitalization, dependence of renal replacement therapy, and others. We'll just take a quick look at the baseline characteristics. We noticed that all the characteristics were similar in terms of number, age, sex, weight, serum creatinine at randomization. Pre-existing conditions were more or less very similar between the two groups. Also, the type of admission, either medical or surgical, hospital-acquired conditions that might precipitate AKI or risk factors for AKI, all were similar. Clinical condition, whether sepsis and certain scores were also similar. So the result of this study, at 90 days, death occurred in 43% of patients in accelerated group and 43% of patients in the standard group, with relative risk of 1.00. That means basically there is no difference between the two groups. Here we see the primary outcome, there is no difference. The secondary outcome, the RRT dependence among survivors at 90 days was more in the accelerated group, 10% compared to 6%, with relative risk of 1.74, which is positive as well. RRT was less in the accelerated group, or the median number of days of use of RRT was less in the accelerated group. Now we come to the adverse effects. It was more noted in the accelerated strategy group. Of 23% of patients had adverse events compared to 16% of patients. Mostly, or the most significant, statistically significant difference was in hypotension and hypophosphatemia less than 0.5 millimole per liter. It was more in the accelerated strategy group. So their conclusion is that in critically ill patients with severe acute kidney injury who received accelerated strategy for initiation of RRT, this did not have a lower risk of death at 90 days than those who received the standard or delayed strategy. This is by far the biggest study with the largest sample size so far, 3,000 patients. The recruitment was wide and in different countries in more than 168 centers, which might allow generalizability of the result on different populations. Deliberate enrollment of patients in whom decision for initiation was uncertain by excluding those whom treating clinicians felt lack of equipoise. This could be a strength and at the same time a limitation of that study by allowing clinicians to use their judgment in confirming full eligibility. This might create heterogeneity. However, there was no evidence of heterogeneity in patients in this study observed in that study. The most recent study is the AKIKI-2. It was published in 2021. It is a multi-center open-label randomized controlled trial of 39 ICUs in France, included critically ill patients with AKI KDIGO stage 3. They enrolled 278 patients and randomly assigned 1-to-1 ratio to either a delayed strategy or more delayed strategy. That we can consider it early versus late. The more delayed strategy the RRT initiated was postponed until mandatory indication like hyperkalemia, or until blood urea nitrogen concentration reached 140 milligram per deciliter. Primary outcome was the number of days alive and free of RRT between randomization and 28 days. So RRT was ultimately initiated in 79% of the third group, and there was no difference in numbers of day alive free of RRT between randomization and day 28. If we can see, mortality was higher in the group who had RRT deferred, or the delayed group. In 28 days, 45 patients, the mortality was 45 patients in the deferred versus 38% in the early, while in 60 days, 55 versus 44 between deferred and early, and both were statistically insignificant. So in conclusion, of the timing of starting RRT, the accelerated initiation of RRT is not associated with clinical benefit in terms of mortality or early discharge from ICU. It might increase the cost of healthcare services if we start earlier, might be associated with an increased risk, as we saw before in the previous studies that we discussed, that the adverse events are higher in the early group. Clinical judgment still plays a major role in decision making in starting renal replacement therapy in ICU. By this slide, I conclude the talk. If there is any question or comments from the audience, I'll be happy to receive it.
Thank you so much, Dr. Yassin, for this enlightening talk and great review about the AKI and the CRRT. I'm just checking to see if there's a question. Maybe there's a question from last presentation about the impact of hemodialysis on residual kidney function. Maybe this is live within the like the AKI and CRRT. Dr. Yassin, any comment about the impact of dialysis on residual kidney function?
Yeah, sure. Of course, in ICU setting or in conventional dialysis in our dialysis centers, we know that starting dialysis might predispose the patient to episodes of hypotension, and we try not to do it unless it's absolutely necessary or there is an absolute indication, because it might affect the residual kidney function, especially hemodialysis. And as we know from our previous like it's a common knowledge in between nephrologists that BD is superior to hemodialysis in preserving kidney function, and it mainly comes from those the advantages of BD, that it has less or makes the patients less prone to episodes of hypotension, less prone to the or exposure to the dialysis filter itself with all the adverse events that it might have, the reaction to the dialysis filter itself. So in short, hemodialysis might negatively affect the residual kidney function.
Thank you, Dr. Yassin. There's a question about when to stop CRRT.
Of course, again, it's a clinical judgment to stop CRRT. Once we have no indication for CRRT. Sometimes we need to stop it to see if there is, if especially stopping ultrafiltration to give chance for the kidneys to respond and for recovery. So it's mainly a clinical decision. When there is no indication, we should stop. And this is the benefit of intermittent or prolonged intermittent approaches.
This is good. I think we don't have further question. Just there's a comment from Dr. Omar. He's a home dialysis nephrologist. He commented about the previous question about the hypocalcemia in PD patient. And I think with that, we will conclude this lecture. Thank you so much, Dr. Yassin, for your participation and presentation. Now, if you allow me,
شكرا لك دكتور خالد. Thank you very much.
Yes, شكرا. We can go to next presentation. Satellite symposium will be presented by Dr. Ahmed Abdel Hafid. He's the brand specialty manager at Spimaco, and he will talk about the Crutel as a new Spimaco milestone for patients in Saudi Arabia. Maybe Dr. Yassin, if you can stop sharing so the other speaker can. Thank you. Dr. Ahmed. The mic is yours. تفضل. Yes, Dr. Ahmed, السلايدات واضحة بس احنا ما نسمعك. If you can now present, you can now make it full screen. Yes, it's clear now.
Okay. Thank you so much, Dr. Khalid, for allowing me to present our presentation today. On behalf of Spimaco Dawaiya and my colleagues attending this webinar, we would like to send our gratitude for allowing us to be with you. My name is Ahmed Abdel Hafiz. I'm Brand and Specialty Manager, Immunology, Nephrology Portfolio in Spimaco Dawaiya. Today, you will talk in 10 minutes about our new milestone, Spimaco milestone for solid organ transplantation patients in KSA, our Crutel tacrolimus. Spimaco Dawaiya introduces the expert guard for a lifelong connection that sustains improved quality of life. Crutel tacrolimus caps offer the perfect fit between transplanted organ and the patient's body, being a cornerstone of most immunosuppressive regimens in solid organ transplantation. So we are providing SOT patients in case A with a lifelong connection between the organ and the recipient's body, being the expert guard for this process. Therapeutic indications of Crotal: number 1, prophylaxis of transplant rejection in liver, kidney, and heart allograft recipients. Number 2, treatment of allograft rejection resistant to treatment with other immunosuppressive medicinal products. If we are talking about the pharmacokinetics of this medication, it's very crucial to know this. In terms of absorption, in healthy body, it reaches 43 hours, and for kidney transplant recipients, reaches around 15.6 hours. The Cmax, the peak concentration of Crotal tacrolimus caps in the blood, achieved within 1 to 3 hours. And please, you can ask your patient, as you know, to take and administer Crotal tacrolimus caps 1 hour before the meal or 2 hours to 3 hours after the meal. When in the fasting condition, tacrolimus reaches its peak in terms of the rate and extent. So rapid absorption in a fasting condition will be higher. So in terms of food and drug interaction, tacrolimus caps should be taken 1 hour before the meal or 2 hours to 3 hours after the meal. In terms of distribution, it's highly bound to erythrocytes and the plasma proteins, around more than 98%. Elimination, it's a low clearance substance. And in terms of metabolism, it's extensively metabolized in the liver by cytochrome P450-3A4, and as well in the intestinal wall. Crotal tacrolimus caps is proven in all guidelines of kidney transplant, like KDIGO guidelines, as a cornerstone in initial immunosuppression induction therapy and initial maintenance and long-term maintenance therapy, as well as the European Association of Urology as the highly recommended calcineurin inhibitor to be prescribed with other immunosuppressive agents. The power of Crotal tacrolimus caps provides high graft survival levels. Throughout a 5-year follow-up study, Crotal tacrolimus caps had a significantly higher proportion of non-rejecting patients. And at last, the Crotal tacrolimus caps-based therapy is associated with more favorable cardiovascular profile than therapy with cyclosporin, mitomycin. Crotal concentration, we are available in the Saudi market in 3 forms, three concentrations: the 0.5 milligram, and the 1 milligram, and the 5 milligram, and all in a pack of 100 capsules. And here you can see the 3 packs shapes. At last, the beauty of the thing, just we want to announce that Crotal tacrolimus, as a very important milestone in SPIMACO, by year of 2024, will be fully manufactured in KSA to provide a fully Saudi-made product of high global quality standards. And this will allow expansion of the medication access to all transplant centers and SOT patients in the kingdom. Thank you so much for your listening, and really we appreciate our attendance with you. Thank you so much.
Thank you, Dr. Ahmed, for your nice and brief, enlightening presentation. And we have 1 minute for question, if we have any question about Crotal. There's a question about the price, Dr. Ahmed.
Okay. So I can show this in my slides. So regarding the price, so half milligram is almost 500 Saudi riyal. 1 milligram is 1,000, almost 700 riyal, and 5 milligram is 2,400 riyal. So I can illustrate this in a presentation if we can just take the prices in brief. This is a public price. I mean, in terms of public price.
Okay, that's clear. Just there's a question about the timing for the tacrolimus, but when to check the tacrolimus level.
Actually, the tacrolimus level reaches its steady concentration within 3 days. So preferably, if we can check after 3 days of administration, would be the best timing.
Yeah, and we check the now the trough or the peak, like
Yes.
Yeah, go ahead, please, Dr. Ahmed.
Yeah, it reaches after 3 days will be the ideal from administration. So within 2 to 3 weeks will be the best timing as well.
Okay. Last question: is it available in NIPCO?
Yeah, it's available in NOPCO as a first hour addition, Dr. Khalid.
Okay. Okay, excellent. I think we have no further questions. So thank you so much, Dr. Ahmed, for your nice presentation.
Thank you so much.
Appreciate it. Now we will move to our next presentation. Another satellite symposium will be presented by Fresenius company. It's about the 6008 care system, more care and less complexity. From Fresenius Medical Care Company will be presented by Mr. Tariq Sofi. Mr. Tariq, are you available?
Yes, doctor.
Yes, please. You can have the mic.
Assalamu alaikum wa rahmatullahi wa barakatuh. Assalatu wa salam ala Sayyidil Anbiya wal Mursaleen. Good morning, good afternoon, dear panelists and participants. Welcome to the dialysis symposium, which is organized by the Saudi Society of Internal Medicine. On behalf of Fresenius Saudi Arabia, I would like to express my sincere thanks to the organizing committee who has given us an opportunity to use this platform to introduce the new technology 6008 care system, which is tailored fit for the end users in dialysis unit. Now, here is the first slide. Let me begin with this slide, which proves that Fresenius is conducting the business with integrity and honesty.
So Mr. Tariq, I think you are not sharing your slide yet. Can you share your screen?
Is it not showing up, doctor?
No, not yet.
Okay, sorry for this one. Okay, now doctor can see it.
Yes, it's sharing. Can you make it full screen, please?
Yeah, sure. Is it fine, doctor, now?
Yes, it's okay.
Yeah. So let me begin with the slide where Fresenius Medical Care conducts business with integrity and honesty with all law, company policy, and our values. So I would like to present here 6008 care system, where our slogan is more care and less complexity. We are telling our users, leave the complexity towards us and you give more care to the patients. So time is short. Actually, there are many benefits and features in this device, but as time is allotted, so we will go only which are new features in this technology. 6008 care system is leveraging leading edge technology to deliver advanced dialysis therapy more easily, leaving more time for direct patient care, which is our motto. More patients can benefit from improved outcomes and a higher level of care quality. Now we say less complexity in the therapy. Why? We have, first of all, is all-in-one disposable, completely pre-connected blood lines for all treatment modalities. So you don't have a different lines for different modalities. And also easy switch of the treatment modalities, easy delivery of high volume HDF, ear-free. There is no dead space in the extracorporeal circuit in this cassette. And its lowest extracorporeal volume, which is 118 mLs. We also say from the patient's point of view and user safety, it has reduced the risk infection and cross-contamination. Why? Because there are only fewer process steps to touch points critical to hygiene. Automatic connections, which is integrated in infusion port. I will show you videos and this everything in this presentation. Blood reinfusion is a closed circuit, so you don't need to disconnect the patient from if you are dealing with the CVCs or you are dealing with fistula. You can leave it, so you don't touch it until you return the blood. And there's an integrated pressure measurements as well. So no air is going to the blood component. So we have also improved level of care quality. As I said, it's a reduced pressure on staff, improved experience for the patients as well. From the point of direct costing, which have optimized economic efficiency and eco-friendly, we have, as I said, is all-in-one care set. It's a connected, compact design, lightweight material, and automatic emptying of the disposal, which was not previously in any freezing technology. We are emptying complete the dialyzer internally and externally, as well as the care set. So this is at a glance. So we talk about the 6008 care system, which offers advanced therapies options for cardioprotective hemodialysis while addressing today's challenge. What are our challenge? Efficiency, eco-friendly, and optimized workflows. So we will go first advanced therapies, but I have selected only specific one which are new to this device. First of all, let's go to the less complexity in the therapy delivery. And this is our care system, which is innovative technology, allows for an ear-free design of extracorporeal system. Less blood-ear contact may reduce the risk of clotting during therapy. Compact and flow optimized design leads to laminar blood flow without dead space. It was, you can see, red dotted design award in 2018. So this is what the care sets looks like. It's a lowest extracorporeal volume, which is 118 mLs, and also for single needle, it's 131 mLs. Which you can see over here is a red dotted design award winner 2018. So how we say less complexity in the therapy? Easy to switch between the treatments, maximum flexibility in a therapy delivery, HD, high volume HDF, and single needle from the same care system. You don't have a different lines to use for different modalities. In fact, the single needle you can do from the same one. So only one disposal for double needle and single needle, as I mentioned. Single needle in HD and HDF boards also pre and post dilution available, and its reduced extracorporeal for single needle is 131 mLs. So here I show it here in a flush player that this is single stroke volume here, which is maximum 60 mLs. You can see the same blood line used for a double needle as well as single needle. So this is a single needle stroke volume, which you can see is going down and up. Also, easy delivery of high volume HDF. More patients can benefit from improved outcomes due to the simplicity of high volume HDF in our, which was also in our 5008, and now it's continuing with the 6008 as well, without the manual interaction of the user. The machine delivers automatically maximization of substitution solution without the interaction of a user with the auto sub plus option. So we know this is the information for the HDF high volume, which we were also driving. We launched a drive in 2017. Improves patient outcomes in general. High volume HDF reduces the mortality risk by 30%. We have studies about it to achieve the best outcomes, which says that higher the substitution volume. We say in our technology, we say in our studies, the volume matters. So we need to achieve minimum 21 liters of substitution volume without the ultrafiltration. So in our technology, this HDF high volume is simple as HD. With our care 6008 care system, it's easily integrated in daily routine. It's the most advanced yet still cost effective. Previously, to initiate this treatment, we need extra disposable, which costs extra money. We need substitution solution. With our technology nowadays, you don't need to pay even a penny to continue with this better treatment, which is high volume HDF. So what is simplicity high volume HDF in our 6008? Is automatic connection to be integrated infusion port. So less chance of infection. So it's not exposed to the user. Auto start of the online priming after the self-test without any manual interaction. So you put a machine on test and leave it to the machine. Machine will be prepared automatically for the user. Easy to switch from the HD to HDF, pre and post dilution at the touch of the button. We have an infusion port, which is inside the cassette, which you will see in next video. So this was the infusion port, which once you put the cassette, the user will put the cassette, it will be automatically penetrated in the port of the cassette. So it's not visible to the user. Also Auto Sub Plus at a glance, which was also, as I mentioned previously, in 5008 technology. Auto Sub Plus enables the automatic maximization of the substitution rate. Substitution volume individualized for each patient. It depends upon the condition within the dialyzer, continuously monitored in our devices, which is only in Fresenius available. It gives you, once you achieve the maximum volume, so it gives you optimum performance without interruption and alarms. How Auto Sub Plus works in our device, we can show it in the next slide here. And you, as you can see that, here, by the continuous rolling of this blood pump, it will generate the continuous dynamic signals, pressure pulses, which you can see. It will go to the inside the fibers, and it will be monitored also in the venous transducer. If there is a changing condition along the blood pathway or due to hemoconcentration or clotting, that automatically it will regulate the, or it will increase or decrease the substitution rate in the device automatically, by knowing the pathway of the dialyzer. So this is innovative technology in our device as well. So if it's free flow, it will maximize the flow of the substitution automatically to reach the good volume, to have the better clearance. So auto regulation with immediate increase of the substitution. So Auto Sub Plus functional principle is assessment of the blood flow conditions within dialyzer, not just across the membranes only, but also along with the blood pathway, as I mentioned. Continuous control of the optimal substitution rate based on the dynamic signals, analysis of pressure pulses. Because of that, automatically activation at the start of it. So it doesn't need interaction. It will be started automatically by the device once the patient is connected. Also, I saw that Dr. Sumaya talked about the water quality. And here we have a diasafe for that one. We have a double filtration, which is meeting the ISO standards, ISO 23500. So we have a double stage filtration system for the production of the substitution fluid. So you don't need the extra cost of the substitution fluid. It's the online production of the substitution fluid. Integrated test of diasafe fluid filter during each T1 test. Unlimited amount of sterile non-pyrogen substitution fluid makes saline solution obsolete. So you don't pay extra for the saline solution, no extra cost. So here you will see in next slide that from raw water, we are providing you the ultra pure non-pyrogenic solutions, which has a ISO standards, ISO 23500, which meets the ISO standards. As you can see, we are using only 2 filters. We are saying you give us an ISO standard 23503, we will give you the substitution fluid prepared in our system. So 2 diasafes is enough, which are the 2 endotoxin filters, which you can see over here. So we are giving you from raw water to your substitution fluid prepared by our devices. So next, I will just quit the dialysis dose, which is OCM, which was already talked by Dr. Hakami, KT-RV, which is based in our all dialysis machines, which is a base. So I will focus more on here, which is only in our Fresenius technology, which is called individualized sodium management, which is available from the software of 2.46 onwards. So this is the main additional thing in this technology, in this tailored fit. So we know individual sodium management is a challenge. Sodium is a challenge for every nephrologist and every doctor. Sodium is a hot topic in the market. The optimal dialyzed sodium concentration differs among HD patients, while diffuse sodium load may be associated with thirst and higher intradialytic weight gain. Excessive diffuse sodium removal may cause intradialytic symptoms. Therefore, one important goal in dialysis therapy is to keep the intradialytic dietary salt intake and intradialytic sodium removal balanced. So here we can see in the graphics, most usually patient predialysis plasma sodium is widely separated, which you can see 137, 138, mostly 138, 139 is used. So this is mean predialysis plasma. It's in millimoles, which we are seeing in most of the dialysis use is being used. So this is references. So graphic patients predialysis plasma sodium is widely spread, which I show in the graph. The graph shows predialysis serum sodium average over 6 months in the study 369 unselected patients. Dialysis sodium 137 millimoles. Laboratory normal range for serum sodium is 135 to 145, which we all know. So far, sodium concentration of predialysis plasma is usually rarely determined individually. If the dialyzed sodium should not be followed as standard prescription, but should be aligned with the predialysis plasma sodium. Plasma sodium must be determined at the laboratory prior to each dialysis. But now we have sodium management, so we don't need a laboratory prior to each dialysis. This individual dialysis sodium prescription is key factor to setting the sodium concentration gradient. So benefits of easy and individual sodium management with 6008 Kirsan is controlling diffuse sodium transfer, which enables individual sodium prescription, visualization of the patient's sodium removal, which provides valuable information about the intradialytic salt intake. For the dietitian as well, they are also in concern. Monitoring of predialytic plasma sodium trend data for potential indication of pathological changes. So this is which you can see the difference between the standard fixed dialysate and automatic sodium control, which you can see the zero diffusive mode, which has a sharp turn. So guidelines strongly recommended an individualized dialysate sodium. Sodium load during HD clearly results in greater thirst with resultant volume expansion, increased cardiac workload, and subsequent hypertension. Individualizing sodium dialysate to the plasma sodium concentration may improve hemodynamic stability during the dialysis. So this is the guidelines from Kedoki, which says there is evidence to suggest that high dietary sodium intake and inadequate sodium removal during HD can result in excessive fluid intake and hypertension. Despite generic dialysis sodium prescription being widely utilized, there is increased debate that a standard 130 or 140 milliequivalents per liter dialysis sodium prescription might not be appropriate for all patients. So it's not for all patients. As mentioned above, sodium loading during HD clearly results in greater thirst with resultant volume expansion, increased cardiac workload, and subsequent hypertension. In summary, high sodium diet, volume expansion, and exposure to the sodium dialysate all result in high BP in HD patients. Also, European best practice guidelines on hemodynamic stability, nephrodial transfer, this was also saying, they also said in this trial, individualizing sodium, dialysis sodium to the patient's sodium concentration of the dialysate may improve hemodynamic stability during dialysis. However, this approach would appear difficult to perform in daily practices. But with our sodium management, individual sodium management option in our device, it has made life easy. So how it looks like, sodium management, sodium control drives intradialytic dialysate sodium of the patient. Sodium management automatically determines the predialytic plasma sodium concentration in our device. Sodium control automatically adapts the dialyzed sodium to the plasma sodium of the patient. It helps to avoid actual cost and workload, can make extra timing consuming blood samples are obsolete. It's very easy to implement in our clinical practice. As I said, this is something new in our device. So once you will have our device, this is here, you can see over here, it's a dedicated button, sodium management. Once they press the users, and they will find this screen where we have sodium management button, dedicated button for this one. And here we have in a red, this is prescribed sodium. So to enter the value of the prescribed sodium, when a sodium control is active, the value for prescribed sodium is shown in a gray. So once you give control to the device, so this will be gray, you cannot change it. So next is, it has also show you the distribution volume of the patient which is PV urea, to enter a value of your urea distribution volume, which is also in our devices coming from the OCM. So the machine will take it from there. This next button is plasma sodium change goal. The plasma sodium change goal can be changed by the operator. So whatever is the plasma sodium at the moment of the patient, current plasma, you can make your goal if you know the patient's ideal plasma in the ideal sodium in the plasma. So next button, you can see plasma, the machine will show you the plasma sodium goal. Show the sodium transfer between the dialysis and the patient. The value is calculated from the product of the sodium change goal in a millimoles or a per liter and V urea. And next button, you can see sodium control. It can be on and off. If it's on, so the prescribed sodium will be gray. If it's on, so it will be blue. Then we have a color code in our device. So the next button shows you the current sodium level in the dialysate as numerical value and as a bar. The control range is shown in form of the rectangular title according to the window size. So you can select it. So which is very important here, which is overall sodium balance, which can be in grams. Grams sodium can be, there are also grams sodium chloride measured units. The amount of sodium removal and sodium supply through the ultrafiltration and diffusion during treatment, the units for the displayed value can be selected in a user's. So we have two options, millimoles or the milligrams, or sorry, grams. We have also the other button, which is a diffusive sodium balance. The amount of sodium removal or supply, vice versa, through diffusion during treatment. The units for the displaced value can be selected and also user setup in our device, either grams or millimoles. So next button is which shows us the current plasma sodium for the treatment as calculated by sodium management. And this shows the last button, which is here, shows the predialytic plasma sodium, which will be calculated by the machine automatically. So they need to feed only this one. So usually this is what, when they press the sodium management button, this will appear in front of them. They just need to feed some data and they can decide what is the real plasma sodium of the patient, and the machine will do. If you have a specific goal, so machine can also adopt the zero diffusive sodium. So it will not give or it will not remove from the patient. Potential benefits of individual sodium management is a reduced diffusive sodium may lead to the reduction in thirst, reduction of intradialytic weight gain, a modification of short-term outcomes thanks to reduced fluid overload and reduced blood pressure. Avoiding excessive diffusive sodium removal may also reduce the intradialytic symptoms. So we have also BTM. I will not go through this one. As I said, this device has many options, which is also based in our old machine. We have also recirculation. In this device, we have also access flow meter, which I did not prepare because the time is limited, but I will show you in the end of video, which is very useful information. We have also this elite model in our dialysis, a premium model, the 6008. It's a new version, and we have also dedicated software for pediatrics as well. And we have pediatric disposables separately available for this one. And this is the only machine dedicated also to the pediatric, which is supported with the software 10 kilograms up to 40 kilograms. So it's all also the reduced volume around 78 mLs. So minimized volume of the extra carbohydrate, and it's also air-free, reduce the burden on potential hazards, and less PVC, less plasticizer. As I mentioned, it's adapted for pediatric needs to improve the safety. Microbubbles are also sensitive, and blood flows are as per the weight of the patient. Here we have a weight in the software, so the machine will adapt automatically blood flow as per the selection of the weight. Now let's go to the next slide, which is the reduction risk related handling steps in this device. It's reducing risk of infection and cross-contamination for both healthcare professionals as patients. How we say so, you can see it here. We have studies which shows the catheter risk has dropped with this device 23% and in fistula 27%. Why? Because we have a closed circuit reinfusion in this device. So I will show you the closed circuit surgery. We will see in the next slide how it does. It's a reinfusion. You don't disconnect the patient. You can see both needles are intact, and we have a double optical detector. The machine will start returning the blood simultaneously from the arterial side as well as the venous side, which we say access or return line. So once it's complete, it will be detected, and it will be also followed by the user's volume, what he selected. So you don't need to disconnect. So if you are dealing with CVC, you are not adding additional cost of sterile gloves or two per persons. You can return simultaneously, then one time you can put on the sterility and one go, you can remove it. So also we say non-invasive air free. There is no measurement air transducers, which was in our old machine. Here is air free without potential of reduced risk of blood clot coagulation. Heparin connection is also done in this device automatically. So we say it's a less workload for the users. We have so they can improve the quality of the patient care. So we are comparing it to our old device 5008, which is 3 minutes difference reduction in operating time, one nurse treating one fistula patient. So we say less complexity. Why? We are telling leave the complexity to us. We have an automatic emptying program for this machine as well, including dialyzer. We do not only remove the water from the dialyzer or residual, we remove also the fluids from the lines in the cassette, which is a blood compartment. So as I mentioned that we remove the fluid from the lines as dialyzer, so approximately 2000 kg less waste per year for an average center, resulting potential waste costs. So you are saving. This is we have make studies comparing to our old device. So if you, because we are paying to Baladia per kg cost, so when the residual is less weight, so you don't pay much because of this auto emptying. See, once you disconnect the patient, there's a steps to follow. Machine will remove. It will empty the lines automatically. Okay, so see, as you can see it here, how it removes the fluids. Oops, sorry. So it's all going drain. So it will empty, it will push an ear and remove all the fluids which is in a blood compartment of the lines in a cassette or in a dialyzer. External side of dialyzer compartment of dialyzer and internal inside the fibers, it will be drained out completely, almost nearly to 100%. So if you are removing it completely, for sure, then your waste is less. So this is here emptying. The 6008 care system offers an automatic emptying program for the extracorporeal circuit. Once the reinfusion program has been completed, residual liquid in the 6008 care set and in the dialyzer are nearly completed, removed. This results not only in the savings of the waste, but also in the reduced risk of the potential contamination with the residual liquids. That's what I said. So before I'm ending up, I apologize. I need just a second to share the video, which is very important. So first, I will share with the sodium management. This is really a fantastic video to watch. So the second second video, which is very helpful also, but I did not include in this presentation, is AFM, where access flow meter, where Dr. Fadl will be talking about access flow, which is known as invasive in our device. Uh, So here I conclude my presentation. Thank you, Dr. Khalid. Thank you, Dr. Fadl. Actually, there was some issue with the technology over here. So I hope you can hear me.
Assalamu alaikum. Good afternoon, everybody. We will resume our afternoon session. This session, please don't raise your hand. If anyone having any question, he can write it, in the question and answer, or in the chat. And please, we are not here to answer any question regarding the CME hours or the registration and so on. So here only we are for the scientific, content. So our next session will be about dialysis patient management, about the holistic approach. Should be presented by Dr. Khalid Al-Matham. Dr. Khalid Al-Matham, he has to leave, so I will be presenting on his behalf. Hopefully it will be short and fast. If we succeed to finish in 30 minutes, I will give my last session so we can finish, at 3. So these are the outlines of the talk that I will talk about anemia in patient with CKD, hypertension, fluid overload, and CKD, MBD, and the diabetic management. Just a second here. So you can see that, the prevalence of CKD is increasing. And unfortunately, that what we see in our clinical practice, people who come with advanced CKD are the tip of the iceberg. And the majority of patients, who does have earlier stage of CKD, unfortunately, they are not identified, either because they are not doing their tests and in the absence of, the routine screening for chronic kidney disease, whatever by calculating the GFR, by measuring the serum creatinine, or looking for the albumin creatinine ratio. So starting to talk about anemia. Anemia as defined by hemoglobin of less than 12 is very prevalent as the patient progresses from stage 1 to stage 5 CKD. As you can see that almost 75% of patients with stage 5 CKD, they will have anemia. Anemia is multifactorial, although erythropoietin deficiency is the major contributing factor for anemia with CKD, but especially patients on dialysis, they have, blood loss, either because of clotting of the filter or because of the anticoagulation that we are using. They may have, some of hidden GI bleeding. One of the major also contributors for anemia is iron deficiency anemia, and it is also multifactorial. We have elevated hepcidin mainly because of the inflammation, shortening RBC lifespan, the hyperparathyroidism that make the bone marrow resistant to the erythropoietin. We don't see much of the aluminum toxicity, but it was present at one time early with the start of the hemodialysis era. Chronic inflammation with erythropoietin resistant, infection, malnutrition, and medication. When it comes to iron deficiency anemia in patients with a chronic kidney disease, just from this study, who did a kidney biopsy and they found, confirmation, you can see that anemia of chronic kidney disease is almost in 50%. So chronic kidney disease as inflammation is very prevalent in our population. And when you look to isolated iron deficiency anemia is almost 10%. We have many definition of iron deficiency in patient with CKD. When you look to the European renal best practice guidelines, so they define it as serum ferritin less than 100 and saturation less than 20%. While there is a functional iron deficiency anemia when there is inadequate, iron supply to meet the demand despite normal or abundant iron store. So when you look to the absolute iron deficiency, you can see that the saturation will be low, and the serum ferritin also will be low. While in case of functional iron deficiency, you will find that the saturation is normal or low, while the iron store is normal, and sometimes it is high. Again, iron deficiency anemia is one of the risk factors for this. This is a worldwide data that was published in 2010. You can see that, iron deficiency anemia rank number 13 is not by itself, but mainly related to the disease that can cause iron deficiency anemia. And you can see that when the hemoglobin increase in our patient above 13, and patient who is on dialysis, they may have, some sort of iron increased mortality. So let's see how we treat anemia in patient who is on CKD or dialysis. We have oral iron, we have intravenous iron, we have ESA, and we have the blood transfusion. We are trying to avoid the blood transfusion for the consequences from viral infection to hemochromatosis, fluid overload, and sensitization for people who are going for a transplant. So this is what I mentioned about the blood transfusion. So we have the oral iron. It is very easy, it is cheap, but unfortunately, people, they cannot tolerate a lot of GI side effects, and there is a lot of drug-drug interaction. About IV iron bypass the need for GI absorption and incorporate more rapidly than the oral iron. Intravenous encourage the treatment adherence because it is given, during dialysis for dialysis patient, and fewer administration required to reach the hemoglobin target. EMA suggests that the benefit of intravenous iron, to overweight the risk, because there is some concern about, infection. That's why if you have somebody who is having active infection, try to avoid the IV iron. ESA, it can be administered intravenously or subcutaneously. New formulation are developed. We have many formulation for the time being, reaching into HIF stabilizer. ESA therapy to correct anemia shown many benefits, including the reduction for need for blood transfusion, as well as hospitalization and the left ventricular hypertrophy. As I mentioned, there is a hazard for one of these interventions: blood transfusion alloimmunization. IV iron, we talked about, the increased inflammation and the risk of infection, and the oral iron about the GI side effect and drug-drug interaction. And again, for the ESA also, especially with the overcorrection, we may have increased the mortality and the cardiovascular event. So ESA therapy for anemia in non-dialysis CKD, I will try to summarize it in this slide. So widely used to treat anemia, effective in improving hemoglobin level and relieving the symptoms of anemia, as well as improving the quality of life and reducing the need for blood transfusion. 15% of non-dialysis CKD patients with low hemoglobin don't respond to the ESA. This is the group that we call them, erythropoietin resistance. More common reason for hyperresponsiveness is iron deficiency. That's why it's recommended, to check for the ferritin, and you check for the saturation, and to give IV iron, if indicated based on the guideline. Concern about the use of aggressive hemoglobin target above 11 and some study above 12, because that increases the risk for stroke and cardiovascular event. There is some concern using it during malignancy, especially in regard of thrombosis. Causes of progressive deterioration of mineral bone homeostasis. So patient who does have reduced renal mass, they may have reduced active vitamin D, reduced serum calcium, increased phosphate. This will give a signal to the parathyroid gland through the calcium sensing receptor to increase the BTH. And keep in mind that, the early marker for mineral bone disease that, increase is the FGF23. So again, as I mentioned, all these parameters, but the first one usually, to increase is the fibroblast growth factor 23. So the end result, we have bone disease and we have vascular calcification, and this will lead to fracture as well as the cardiovascular disease and increase mortality. Again, looking for the CKD MBD, or previously what we call it, the hyperparathyroidism, secondary or tertiary. So when there is a reduction of the kidney function, there is a reduction in the phosphate excretion, leading to an increased serum phosphate. By itself will lead to an increase the fibroblast growth factor, or what we call it the phosphatinin. So it is a protective, it's a protein that help in excretion of the extra phosphate in the urine. Also, in the same time, there is a reduction of vitamin D activation and also reduce the calcium absorption. So what will happen? So reduction in the calcium will be sensed by the calcium sensing receptor in the parathyroid gland and will lead to an increase on the BTH. So as a result, again, there is an increased bone efflux of the calcium and phosphate, and this will lead to secondary hyperpara, and later on, the spontaneous, adenoma and tertiary hyperparathyroidism. So hyperphosphatemia associated with an increase of all-cause mortality, and you can see that it is a U-shaped, because with low phosphate mainly related to malnutrition, and with the high phosphate related to very bad control of the CKD MBD. Again, you can see that the risk of mortality, with very low phosphate in comparison, with the high phosphate. So it is a U-shape, and with the low phosphate mainly related to malnutrition, while in the high phosphate related to the vascular calcification. Let us see the guideline for CKD stage 5 based on the KDIGO guideline. So comparison between 2009 and 2017. So treatment should be based on serial assessment of phosphate and calcium and BTH level. And it should be considered together. That means we don't go with only measurement of the phosphate or the calcium or the BTH by itself. In patients with CKD between 3-5, lower elevated phosphate level toward the normal range. So it's very important to keep it normal for the time being. Decision about phosphate lowering the treatment should be based on a progressive or persistent elevated serum phosphate. It doesn't mean that if you have one patient who come to your clinic, just with one reading of high phosphate, that you have to start him with phosphate binder. In adult patients receiving phosphate lowering treatment, to restrict the dose of calcium-based phosphate binder. So we are moving toward, minimization of the calcium exposure to our patients, including, a calcium-based phosphate binder and our calcium and our dialysis to reduce the calcium burden and the vascular calcification. Limit data phosphate intake in the treatment of hyperphosphatemia alone or in combination with other treatment. Again, when you look to the guideline recommendation, unfortunately, that most of the time we are not following, the guideline. This is around 7,000 hemodialysis patients who get recruited. 2.8 of patients are below the normal range, and you can see that around 30% within the normal range, while there is 70% of patients, unfortunately, they are above the normal recommended range. This is from Europe. So how we manage or deal with patients with hyperphosphatemia? So it is an integrated approach. So we'll start with diet. That's very important, to have a renal dietitian in your unit or in your department. So phosphate restricted diet. For patient who is in dialysis, extend or increase the frequency of dialysis and the use of potent phosphate binder. We have many phosphate binder in the market, started with the old one. That is the aluminum-based phosphate binder. It is available, it is cheap, but is not recommended to use it more than 4 weeks because of the risk of aluminum toxicity. And then we have the magnesium-based phosphate binder, the calcium-based phosphate binder, the calcium carbonate or acetate. We have the lanthanum is not available or registered in Saudi Arabia, but we have the sevelamer. Sevelamer is available, either the hydrochloride or the carbonate that we have it for the time being. And then we have the iron-based phosphate binder, and we are moving towards, for the time being, the Vilforo. It is one of the new iron-based phosphate binder registered in Saudi Arabia. So when we go and look back, to the KDIGO, so phosphate lowering treatment should be based on a progressive or persistent elevation of the serum phosphate, as I mentioned, and it should be toward the normal. And try to minimize the exposure to calcium-based phosphate binder. These are the available phosphate binders in the market. Start with the aluminum, that is the AluCap. We are trying to use it. Most of the time, by the way, the AluCap is used as antacid, so it is available over the counter. It's not recommended to use it more than 4 weeks because of the risk of aluminum toxicity. And we have the calcium-based phosphate binder. We have the calcium phosphate, the calcium carbonate and the calcium acetate. The calcium carbonate, it is commonly used here. But again, the concern, it is very effective, but the concern is the number of tablet drug-drug interaction, as well as, increase the calcium burden and the calcium related calcification. We have the lanthanum, fusrinol. It's not available in Saudi Arabia. It is radioactive material. It is effective. It is chewable. Unfortunately, it is not registered here. It is not cheap also. The problem was the long-term outcome. So we don't have enough data. So that's why it's not widespreadly used. Sevelamer, Renvilla, or Renagel, it is available. The most common side effect is the GI side effect. The second drawback of the use of the sevelamer is the tablet burden, because patients need between 8 to 12 tablet burden to achieve the targeted phosphate level. So that's why most of our patients, they are non-compliant because of these tablet burden, as well as the GI side effect. And we are moving now to what we call it, the iron-based phosphate binder. In Saudi Arabia, we have Vilforo. We have it in our hospital. We introduced it recently. It is chewable. You need only 2 tablets, maximum 3 tablets, to control the phosphate. And it's considered for the time being is the most potent, phosphate binder. Price-wise, is not that expensive. It's almost the same price of Renagel. So I think it will take, it will be spread in most of the units in Saudi Arabia soon. So which binder to choose? We have to choose the effective one, reducible burden, tolerable with least GI side effect, and we have to consider the cost. And I think I will skip this one because we talked about, the load of the calcium and so on. This is one of the side effects of the use of sevelamer, severe, gastritis associated with GI bleeding and erosions and so on. Phosphate binder, 50% of daily pill burden in dialysis patients. So most of our patients, they are on polypharmacy, and most of these medication, unfortunately, is phosphate binder. So if you can have effective phosphate binder with the least, tablet burden, it will be very great. And this is one of the study that they look why the phosphate binder is not taken. 25, they said, they report that they have a problem. Some of them, they mentioned they forget to take it. And other here, you can see it either forget or swallowing a problem, or they complain that it is too many. Some of them, they complain that they have chewing problem, taste, and some of them, they have the belief that it is not effective. So this is about, the iron-based phosphate binder, the saccharophilic oxyhydroxide. It is one of the novel iron-based potent non-calcium phosphate binder. You can see here, it is very potent in comparison to lanthanum and calcium and sevelamer. You can see that sevelamer, when it comes to the tablet, it is free of calcium, but it is not that potent. That's why we have to use, between 8 to 12 tablets. This is when it comes to the binding capacity to other saccharase, has higher binding capacity than other phosphate binder. That's why we require least number of tablets and compare with other medications, especially with the available one that is sevelamer. When it comes to diabetes, we'll move now to another metabolic complication that occur in patients with chronic kidney disease, that is diabetes. So we have good number of our patients, they have diabetes, and it's very important, to monitor the hemoglobin A1C, especially for somebody, who is on continuous ambulatory or continuous cyclic peritoneal dialysis, because we are using glucose, and good number of them, they may have, hyperglycemia. So the target for hemoglobin A1C in patient who is with CKD, whatever, on dialysis or not yet on dialysis, we are a little bit, afraid of the risk of the hypoglycemia. So we accept up to 8, especially for somebody with many comorbidities. While if you have somebody, with early stages of CKD, and he does not have any comorbidities, and we are not afraid of hypoglycemia, so you have to go with a restrictive strategy to keep the hemoglobin A1C below 6.5. So the treatment should be toward, cutting the salt. And this is not that easy. So you have to get fresh food, cook them at home, avoid food with more than 4 milligrams of sodium, avoid salt processed meal, keep healthy, unsalted snack, use sweet, sour, bitter, and spicy instead of the salt, and so on. So this is the latest, a guideline for treatment of CKD patient with diabetes. So again, start with the lifestyle modification from physical activity, nutrition, weight loss. For somebody with eGFR above 30, still metformin is the drug of choice for the time being, and we have to add the SGLT2 inhibitor. And if we start it, we can continue till the patient reaching dialysis. If the hemoglobin A1C is not reaching target, we can use the GLP-1 receptor agonist, and then we can move to more anti-diabetic medication like DDP4, insulin, and so on. By this, I finished Dr. Khalid's presentation, and if there is any question, I can answer it before I move to the second presentation. And I'm just reading the question. So there is one question. Where is this? Can we prescribe iron as routine for patient on dialysis? We don't use iron as routine because we are afraid of the iron overload. So when you have iron overload, this will lead to many complications. One of them, what we call it, the secondary hemochromatosis. Also, increased iron, it can impact on the phagocytic, function, and patient will be prone to infection. And that's why, we don't give iron unless it is indication. So the indication for somebody with anemia and having the transferrin saturation less than 20 or the ferritin less than 100. There is another question about, the approach for erythropoietin resistant toward correction of anemia. So the most important part, to see why your patient having erythropoietin resistant. Starting if the patient already, having depleted iron store, that is very important. And even if he's having iron deficiency, just see, if there is any source of bleeding, especially for somebody above 50, try to screen for any colonic cancer or any angiodysplasia. That is very important. If the patient, using the erythropoietin or no, I think that is very important. And if he is on the accurate dose or no, if his dialysis is appropriate or not, because we know that the uromoxitoxin, it can impair the responsiveness of the bone marrow. And one of the important, factor that is, the severe hyperparathyroidism. So you have to make sure that, the patient hyperparathyroidism, is treated very well. Unless you rule out all these, you may think about pure red cell aplasia that we don't see with the current formulation of the ESA. Previously, you know, we see it, and it was contributed to one form of the iron with the prefilled syringes. Question, how we calculate the deficit of iron in dialysis patient? You don't need to calculate. There is no calculation. Just you have to measure the ferritin and the transferrin saturation. So the ferritin is the store and the saturation is the active iron that you need, you know, for fully functioning of the bone marrow. If no more question, I think we will go to the second presentation. Assalamu alaikum. We'll move to the second presentation. If you have a question, you can keep it till the end, whatever in regard of the last presentation of Dr. Khalid or in regard of my presentation. So I was asked to talk about hemodialysis access assessment, and I think that is very, very important topic, you know, for nephrologists, whatever if they are assistant or consultant. And it is one of the major problems that we face. So why we have to talk about, you know, assessment of the vascular access? The vascular access is the lifeline of patient on hemodialysis. You cannot dialyze patient without vascular access. 2, the quality of the vascular access determines the patient outcome in form of morbidity and mortality. It's very clear that, you know, we have higher mortality for somebody who is dialyzing on Birmicath and the lowest mortality for somebody who is dialyzing with AV fistula. Number 3, poor functioning vascular access increase the risk of hospitalization. And if you are a nephrologist, you are aware that most of our, you know, admission and ER visit is related to the vascular access, and this will be reflected to increase the cost of the healthcare system and shortening, you know, the survival expectancy of the patient. Low blood flow rate also limits adequate delivery of dialysis dose. So that's why it's very important, you know, to make sure that your patient having, you know, a good vascular access. You will hear 2 terminologies. One of the terminology is monitoring, and the second one is surveillance. So monitoring is the examination and evaluation of vascular access by a mean of physical exam. So monitoring is physical exam to detect physical signs that suggest the presence of dysfunction. While surveillance is the periodic evaluation of vascular access by using tests. And I will come to that test. Mainly we are using either radiological or by using a special device that may involve the special instrumentation for which an abnormal test may suggest the presence of dysfunction. You are aware about the type of vascular access that we have. We have the AV graft, that is the connection between the artery and between the vein with synthetic material. We have the AV fistula, that is the connection between the artery and vein from the native vessels, and we have the central venous catheter. Unfortunately, that most of our patients start dialysis with the CVC that we don't like, you know, to see. Difference between the AV graft and the AV fistula, that the AV fistula is a native vessel, so there is lower risk of infection, lower risk of thrombosis, and lower mortality in comparison to the AV graft. But the only advantage of the AV graft that you can use it, you know, earlier than the AV fistula. So when you refer your patient for AV access, because we try to refer our patient before they are on dialysis, because if they come as a crash starter, unfortunately, there is no time for maturation of the fistula and we have to put them on CVC. So the KDOQI 2019 guideline, it is reasonable that in non-dialysis CKD patient with a progressive decline in kidney function, referral for dialysis access assessment and subsequent creation when the eGFR between 10 and 20. So between 10 and 20, especially for diabetic patients, try to refer them at higher GFR. But earlier referral should occur in patients with unstable or rapid decline of the GFR. And here, for example, more than 10 ml per minute per year. So 15 to 20, whereas if somebody, the GFR deteriorating very quickly, you can refer even earlier. Looking into the history of dialysis, very interesting, So this is the vascular access on the late 50s and early 60s, what they call it, the shunt. And you can imagine, so they will go with one line into the artery and they will go into the vein, and then they will use this metal device. And when they connect the patient to dialysis, they have to disconnect from here. So you can imagine how many patients, develop infection, how many patients develop thrombosis or even limb ischemia that require amputation. Again, this is one example of the shunt that was used on the early 60s. All these change, with the innovation in vascular surgery in form of creation of the AV fistula. You can see that this is the first publication by Brescia and Semino. That's why we will see that the AV fistula sometimes called in the literature that Brescia and Semino fistula. This one on 1965, it was published in New England Journal of Medicine. And I will show you the outcome. So this is what they did. So you can see the vein is larger than the artery. So they connect the artery with the vein. And then they succeed to dialyze their patient. So this is the report of their patient. And you can see that, for all these patients, it was very successful, except in 2 patients that did not work. Well, in general, there is no major complication. And all these patients, were able to dialyze. There are many terminology, it depends on the site of the connection between the artery and the vein. We have the commonest one, radiocephalic. It's the one that we call it, Brescia Semino. We have the snuff box arteriovenous fistula. We have the proximal forearm fistula. And we have the brachiocephalic fistula. And then we have the graph, this is transpose arteriovenous fistula also. And this is the graft. We use loop graft. This is forearm loop graft. This is upper arm straight graft. And this is loop graft in the thigh. We don't like to use in the thigh, but for somebody, with difficult access, unfortunately, it could be the last resource. So going back to the guideline. So we saw the guideline in regard of the referral. Now let us see when to monitor. So the KDOQI considered it is reasonable to assess or check the vascular access and the surrounding area by physical exam prior to every cannulation. That means it is our everyday job. So that's in case of the AV fistula or graft, or in case of connection for potential complication. It is not graded. So when to use a newly placed AV fistula, I think that is very important. Look to this study, they look for, different part of the world, from Japan, from Europe, Australia and New Zealand, as well as in the United States. And the upper cartoon A, you can see in this graph, Japan, they use the AV fistula very early. Majority of their patients, they use it below first month. Well, you can see that in Europe, almost 2 months, and in the United States, almost 3 months. Again, you can see that for the AV graft, it can be used, much early. And this is, when you look to the blood flow as well as to the diameter for people, with the AV fistula who were successfully cannulated versus not successfully cannulated. The upper part, you can see that the blood flow within 2 weeks, it can reach above 600 and the diameter around 0.4. While for the people, unfortunately, who failed you know, the cannulation, or what they have, what you call it, the primary failure, you can see that within 2 weeks, you know, their blood flow is almost less than 200, and their diameter is less than 0.3. So when we cannulate a newly created fistula, we have the rule of 6. A flow in the fistula should be greater than 600. The diameter of the fistula should be at least 6 millimeter. The fistula should not be more than 6 millimeter in depth. Fistula should have discernible margin, clear margin, and the fistula should be ready to be used within 6 weeks. This is, we call it, you know, the rule of 6. And this study, it is all, this study is almost 1 year old, ولكن it looked, you know, to patients who get an AV fistula, around 70 patients who get evaluated up to 4 months, and they look, you know, what are the criteria for successful cannulation. You can see that fistula adequacy for dialysis doubled of the minimal venous diameter was 0.4. It was around 89% from this study, and the flow volume was more than 500. So whatever of these, you know, is positive, you can see that it is between 85 to 95. ولكن combining both of them, that means the diameter more than 0.4 and the blood flow more than 500, you can see that the success rate is more than 95%. Women are less likely to have adequate fistula diameter because they have smaller vessels, and there is no significant difference in the blood flow or minimum venous diameter during 2 or 4 months. That means you can use it, you know, even earlier. And I think that is very important. The last part, that experienced nurse, I think, is very important, and you should have the experience or the expert nurse for cannulation in your unit. And it has the best, you know, accuracy, especially if you have the data about the diameter and about the volume. So let us see the guideline for the AV graft. So the AV graft, this is from the Keiduki. A graft should not be cannulated for at least 2 weeks. Canadian, 3 to 6 weeks. European best practice guideline, 2 to 3 weeks. Renal Association from UK, 2 to 3 weeks. And the idea that we don't, you know, cannulate the AV graft less than 3 weeks, because we are afraid that it will be an extravasation of the blood and adhesion of the graft to the underlying skin and overlying, you know, structure that will make it, you know, very difficult later on, you know, to be removed in case of infection. But we have what we call it rapid access graft, the fluoxetine here. So we have the fluoxetine. It is one of the rapid access graft. It is inert, and it can be used within 24 hours to 48 hours. So that's very important to discuss with your vascular surgeon, you know, about the type of the AV graft that you have in your center. And you can see that the patency with the use of the rapid access graft is similar to patient, you know, who is having the regular, you know, graft. So the simple algorithm for evaluation of patient with early AV fistula failure. First of all, physical exam by skilled personnel at 4 to 6 weeks. Indication of candidate with early fistula failure, because it needs early referral, you know, for angiography with or without, you know, intervention. So what is fistula failure? Fistula failure, we have a primary and we have secondary failure. The primary failure defined as the fistula that did not work by 3 months after surgery or after creation. While the secondary failure is defined that as a failure of permanent access after it has been used for dialysis for 6 months. That means a patient was having the fistula used for 6 months, and unfortunately after that did not work. So that is the secondary. While if it did not work from the beginning, we call it a primary failure. This is just to show you that most of the fistula in this study, they look for around 100 patients. Most of the fistula is radiocephalic as expected, and most of them is on the left side. Okay, let us see where is the lesion. in most of these fistula. So most of the lesion in the arterial anastomosis site. So that's why you have to expect where is it. Number two, in the accessory vein, so the presence of the accessory vein and juxta anastomosis site, that the artery in the venous side. And then we have, proximal venous stenosis. So that's why, so most of the fistula failure related either a problem in the arterial anastenosis or venous anastomosis or the presence of collateral. Well, when you look to the graph, so this is from one study when they look to the graph, so you can see that most of the lesion related to venous anastomosis. So at the site of the venous anastomosis, look to the other side, and we have here in the peripheral basilic, we have the arterial anastomosis also is a prevalent. So when you look to the graph, so it's mainly related to the anastomosis venous and then arterial, while when you look to the AV fistula, mainly we are looking for anastomosis plus, accessory veins. So why patient, having AV fistula dysfunction? It is multifactorial. Some of them is upstream, some of them is downstream, factor. Like surgical injury, hemodynamic or shear stress, the presence of a trauma because of the needle, the uremic toxin by itself, the oxidative stress, inflammation, and there is the proliferation. And this is exactly, what happened when we talk about, the uremia and the shear stress, especially when we have, the medial calcification that make the vessel is unfortunately, undistanceable, and you can see that this is the lumen for somebody, with intimal hyperplasia, and consider in correlation with somebody, who is healthy. So even if there is injury and there is modeling, the outward modeling for healthy patient, while for our patient, unfortunately, the modeling is inward, and the patient will have, narrowing of the lumen. This is exactly what happened. I will not spend time on it. Monitoring. Physical exam, and the physical exam, it will be by inspection, palpation, auscultation to detect physical sign of dysfunction. Number two, and I think that is very important, is the measurement of the delivery of dialysis dose. That means if you have somebody, who is having good KT over V or urea reduction ratio, and suddenly you see the drop of the urea reduction ratio, very important to check for, the patient access. Number three, and I think that is very important to practical point, the presence of clinical evidence of dysfunction, like difficult cannulation, prolonged bleeding after dialysis, swelling of the extremities, or the presence of aneurysm. Physical exam. Again, like any physical exam, we start with an inspection, and then with palpation, and then with auscultation. Let me move this one. Okay, when to start monitoring the AV fistula? Soon after the creation, to follow the maturation and throughout the life of the AV fistula during each dialysis. Let us see the inspection, what we are looking for. During dialysis, you are attending your dialysis session, whatever you are a nurse or you are a physician in the dialysis unit. First of all, you look for the diameter, usable length. This is mainly by our dialysis technician or dialysis nurse. The presence of any obvious, side branches. Arm elevation, I will talk about it. Inspection of the ipsilateral extremity, not only to concentrate on the same side. Shoulder, chest, breast, neck, and face. That's very important. So all the time, look to the side of the axis and compare it, with the other side. Look for any hematoma in a newly cannulated AV fistula. Look for any sign of infection, swelling, erythema, tenderness, and if there is a presence of any discharge. Look for any scar, dilated veins, and sign of Steele syndrome in case of the AV fistula or in case of AV graft. Aneurysm and pseudoaneurysm, if present, the overlying skin should be examined for evidence of marked thinning, depigmentation, and tightening, because all these are a risk, for, aneurysm rupture. So you have to monitor it and you have to document it in the chart. Don't forget to look for edema. The presence of edema in the extremity ipsilateral to the axis is almost always indicate the presence of central venous stenosis. We call it pulmonary we call it upward stenosis, and the proximal stenosis, we call it venous hypertension. If the edema involved the arm only, it suggests the stenosis at the level of the subclavian vein. If the edema include the ipsilateral chest, breast, or the face, the stenosis is most likely at the level of the brachiocephalic. If the edema involve both sides, is most likely suggestive of superior vena cava stenosis. So just, the presence of edema, it can tell you, an idea where is the most likely lesion of stenosis. What is arm elevation test? And I will show you a slide of this arm elevation test. The test should be included in the inspection of the AV fistula, but not the AV graft. In patient with an AV fistula, the axis is generally distended when the arm is dependent due to the effect of gravity and should collapse if it's elevated above the level of the heart. If a venous stenosis is present, only the portion of the AV fistula proximal to the lesion will collapse, while the portion distal to the site will remain distended. This is a fistula. This is a normal fistula. This is, with the arm elevation, you can see it is collapsed again. So you can see, it is collapsed with elevation. Again, we have to evaluate and looking for any hematoma, looking for aneurysm. And when you have aneurysm, very important, look for the skin, if it is shiny, if it is thin, if it is depigmented, as this, it could be a sign for, aneurysm rupture. Look for a sign of steel. And we look also for the swelling as well as for the dilated vein. You can see the dilated vein and you can see the swelling here. Not all swelling, related to infection. Keep in your mind that, allergic reaction, especially to the pads that we are using, or the chlorhexidine or bividone also, or the local antibiotic, it can occur like in this patient. Infection like cellulitis, it can happen. Again, this is, the comparison between the left and between the right arm. You can see the swelling here. So in the A, it is related to the right subclavian vein thrombosis. You can see the collaterals. You have to mark if you have somebody, with aneurysm. It's very important to mark, and you can see if the diameter increase. Again, this is the dilated veins, and so on. So let us move toward palpation. So we palpate for thrill, pulse, and we do some maneuver like the augmentation or sequential occlusion test. Thrill. A thrill is a palpable vibration or buzz. It's related to flow. When it present, indicate that there is a flow. So that's why, when we ask the patient, if they feel this, electricity-like, vibration, that means the fistula or the graft is working, and if it is absent, that means it's not working, and they have to present, to the hospital or to call the provider, for intervention. It could be diffuse or localized. The presence of soft, continuous, systolic and diastolic, diffuse background palpable over the course of the axis, either the AV fistula or AV graft, is normal, and it is most obvious at the venous anastomosis. A stenotic lesion creates localized area of turbulent flow within the vessel, so that's why you will find it, mainly diastolic. So, as the lesion develops progressive increasing resistance to the flow, the thrill becomes short, and unfortunately, it loses its diastolic component. So it will be only systolic, as it is a transmitted sound. The thrill may be best evaluated by using the palm of the hand. So this is the way that we look for the thrill. So with the palm of the hand, so the first question we ask ourselves, is there a thrill or there is no thrill? So if there is no thrill, that means the axis is not working. It's most likely thrombose. The normal thrill is systolic and diastolic with soft background. But if there is thrill that is systolic and it is localized, is not all over the course of the thrill, so and lose its diastolic components, most likely related to stenosis. The pulse, again, usually it is soft and it is compressible, whereas when it is hyperpulsatile or strong bounding pulse, it may indicate that there is stenosis, mainly at the venous side. So what about pulse augmentation? This test is performed by occluding the axis several centimeters above the arterial anastomosis. I will show you the picture of that. So as you are checking the pulse, with one hand while evaluating the intensity of the pulse with the other hand. The test is based upon the fact that if the axis is completely occluded, some distance from the arterial anastomosis, the normally soft pulse will become augmented. The degree of this increase in pulse intensity is directly proportional to the quality of the axis inflow. If there are a problem anywhere within the arterial system from the anastomosis upward, it will affect the degree to which the pulse is augmented. Although it works better for AV fistula evaluation, it's also reasonable to be checked for patients with AV graft. This is the way that we do. We occlude at A and we check, the pulse at B. So if it is hyperpulsatile or augmented, so most likely there is a stenosis. Sequential occlusion, almost the same way. But the way that we do it, that we move our finger, from one side to another side, and you will see where is the area at which, the thrill or the pulse will disappear. Auscultation is exactly when we are doing when we are checking, the thrill or the pulse, but with the use of the stethoscope. So by putting your stethoscope over the AV fistula, you will hear systolic and diastolic low pitch background, while in patient who does have a stenosis, most likely he is having only systolic that is high pitch. Again, the physical finding that we are looking for, if pulse increase and thrill decrease, so most likely we are talking about, stenosis. Pulse disappear, sudden decrease in the caliber, and if the patient, having distended and hyperpulsatile pulse, may indicate that the patient having stenosis. But again, the absence of pulse or thrill indicate that the fistula is completely gone. Reproducibility, it is reproducible. I will skip this one. What about monitoring as part of the guideline? So the guideline said regular physical exam or check of the AV fistula by knowledgeable and experienced healthcare practitioner to detect a clinical indicator of flow dysfunction. Inspection, palpation, and auscultation. Regular physical exam or check of the AV graft, again, by knowledgeable and experienced health practitioner. It's considered to be reasonable for nephrology trainee and healthcare practitioner involved with a clinical hemodialysis patient to be properly trained in the physical exam of access assessment. So let us move to the last part, surveillance. I have 5 minutes and I will finish it, inshallah. Surveillance is defined as a periodic evaluation of the vascular access by using tests. Here we are not using the physical exam. Here we are using tests that may involve special instrumentation and for which an abnormal test result suggests the presence of dysfunction. We have many surveillance methods. Access blood flow, that is very interesting. It's using a transonic device. With saline dilution is the golden standard. Change in the UF rate using the hematocrit, change in the conductance with built-in flow measurement device in the dialysis machine. And this is the one that Mr. Tariq Soufi from Fresenius, he talked about with their machine that, while the patient, connected in his dialysis session, it can give you, a measurement of the flow. Static venous pressure and Doppler ultrasound imaging. So the Doppler ultrasound, it is very easy. Static venous pressure is not widely used, and I will come through it quickly. So what the guideline said, do the guideline recommend to do surveillance for all your patient or no? Let us see. There is inadequate evidence for KDOQI to make recommendation on routine AV fistula surveillance by measuring excess blood flow, pressure monitoring, or imaging for stenosis. The KDIGO does not suggest routine AV graft surveillance also. So no routine surveillance suggested for the fistula or the graft. Surveillance and preemptive intervention for AV access stenosis, not associated with a clinical indicator. That means you did the surveillance and you discovered something without any finding. Let us start to look for endovascular intervention. The KDIGO does not recommend the preemptive angioplasty of AV fistula with stenosis, not associated with a clinical indicator. And that's why they don't recommend the routine, surveillance. That means routine surveillance, you found there is a lesion, but there is no clinical sign. They don't recommend to go for intervention. The same thing for AV graft. What about preemptive intervention for AV access stenosis associated with a clinical indicator? It is considered to be reasonable for patients with consistently persistent clinical indicators and underlying AV access stenosis to undergo a preemptive angioplasty of their access to reduce the risk of thrombosis. So access flow, just I will go now with the instrument. So the access flow should be measured monthly. If you adopt the access flow measurement in your unit, it should be done in the first 1.5 hours of dialysis to eliminate error. If access flow less than 600 in a graft or 500 in fistula, patient should be referred for fistulogram. So this is the protocol. Do it monthly, 1.5 hours. If less than 600 or 500, refer for fistulogram. If you found lesion in fistulogram, refer to vascular surgeon. If access flow of 1,000 decreased by more than 25 over 4-month period, also refer for fistulogram. This is the Transonic machine that is very famous and widely used. But if you have the new machine, the dialysis machine that incorporate the access flow measurement, it will make your life easy. So what we are doing with this machine, we are measurement the recirculation, and I will skip the recirculation. I will go directly to the access recirculation, because for center who don't have machine, they measure this recirculation, and there is, a protocol and guideline from the KDOQI. Or you can go to the handbook of hemodialysis and you can see how to do this one. So access recirculation, that means dialyzing the blood. So when the blood fluid concentration in the arterial line lower than the systemic circulation, indicating that there has been mixing of dialyzed blood with undialyzed blood. Yani you are dialyzing blood. There are two most common techniques for accurate measurement: urea and non-urea based method by the ultrasonic dilution method. The presence of recirculation, we make it significant if it is more than 10% for urea base and 5% if you are using the dilutional method. This is exactly what happened. So we have the blood coming from the machine, arterial here. Then it will go to the machine and it will be dialyzed, and then it will go to the venous. Let us see what will happen in case of stenosis. So in case of stenosis, the blood will go to the patient, from the patient will go to the machine. And then unfortunately, because of the stenosis, we are dialyzed blood, because the blood in the venous site is mixed. Here you can see the arrow. So the blood here in the venous site is mixed. So the concentration gradient is reduced, and this is what we mean by the urea recirculation or access recirculation. When to refer for intervention, if you are doing the static venous pressure monitoring, I will not talk about it, just I will tell you about the number if you put it as part of your guideline. In graft, pressure ratio more than 0.5, and artery ratio more than 0.75, and fistula more than 0.3, and the arterial more than 0.45. In central stenosis with good collateral circulation, especially in patient with AVF, all the pressure may be normal. So just to keep it in mind. And by this, I'm done with the 2 talks. I will try to answer a few questions before I introduce Dr. Al-Ami. When to refer Steele syndrome patient to the vascular surgeon? Any patient with Steele syndrome, please refer, because it can lead to catastrophe. So don't, ignore any minor, complaint of the patient in regard of Steele. There are stages of Steele. There is 1, 2, 3, 4. But I think if you have any Steele, please send your patient for further evaluation, because your patient should not suffer from pain, and later on, he may end, with catastrophe and amputation. Another question, IJ Burmicata frequent infection, what is exactly the time to remove? And in neuro insert, the maximum duration? Unfortunately, there is no guideline in regard for how long you keep the Burmicata. Ideally, the Burmicata, it should be kept for the period for the AV fistula to mature, that is between 2 to 3 months. But unfortunately, with the lack of the vascular surgeon and people who are in charge of the vascular access, so we have patients, who are having their access for years. I have seen somebody with Burmicata for almost, 5 years. Is it recommended to change it every 6 months if there is no infection, or 1 year? If it is working, nobody will touch it, because keep in mind that when you remove it, especially if it is a chronic, most of the time that, the IG at that site, it will be thrombosed. When it gets infected, you can remove it and you can reinsert within 48 hours if the blood culture is negative. Muhammad, can recirculation happen in Burmicata? There is recirculation in Burmicata, yes, and it is much higher than the AV fistula, and that's why we have to use it occur in the temporary catheters more than in the Burmicata, but unfortunately it can occur on the Burmicata, especially if there is if you are not using heparin and the flow in the Burmicata is not that good, so it can happen, and you can measure it also. And if you have recirculation, your Burmicata, by the way that we do, we put TBA. It's different from the AV fistula. So if you identify excess recirculation in the Burmicata, you will look the access with the TBA, while for the AV fistula, you will refer for fistulogram and for angioplasty. And I think I'm on time and have no more question, and I will go to last speaker, Dr. Al-Ami. Dr. Muhammad is here. Abu Turki?
Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته. If you are ready, I will introduce you.
يا الصوت واضح؟
الصوت واضح جدا.
Yeah, I'm ready.
Okay, بسم الله الرحمن الرحيم. So we will go to the last session. We skipped the last one. And it is my pleasure to introduce my brother, friend, and colleague, Dr. Muhammad Al-Ami, who is senior consultant nephrologist and who is in charge of King Salman Kidney Center and the renal service line and C2 cluster in Riyadh. Dr. Muhammad, he will talk to you about, I think, very important topic, and I think it's the most important topic here if you are working in dialysis unit, that is the hemodialysis emergencies. Dr. Muhammad, you can start.
Thank you, Dr. Fadel. We'll talk about hemodialysis emergencies. As you know, the hemodialysis is a life-sustaining treatment for patients with kidney failure and severe AKI, and usually became a routine treatment carried out in outpatient clinics and hospitals, nursing facilities, and patients' home currently. It is a complex procedure, as you know, and it is quite safe. There are serious complications, but it is uncommon due to the use of modern hemodialysis machines and water treatment systems, as well as the development of strict protocols to monitor various aspects of the hemodialysis treatment. Hemodialysis, as mentioned by our colleagues before in the lectures, involves the creation and maintenance of vascular access, generation of water suitable for making dialysate circulation of blood through the extracorporeal circuit, and administration of medications such as heparin, IV iron, EPO, and vitamin D. Complications can occur at any of these steps, which can range from mild to life-threatening. Before we talk about the complications, as you know, the acute complications that commonly occur during routine hemodialysis, we have hypotension up to 55% of the treatment, cramps up to 20%, nausea and vomiting up to 15%, headache 5%, and chest pain, back pain, and itching, and fever and chills less than 1%. In my talk, I will concentrate on hemodialysis emergencies that include the dialyzer reactions, dialysis or DDS, dialysis disequilibrium syndrome, uremic and dialysis-associated pericarditis, air embolism, VND, vascular access hemorrhage, hemolysis, dialysis water contamination, and arrhythmia episodes. Regarding the dialyzer reactions, this is what we can see. This is the dialyzer that composed of the hollow fibers, and we have the inlet and outlet for the blood. And the dialyzer is composed of many hollow fibers made from biocompatible membrane across, with solutes are cleared through the diffusion and convection. Dialyzer reactions are hypersensitivity reaction to the membrane itself or the product used to sterilize the membrane. Usually insufficient rinsing of the dialyzer after the use of ethylene oxide that was commonly used to sterilize dialysis membrane in the past, and formaldehyde that was used to reprocess the dialyzer led to patients being exposed to these substances. Dialyzer reactions were previously called first use reactions because they were typically seen when the dialyzer was used for the first time, and currently we are not using or reusing the dialyzer. Dugardez reported 21 severe allergic reaction to dialyzers in 260,000 dialysis sessions, for a frequency of approximately 1 episode in 12,000 hemodialysis sessions. And these allergic reactions, including 4 respiratory arrests and 1 death, and reactions have been reported to occur with dialyzers that composed with caprofen, that is cellulose membrane used more commonly in the past, and acrylonitrile. This is a synthetic membrane that cause acute reaction among patients that they are using ACE and ARBs, and polysulfone and polyether sulfones, which are the most commonly used synthetic membranes. And this is the number of the dialysis, the number of reactions that come with mainly with the caprofen. Dialyzer reactions are now rarely seen due to the increased use of biocompatible membranes and reduced use of ethylene oxide sterilization. And there are some measures based on the guidelines, some measures to minimize an allergic reaction to a dialyzer. We have to prime the dialyzer well, switch from ethylene oxide sterilization to gamma or steam sterilized dialyzer. In the event of hypersensitivity reaction, do not return the blood because this may aggravate the allergic reaction. صوت واضح؟ Treat with antihistamine and corticosteroid and epinephrine for hypersensitivity reaction. Also roll out other conditions that may simulate an allergic reaction like air embolism, hemolysis, and pyrogenic reactions. As we know, dialysis reaction, we have two types of hypersensitivity reaction or dialysis reaction, type A reaction and type B. Type A that occur early in the treatment, usually within 5 to 20 minutes, up to 30 minutes. And these reactions are mediated through IgE, and they typically occur during the first treatment, but occur after multiple treatments. Signs and symptoms include pruritus, urticaria, laryngeal edema, bronchospasm, dyspnea, and hypotension and cardiac arrest. For the future treatment, dialyzer with different methods of sterilization should be used, like switching from steam or ethylene oxide sterilized dialyzer to a gamma ray sterilized dialyzer. We have to avoid the usage of ACE inhibitor with acrylonitrile dialyzer, and most of type A reactions have been attributed to ethylene oxide, formaldehyde, and the use of ACE with the acrylonitrile dialyzers. The other type of reaction, type B, and usually occur later in the treatment and are less severe, and is complement mediated. Those patients they will present with chest and back pain, nausea and vomiting. Dialysis can be continued if symptoms are mild, although switching to different dialyzer should be considered in the future. Usually this type B reaction occur in the past with the caprofen and the polysulfone or polyether sulfone dialyzers, because they usually appear, those dialyzers appear to activate the complements. We have another emergencies that we have to know with the common used medications, like we have a hypersensitivity reaction to them, like heparin and IV iron and erythropoietin. Regarding the heparin, usually may result in HET. 5% of patients with HET develop allergic-like reactions characterized by nausea, cough, fever, and chills. Patients with HET develop an anaphylacticoid reaction immediately after heparin re-exposure that is mediated by IgG antibody, and this is mainly with HET type 2. As we can see here, the clinical pathological signs or symptoms of finding of HET, we will have thrombocytopenia up to 95%, thrombosis up to 75%, and lastly, anaphylacticoid reaction up to 5%. IV iron is administered to approximately 70% of patients on hemodialysis each month. The rate of fatal or adverse reaction varies by iron formulation, with the high rates of high molecular weight dextran and the lowest for iron saccharose, which is currently the most commonly used iron formulation. This is how to approach those patients with hypersensitivity reaction to iron. Most of the patients, they will have mild hypersensitivity reaction, like itching, flushing, urticaria. So this is the way of the management to stop the iron and monitor vital signs and restart the iron with the half dose. But if it is severe and or moderate and severe, we have to stop the IV iron to switch the patient to another IV iron. This is the summary of the dialyzer reactions and other or medication, common medication reactions, and how to manage those patients. Dialysis disequilibrium syndrome or DDS, characterized by neurological signs and symptoms occurring during or shortly after a hemodialysis session. And it was first described in 1960s. And DDS has been typically seen in patients with significantly elevated serum urea undergoing their first dialysis treatment. Other risk factors include rapid reduction of serum urea, extreme of age, metabolic acidosis, hyponatremia, hypernatremia, liver disease, and pre-existing neurological conditions. This is what we can see in, this is the brain cells and extracellular fluid. This is a normal with the equal osmolality even between the brain cells and extracellular fluid. If the patient uremic and starting on hemodialysis, it is also if the osmolality of the extracellular fluid increased, the brain cells osmolality will increase. But in DDS, the brain cells osmolality will be higher than extracellular fluid osmolality, so the fluid will go inside the brain cells and will cause cerebral edema, and may be seen on the CT and MRI. And the cerebral edema seen in DDS is caused by the movement of water, as we mentioned, into the brain cells. And the most prevalent theory that has been postulated to explain this occurrence is the reverse urea effect. And this theory states that rapid reduction of urea with hemodialysis lower serum osmolality significantly relative to CNS, generating an osmotic gradient that drives water into the brain cells. Rosen and his colleagues studied 10 patients with AKI with a baseline urea concentration of 210 to 460 milligram, undergoing their initial hemodialysis sessions. And they obtained concurrent plasma and CSF samples before dialysis, and immediately after dialysis, and 24 hours after dialysis. The CSF to plasma urea ratio was 0.9 pre-dialysis and 1.99 immediately after dialysis, and back to the baseline 24 hours later. As we know, the DDS characterized by nausea, vomiting, headache, encephalopathy, and seizure. And this is most of the studies, our clinical manifestations in many studies, that as we can see, nausea and muscle cramps and headache, it is common, and even hypotension and shock. So how we manage DDS usually depends on the severity of symptoms. And if symptoms concerning for DDS develop during dialysis, the treatment should be stopped. There will be, if there is mild symptoms, may be managed supportively. Severe symptoms measured to reduce the intracranial pressure can be used. Also, administration of hypertonic saline or mannitol and hyperventilation have been used in published cases, but the outcome have been poor. The key in the management of the DDS is the prevention. Prevention by reducing serum urea by no more than 40% over a short period of time, initiating hemodialysis using a low blood flow of 200 over 2 hours. And DDS has been reported in prevalent maintenance hemodialysis patient. So using a lower blood flow when such patient have significantly elevated serum urea recommended. In patient with a very high serum urea, slower reduction in serum urea using CRRT or bag systems should be considered with a very slow blood flow. Another approach to increase the osmolality in the blood or dialysate to reduce the degree of change in osmolality with dialysis like higher sodium dialysate and agents that have been used, including mannitol, glucose, glycerol, and urea. For the there is no set urea value above which patient predictably develop DDS, and both high urea level and rapid decline are risk factors for DDS. Additional risk factors including pre-existing neurological conditions and the first session of hemodialysis, hyponatremia and liver disease. It is unknown whether the risk of DDS is similar in patients with advanced CKD and those with AKI. This is the strategic, the potential strategic to prevent DDS in a high-risk patient, to limit the first hemodialysis session to 2.5 hours, limit the blood flow to 200 to 250, and sodium or high sodium dialysate, and consider IV mannitol and CRRT. This is a study done by Port. He reported that a higher dialysate sodium concentration prevented DDS in the first sessions. Each 1 millimole increase in serum sodium offset the osmotic effect of 12 milligram of serum urea. So sodium modeling may be useful in preventing DDS during the initial hemodialysis sessions, and adding glucose or glycerol to the dialysate may also prevent the DDS. If we can see here, this is the dialysis or the pre-dialysis EEG of one patient, and this is when the patient on dialysis and the sodium dialysate was increased, and it is almost the same. There is no changes, but here for the same patient pre-dialysis and with the standard dialysate, we can see the EEG. There is changes in the EEG. Uremic pericarditis. This is another dialysis or hemodialysis emergency. In 1836, English physician Richard Bright reported the presence of pericarditis in patients with kidney disease at autopsy. And more recently, pericarditis in CKD patients has been classified as uremic pericarditis or dialysis-associated pericarditis. Uremic pericarditis defined as developing before or within 8 weeks of initiation of dialysis, while dialysis-associated pericarditis defined as developing after 8 weeks on dialysis. So the exact cause of pericarditis is unknown. Uremic and dialysis-associated pericarditis remain the most common cause of pericardial disease in kidney failure. And there are other causes like infection, autoimmune disease, malignancy, trauma, and MI. Uremic pericarditis is thought to be due to the accumulation of uremic toxins, usually improves with dialysis initiation. Dialysis-associated pericarditis frequently occur in patients with inadequate dialysis and improves with intensified dialysis. Some experts suggest that viral illness or other stress may trigger the development of this disease. With earlier initiation of dialysis and more efficient dialysis machine, uremic pericarditis is much less common than in the past. Chronic pericardial inflammation from any cause can result in constricted pericarditis, which occur rarely in kidney failure. The clinical presentation of uremic and dialysis-associated pericarditis may differ from pericarditis due to other causes of pericarditis occurring in patients without kidney failure. There are what we have, pleuritic chest pain is common, but improvement by leaning forward is not commonly reported. Uremic and dialysis-associated pericarditis may be accompanied by fever, chills, dyspnea, cough, or malaise. Pericardial friction rub is heard in most patients. On ECG, diffuse ST segment elevation classically associated with pericarditis in non-dialysis patients are seen in less than 10% of dialysis patients. So echo is the most commonly used to evaluate for pericardial effusion and signs of tamponade. Patient may present with hypotension, tachycardia, muffled heart sounds, elevated JVP. Pulses paradoxus is suggestive of tamponade, as we know. Laboratory studies commonly showed elevated ESR, CRP, leukocytosis also may be seen in approximately 50% of cases. Pericardial fluid is exudative, and mononuclear cells are seen in the fluid. Cardiac tamponade has been reported to occur in approximately 10 to 20% of patients with uremic and dialysis-associated pericarditis. A diagnosis of tamponade requires urgent pericardiocentesis to avoid cardiogenic shock and cardiac arrest. Management of uremic pericarditis in patients not already receiving dialysis is initiation of dialysis. Intensification of dialysis is recommended for dialysis-associated pericarditis with daily hemodialysis for 10 to 14 days. In one study, 87% of uremic pericarditis patients improved with hemodialysis initiation, whereas only 53% with dialysis-associated pericarditis responded to hemodialysis intensification, or what we call daily hemodialysis. So in those patients with uremic pericarditis, we have to avoid heparin during dialysis due to the concern of hemorrhagic pericarditis. Fluid removal by ultrafiltration should be attempted very cautiously as it can precipitate cardiac tamponade. medications like indomethacin, colchicine, and oral and intrapericardial corticosteroids have been evaluated in small studies without evidence of benefit. Significant pericardial effusions that do not improve with intensified dialysis usually require pericardiocentesis with or without drain placement or pericardial window. If we perform that, or if that pericardiocentesis performed without a placement of drain, monitoring for the reaccumulation of the effusion is required. Management of constrictive pericarditis require complete pericardectomy. The other emergency air embolism, there are multiple potential causes of air entry into the patient bloodstream. Improper administration of normal saline or medication, as well as inadequate priming of dialyzer, may result in the introduction of air into the circuit. And if significant volume of air enters the circuit, may by these mechanisms, it is detected by the air foam detector. This is what we can see here, foam and bubbles. Air may enter the extracorporeal hemodialysis circuit either as a result of residual air trapped in the tubing or dialyzer due to the incomplete priming, or because of broken or loose layer connection pre-pump. Air entering the trap lowers the blood levels, which is detected by a sensor that triggers an alarm and stops the blood pump. Hemodialysis can be resumed after assessing the patient and the venous line, and then taking any necessary steps to remove blood from the circuit. Because of this safety mechanism, life-threatening air embolism is very rare. Cases reported in the recent year have been attributed to failure to clamp tubing or catheter or other human errors. The clinical manifestation of air embolism depends on the volume and rate of air entry and the end organs affected. Very small air bubbles termed microbubbles or microemboli do not trigger the air foam detector and enter the patient bloodstream. The entry of significant amount of air into the right heart and pulmonary artery can cause increased pulmonary artery pressure, pulmonary edema, hypoxia, hypotension, and cardiac arrest. Once in the systemic circulation, air emboli can occlude the blood vessels and cause ischemic injury. The cerebral arteries are most commonly involved, and patients may develop altered mental status, a neurological deficit, seizure, and death, stroke and death. So, management of possible air embolism, administration of supplemental oxygen to treat hypoxia and reduce the size of air emboli by increasing the rate of nitrogen removal. Fluid and vasopressors should also be administered where needed. Hemodialysis should be stopped without returning blood from the extracorporeal circuit to the patient. A patient with suspected or known venous air embolism should be placed in the left lateral recumbent position to prevent any air in the right ventricle from entering the pulmonary circulation. But for the arterial air embolism, the recommendation are to position the patient in the supine position, as left lateral recumbent position is insufficient to prevent arterial air emboli from entering the systemic circulation. Head down positioning may exacerbate cerebral edema in patients who sustain cerebral air embolism. So how to prevent the air embolism? Avoiding very high blood flow rates, maintaining high blood level in the air trap, training staff and patient and caregivers for home hemodialysis to avoid scenarios that increase the risk of air embolism, and preventing air embolism during placement and removal of central catheter, correction hypovolemia and other causes of reduced central venous pressure, placing the patient in the Trendelenburg position, priming the catheter, inserting the needle during expiration, keeping needle hubs and lumens occluded may help to prevent air embolism during catheter placement. Catheter removal during Van Zarva maneuver with, or with breath held after full inspiration, and placement of an occlusive dressing for 24 hours are recommended for catheter removal. Next emergency, VND, or venous needle dislodgement, is a rare but life-threatening complication of hemodialysis with a typical dialysis blood flow of 300 to 500. Those hemorrhagic shock ensures within minutes after loss of 30 to 40% of total blood volume until the pump is stopped, or severe hemorrhage and even death can occur within minutes. The causes of VND: improper needle tapping, suboptimal cannulation technique, failure to secure blood lines appropriately, patient movement and needle removal. Other factors such as covering needles, and this is common in most of the units, and or blood lines with the blankets or other items, and setting the lower limit of the venous pressure alarm too low can make it more difficult to detect venous needle dislodgement when it occurs. So the venous pressure monitor measures the pressure in the circuit between the venous air trap and the patient's venous axis. The venous pressure is positive, reflecting the resistance in the circuit and venous axis. If the venous needle becomes dislodged, the venous pressure will decrease, but the drop in the venous pressure may not be sufficient to trigger a low limit alarm. If the patient with AV fistula with an intra-axis pressure of 20 millimeter mercury has venous needle dislodgement, the venous pressure will decrease by 20. If the low alarm limit is set to less than 20 below the baseline venous pressure, there will be no alarm triggered. Therefore, it is possible for a patient to lose significant amount of blood before an alarm is triggered. And blood loss following venous or VND can range from minimal to life-threatening or fatal. So the management of significant blood loss, including, as we know, IV fluid, vasopressor, and support, and blood transfusion. But the prevention and early detection of VND is the key. So the recommendation for that, using consistent procedure for needle and bloodline tapping, keeping the axis and bloodline connections visible at all times, regular monitoring of the vascular axis during hemodialysis, prohibiting staff from adjusting alarm limits, educating staff and patient about VND, keeping such patient close to the nurse's station. Patients who are at high risk, including those patients with who are restless and have dementia or altered mental status, and those patients they have allergies to tape. The Veterinary Administration National Center for Patient Safety reported 40 major hemorrhage due to VND or disconnection at the dialysis catheter site during 2.5 million dialysis sessions, or approximately 1 episode per 60,000 hemodialysis sessions. In data from Pennsylvania reported 32 patients with VND during 2.26 million hemodialysis sessions for a frequency of about 1 in 70,000 hemodialysis sessions. So it is rare, but it is a serious complication. 2 large Canadian series of patients on home dialysis reported VND in 1 in 11,000 and 1 in 20,000 hemodialysis, as we can see here. And most of them, it is a human error. Next emergency, or the hemodialysis emergency, vascular access hemorrhage. And it is also rare but life-threatening complication of hemodialysis access. It was reported as the cause of death, about 0.4% of death among hemodialysis patients. Also, approximately 80% of death caused by vascular access hemorrhage occur outside the dialysis unit, Most of these events occur during the rupture of an AV fistula or AV graft. Smaller number results from the central venous catheter associated complications such as perforation, ANCAP port, disconnection from the extracorporeal circuit, and accidental removal. VND during hemodialysis accounts for a very small fraction of fatalities. This is a rupture of AV fistula and AV graft occur at sites where the vessel wall has weakened. As we can see, this is shiny, and this is pseudoaneurysm. Aneurysms and pseudoaneurysms are most commonly developed after repeated cannulations in the same location. Aneurysms are focal dilatation of the vessel wall. Pseudoaneurysms are hematoma that communicate with the AV fistula or AV graft through the defect in the vessel wall. AV grafts are more likely to develop pseudoaneurysm than AV fistulas due to a higher intra-axis pressure and limited capacity to repair defects at cannulation sites. Because of this, AV grafts are associated with a higher risk of vascular access hemorrhage. Risk factors for increase the formation of aneurysm and pseudoaneurysm include high blood flow, repeated dilatation of recurrent stenosis, and infection. In published series, more than half of the patients who experienced fatal vascular access hemorrhage had an infection, clotting, hemorrhage, or other vascular access complications in the weeks or months prior to their death. Vascular access hemorrhage should be managed by applying direct continuous pressure to the site until emergency medical personnel arrive. Use of tourniquet, blood pressure cuffs, or bandages on the affected extremity should be avoided. Ruptured AV fistula or AV graft require ligation, resulting in the loss of access. In order to prevent aneurysm or pseudoaneurysm formation, proper cannulation technique is important. Cannulation of any aneurysmal portion of the axis should be avoided. Every vascular access should be examined regularly and aneurysms for the aneurysms and the pseudoaneurysms. Not every aneurysm warrants concern. Physical examination of the aneurysm is the most important tool to determine the need of for the intervention. Any rapidly enlarged pseudoaneurysm evidence of outflow stenosis, thinning or ulceration of the skin over the pseudoaneurysm, pulsatile, or evidence of infection should prompt urgent intervention and referral to vascular surgery. This is NKF guidelines for when to refer the aneurysm and pseudoaneurysm. Aneurysm skin for the aneurysm skin over the AV fistula is compromised. Risk of fistula rupture. Available puncture sites are limited. Pseudoaneurysm greater than twice the diameter of the graft. Difficulty achieving hemostasis post-treatment. Spontaneous bleeding from the site. If the aneurysm is stable without evidence of imminent rupture, like ulceration, thinning, or shining of the skin or infection, the referral should be made for a fistulogram to evaluate for potential underlying outflow stenosis. Angioplasty, usually done to decrease the intra-axis pressure and usually will prevent aneurysm formation or slow its growth. Next, emergency, the hemolysis. As we know, red blood cells are subjected to shear stress when traveling through the extracorporeal circuit, as the blood flow in the center of the tubing is higher than that at the wall, and this causes low-grade hemolysis. The causes of hemolysis during hemodialysis could be dialysate related, like contamination with copper, zinc, nitrite, and chloramine. Hypoosmolar dialysate, hyperthermia, could be mechanical through the extracorporeal circuit related. blood pump malocclusion, single needle high flow dialysis, partial occlusion of hemodialysis catheter, kink tubing, faulty blood tubing. Also could be patient related. Those patients may have sickle cell anemia or hereditary spherocytosis or autoimmune hemolysis. صوت واضح ولا؟
واضح يا ابو تركي.
Mild hemolysis may be not be associated with any symptoms. Severe hemolysis may be present with nausea, vomiting, diarrhea, abdominal pain, back pain, chest pain, dyspnea, chills, and hypertension. The blood in the extracorporeal circuit may appear brighter and more translucent. When hemolysis is suspected, dialysis should be stopped immediately. The blood in the extracorporeal circuit should not be returned to the patient, as this may result in severe hyperkalemia due to the potassium release from hemolyzed cells. Patient should be referred to emergency department for urgent medical evaluation. Also, lab findings include decreased hemoglobin and haptoglobin, and increased LDH and bilirubin. Patient with severe intradialytic hemolysis complains of nausea, shortness of breath, abdominal and back pain, and chills, and initially develop acute hypertension. And this is the way on how to review the patient with the hemolysis. If we suspect the hemolysis during hemodialysis, we have to stop dialysis and to investigate or examine the patient and investigate him, and to do the regular management and approach to those patients, and to know what is the cause of the hemolysis. Dialysis water contamination, this is another emergency. Water treatment system consists of serious components that each remove contaminants by different mechanisms. When one or more components of the water treatment system fail, or there is significant contamination of the water supply, the product of water may be unsuitable for dialysis. And if water contamination goes undetected, patient may experience life-threatening complications. And this is the components of the water treatment system. And the parameters: temperature blending valve, multimedia depth filtration, activated carbon filter, and softener. This is for the components, and for the water treatment, reverse osmosis and deionization, and ultraviolet and endotoxin retentive filters. Fortunately, with the current protocols for monitoring and maintaining water system components, the complications related to water quality are rare, based on the international guidelines and the guidelines of the American our American guidelines. We'll go with the content or contents of the water treatment, like chloramine is frequently added to drinking water as a disinfectant to kill microbes, and it is removed by carbon tanks that contains activated granular carbon. Exposure has caused multiple outbreaks of hemolysis in hemodialysis centers and methemoglobinemia, which present as a dyspnea and cyanosis, suggested by chocolate brown colored venous blood and confirmed by direct measurement of methemoglobin. For mild cases, monitoring of methemoglobin level may be sufficient, and for severe cases, methylene blue is the first line therapy. For fluoride, it is also widely added to the water supply to prevent tooth decay. Signs and symptoms of fluoride toxicity include pruritus, chest pain, nausea, vomiting, diarrhea, syncope, tetania, and ventricular fibrillation leading to cardiac arrest. Fluoride usually binds to calcium and magnesium, causing hypocalcemia and hypomagnesemia. It is also causes hyperkalemia, oxidative stress, and cell cycle arrest and apoptosis. Aluminium toxicity has occurred due to exhausted deionization tanks, and acute aluminum exposure causes severe neurotoxicity, which can manifest as seizure, myoclonus, and encephalopathy. Treatment includes hemodialysis and chelation with defuroxamine. Copper intoxication manifesting as a myalgia, abdominal pain, diarrhea, acidosis, pancreatitis, and hemolysis, and methemoglobinemia. So water treatment systems and hemodialysis machine are susceptible to growth of gram-negative bacteria and non-TB mycobacteria. Gram-negative bacteria also produce endotoxins that can cause pyrogenic reactions, which are characterized by fever, chills, hypotension, headache, and muscle ache occurring during dialysis or within a few hours after dialysis. Disinfection of water treatment and hemodialysis equipment keeps bacterial mycobacterial counts very low. Endotoxins is removed by reverse osmosis by endotoxin filters. Outbreak of bacteremia or pyrogenic reactions have been occurred in the setting of dialyzer reuse, contaminated water and dialysate, contaminated dialysis machines, and central catheter use. Pyrogenic reactions are usually mild to moderate in severity, but bacteremia has led to severe systemic infection and death. Adherence to protocols for monitoring water treatment system, which include regular water cultures and measurement of endotoxins level, are the key to prevent complications. And as we know, we have to send the chemicals and bacteriology and the endotoxins for the water treatment system. Patients on center hemodialysis are exposed to close to 200-liter water during an average dialysis session. So that the acute loss of water in dialysis unit is an emergency, and it may be localized due to breakage in water pipes in the dialysis unit only, or represent a hospital-wide problem. Patient needing acute dialysis may be switched to alternative renal replacement therapy like CRRT, or transferred to different medical facility. This is the summary for the concomitant and what are the complications of those components, and how we can deal with it. The last thing of the emergency is arrhythmia. Cardiac arrest and arrhythmia are the most common cause of death in kidney failure, accounting for 29% of death among dialysis patients. Sudden cardiac death has been defined as unexpected sudden death within an hour of symptoms, or unexpected death without obvious non-cardiac cause in patients known to be well within the previous 24 hours. Sudden cardiac death is likely common in kidney failure due to high prevalence of coronary artery disease and structural heart disease, combined with frequent exposure to poor arrhythmic triggers. In the non-dialysis population, reduced left ventricular ejection fraction is common among patients who have a sudden cardiac death. In non-dialysis population, reduced left ventricular ejection fraction is common among patients who have sudden cardiac death, but among hemodialysis patients, reduced left ventricular ejection fraction is less common. Instead, left ventricular hypertrophy, which can be eccentric instead of concentric, is observed more frequently, reported to be present in more than 70% of hemodialysis patients with a sudden cardiac death in some case series. It is well known that hemodialysis patients have a higher risk of sudden cardiac death following the long interdialytic period. Hyperkalemia, which has been associated with sudden cardiac death, may be one of the reasons for this trend. Fluid and electrolytes shift that occur during hemodialysis may also play a role. Use of dialysate potassium of less than 2 has been associated with a higher rate of sudden cardiac death. Currently, we are not using the K0 or K1 bath. Dialysate calcium of less than 2.5, higher serum dialysate calcium gradient have also been associated with increased risk of cardiac arrest. Also, metabolic alkalosis has been associated with the QT prolongation, which could be risk factors for sudden cardiac death. In the general population, ventricular fibrillation is the most common cause of sudden cardiac death. Recent studies using implantable loop recorders have shown that bradyarrhythmia appear to be more common than ventricular arrhythmia in patients undergoing dialysis. Clinically significant arrhythmias were seen to occur most commonly during the first dialysis sessions of the week, and were also common in the last 12 hours of the long interdialytic period. Bradyarrhythmias were fairly common in the last 12 hours of the other interdialytic period as well. Usually, based on one study, the cardiac arrest occurs only 7 times per 100,000 hemodialysis sessions, and the symptoms that preceding cardiac arrest, most of those patients, they will have dyspnea 11%, feeling sick or bad 7%, nausea 6%, chest pain 5%, dizziness 4%, and lastly vomiting and abdominal pain. And this is the possible strategy for preventing arrhythmia and hemodialysis, manage the cardiomyopathy, how to manage systolic dysfunction, diastolic dysfunction. Systolic dysfunction, we have to use cardiolipin and dilated cardiomyopathy. Diastolic dysfunction, consider more frequent hemodialysis to reduce left ventricular mass, and consider the use of spironolactone and ACE and ARBs. Minimize arrhythmic triggers like potassium shift, to monitor pre-dialysis potassium frequently and change a dialysate bath accordingly. Calcium shift, avoid also low calcium bath, especially with the concurrent use of QT interval prolongation. Metabolic alkalosis, avoid high dialysate bicarbonate concentration. Also, rapid ultrafiltration, encourage patients to adhere to salt and fluid restriction, and extend dialysis time so that ultrafiltration does not exceed 10 ml per kg per hour. Also, hemodialysis induced myocardial ischemia, lower dialysate temperature to 0.5 to 2 below the patient temperature to reduce the interdialytic hypotension. Also, other medications that we have to avoid QT interval prolonging medications when possible. Also, there are some devices that those patients will get a benefit, like pacemakers and ICDs. And this is depend on the cardiologist evaluation. That's all. Thank you.
Thank you so much, Dr. Mohammed, for this nice presentation about dialysis complication. And I think we have time for a few questions.
Dr. Khalid Khan.
Yes.
Hypotensive on dialysis, which is a big problem for ultrafiltration hemodialysis. What is your approach for elevating blood pressure? Can we start tab midodrine regularly? Hypotensive. Okay. First of all, you have to re-evaluate your patient, and you have to readjust the dry weight before you, and you have to look for the other symptoms like cramps or chest pain or abdominal pain for those patients with hypotension. The other thing, you have to review your antihypertensive medication. That this patient, what I mean, if he used it before the dialysis session, and monitor his blood pressure at home on the day of dialysis. Usually we use midodrine. Currently, some of the hospitals, they don't have midodrine to increase the blood pressure. But those patients, we have to evaluate them and to do echocardiogram for them and to refer them for cardiologists to evaluate the cardiac issues regarding the hypotension. Okay.
Okay. I'm checking. Doctor, do you have any more questions to Dr. Muhammad? I think most of the questions were answered from the previous session. So just wait for 1 minute to see if there is. I'm not sure the question about recirculation. Can it happen from Bermacath? Or it's only
it was answered. It was answered, Dr. Farid.
Answer.
Okay. And I think most of the questions here are answered. So before we end, just a few points for our colleagues. For anyone who registered into the Zoom link and you have attended the Zoom today with us, you will receive CME. Of course, we will send you a certificate for attendance. If you write your name clearly, if you attend the Zoom with a different name, or it is not the clear name, we cannot add your CME hours. The target audience for today, because we received a question if there is for technician or for laboratory staff. No, the audience target audience is nephrologists, nurses, and pharmacists. But if you attend anyway, we will submit your number to Saudi Commission and they have the decision. How long does it take? It's not within our hand. We submit the list immediately. Before we conclude, I would like to ask you now, we will have a poll survey. If you can, please participate with us in this way. It's important for us to have your feedback before we conclude our course today. So now the poll, you will see it now on the screen. So it's only simple 3 questions. We need your kind participation. While our colleague are answering the poll survey, I would like to take the chance to thank our eminent speaker today for their participation and presentation. This is the annual dialysis course for the Ministry of Health. Inshallah, the next one will be chronic kidney disease that will take place on the 6th of May, and you will receive invitation to attend soon. I would like to take the chance to thank the Saudi Society of Internal Medicine for their organization. And it's my pleasure to thank our sponsors for today, Fresenius Medical Care Company and the SPMAC والدوائية for their sponsorship and participation. By this, I would like to conclude. We will keep the poll open so you can fill it more. The more that we have, it's better for our feedback for the future. And I wish you a nice day for all.